Bismillah ar-Rahman ar-Rahim. Welcome. Music down. Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome to the 5th Emirates Oncology Society conference, which will be happening for the first time over 3 days. We would like to welcome you all. I know it's early in the morning, and inshallah we'll have very exciting 3 days. So we'll be starting with a few sessions, and the official opening will be at 11 o'clock inshallah, with the collaboration with the Ministry of Health in UAE. With the first session, we would like to start with Dr. Fadi Haddad, who will be talking about latest aspects of the management of 5FU toxicity. Dr. Fadi Haddad is a leukemia fellow at the prestigious University of Texas, MD Anderson. He's an assistant professor at the Department of Leukemia at Division of Cancer Medicine, University of Texas, MD Anderson. He did his fellowship in Beirut, in Lebanon, and he also had a strong background in clinical research with over 40 PubMed index peer-reviewed publication. After this, we'll have Dr. Saeed Rifa'i talk about another topic, inshallah. So we'll start with this session, and Dr. Saeed Rifa'i will take over after that.
Good morning. I would like to thank Professor Humaid Al-Shamsi and all the organizers for this meeting for inviting me to speak today about the management of 5FU toxicity. I am Fadi Haddad, Assistant Professor at MD Anderson Cancer Center, and we'll be going over today the toxicity of this compound and how to manage the side effects. First, how are we using fluoropyrimidine in cancer therapy? 5FU is a key anti-cancer agent, as we all know, for different solid tumors, including colorectal cancer, gastric cancer, esophageal cancer, breast cancers, and others. 5FU is either administered intravenously as a bolus or a continuous infusion, or administered as oral formulation known as capecitabine. And usually, this drug is given as part of a combination regimen, Folfox, Folfiri, Folfirinox, and others. Now, how does 5FU affects both the DNA synthesis and the RNA transcription? The main mechanism, in fact, of the 5FU activation is the conversion to the FUMP product. And as we can see here on the right side of the slide, the DPD conversion of the 5FU to DHFU is the rate-limiting step of 5FU catabolism in normal and in tumor cells. And up to 80% of administered 5FU is broken down by DPD enzyme in the liver, and the dose of 5FU is based on this assumption. Now, if the DPD is deficient, for example due to genetic mutations that we can see in some of the patients, then more 5FU is shunted to the anabolic pathway, leading to accumulation and increased levels of the active metabolites, which could be potentially toxic and sometimes fatal. Now, what will be the expected side effects when using fluoropyrimidine in cancer therapy? Usually, 5FU and capecitabine are well tolerated in general. The common expected side effects occur several days after the end of administration, usually more than 96 hours after we finish the administration of the drug. Common expected side effects usually occur in the third or later round of chemotherapy, because usually we don't see that much of side effects during the first cycle of therapy. What are the common expected side effects? Usually we can see some nausea, vomiting, diarrhea, mucositis, neutropenia, thrombocytopenia, anemia, which are hematological toxicity of the drug. Most of those are either mild to moderate grade 1 and 2. And these common toxicity can be managed usually with dose reduction and supportive care in the outpatient setting. Now, sometimes we might face what we call unexpected early onset severe toxicity. In particular, gastrointestinal, hematologic, or dermal toxicities that occur or worsen to grade 3 and 4 in severity during or within the first 96 hours of 5FU or capecitabine administration. And this, conversely to what we've seen earlier, it occurs mostly during either the first or the second cycle of therapy. These unusual and severe toxicities include cardiac or nervous system toxicity, such as myocardial ischemia, arrhythmia, chest pain, altered mental status, encephalopathy, and others. And for patients with early onset severe toxicity, traditional supportive care measures, similar to what we used in the other types of toxicities, may not be sufficient in these cases. So here on the right side, we can see what we call the 5FU overdose nomogram. And what does it tell us? In fact, this nomogram showed survival as a function of the overdose severity based on 5FU infusion rate and the total dose of 5FU that is administered to the patient. The patients that are in the expected lethal zone, which is the upper right in yellow, expected lethal zone, those patients would be expected to die based on the infusion rate and the dose of 5FU that they are given. Patients in the expected tolerated and expected serious toxicity zone, which are, as we can see, more in green or in grayish, would be expected to survive. Now, what is the frequency of this toxicity? So the FDA had published a report of 203 cases of early onset or life-threatening toxicities after either 5FU, which is 58 patients, or capecitabine, 145 patients. And all those patients were treated only with supportive care in the event that this toxicity happened, and all those patients succumbed, unfortunately, to this toxicity. Now, while accidental 5FU and capecitabine overdoses occur rarely, the occurrence of severe and life-threatening complications is more common. In pivotal capecitabine monotherapy trials in colorectal cancer, we have seen the toxicity in 30% to 40% of the patients, 60 to 70% in trials of capecitabine and docetaxel in breast cancer, 10 to 28% of patients had treatment-related hospitalization in phase 3 clinical trials of these drugs, and less than 1% of the patients experienced fatal treatment-related toxicity. Early onset severe toxicity with 5FU or with capecitabine is increasingly being recognized in the literature and is now estimated to occur in 13 to 19% of patients. Now we're going to talk about uridine triacetate, which is a drug that we could use to fight these toxicities. So usually the uridine triacetate is indicated for the emergency treatment of adult and pediatric patients following a 5FU or capecitabine overdose, regardless of the presence of symptoms, or in patients who exhibit early onset or severe and life-threatening toxicity that is affecting either the heart or the central nervous system, or even early onset and unusually severe adverse reactions such as GI toxicity, neutropenia, for example, within the first 96 hours following the end of 5FU or capecitabine administration. Uridine triacetate is not recommended for the non-emergent treatment of adverse events. So usually this medicine is reserved for the cases that are very severe, that are life-threatening, whereas non-severe or non-emergent adverse events are usually managed with supportive care, antibiotics, growth factors, etc. The safety and the efficacy of uridine triacetate that is initiated more than 96 hours following the end of the treatment administration have not been established, and therefore we recommend that let's classify it as an antidote, or this drug used to fight the toxicity of 5FU or capecitabine should be given within the first 96 hours following the end of therapy. It's important to note that uridine triacetate does not have marketing authorization approval in any country other than the United States. And this could impact how much we can have access and use this drug in clinical practice. Now, what is the mechanism of action of uridine triacetate? So if we look at the figure on the right side, we can see that uridine triacetate is an acetylated prodrug of uridine. So following the oral administration of the drug, uridine triacetate is deacylated by non-specific esterases, which yield uridine, which competitively inhibits cell damage and cell death caused by fluorouracil. Fluorouracil is a cytotoxic antimetabolite that interferes with nucleic acid metabolism, as we all know, either in normal cells or in cancer cells. Cells anabolize fluorouracil to different, I would say, compounds which are FDUMP or FUTP. FDUMP inhibits thymidylate synthase, blocking thymidine synthesis. The second source of fluorouracil cytotoxicity is the incorporation of its metabolite, FUTP, into RNA. Now, what is the efficacy of uridine triacetate? In fact, in this analysis of 135 patients who were treated in 2 open-label trials, and those patients either received an overdose of 5-FU or capecitabine or presented with severe and life-threatening early onset toxicity within 96 hours following the end of 5-FU or capecitabine administration. 117 patients were treated following an overdose, and 18 patients were treated after exhibiting early onset toxicity. And as we can see in the table, most of the patients survived after treatment with uridine triacetate. Of those 135 patients, only 5 patients died because of toxicity, and 2 of those 5 patients had a treatment with uridine triacetate beyond 96 hours. And as we discussed before, in those situations, treatment should be initiated very early on, before 96 hours of the end of capecitabine or 5-FU administration. So here, this figure shows nearly that all patients that were exposed to a lethal dose of 5-FU. So if we look at the top right, which is the yellow square, those patients received a lethal 5-FU dose, and those patients were treated with uridine triacetate. And as we can see, all those black triangles are patients that were expected to die, but they all survived after receiving uridine triacetate. Now, what about capecitabine overdose and the use of uridine triacetate? Capecitabine toxicities has been observed during therapy in patients who have a DPD deficiency and in accidental or intentional overdoses. However, the incidence is not well described. A 20-year retrospective review of capecitabine exposures that was reported between April 2001 and December 2021 showed that 49 patients had an acute on chronic exposures, all accidental with a median ingestion of about 2 grams. 32 patients reported acute ingestions, 29 were accidental and 3 were intentional. 6 patients were given uridine triacetate due to symptomatic toxicity or intentional acute overdose, and no new or progressive toxicity was observed among treated patients. And there was no death reported in this study. Now, what about the dosing of uridine triacetate? Now, among adults, the dose is usually 10 grams that is given orally every 6 hours for up to 20 doses. In pediatric patients, the dose is 6.2 grams per meter square of body surface area, however not to exceed 10 grams flat dose per dose, and it is also given orally every 6 hours for up to 20 doses. And on the right side, I kept more details about the dosage and administration. Now, what about the side effects of, in fact, uridine triacetate? There are no contraindications or warnings or precautions listed for uridine triacetate. Safety was assessed in 135 patients, and the following adverse reactions that are listed below occurred in more than 2% of the patients receiving uridine triacetate. We observed vomiting in 10% of the patients, nausea in 5% of the patients, and diarrhea in 3% of the patients. Now, how should we counsel our patients? So we should always advise the patient or caregiver on the importance of taking all 20 doses of uridine triacetate, that uridine triacetate can be taken mixed in food, applesauce, pudding, yogurt. Uridine triacetate granules should not be chewed. We should instruct the patient or the caregiver that if the patient vomits within 2 hours of taking a dose of uridine triacetate, to take another complete dose as soon as possible after vomiting. and that if the patient misses a dose at the scheduled dose, to take the next dose of uridine triacetate as soon as possible.
Thank you, Dr. Fadi, for this excellent talk. I think still we have 3 minutes if there is any question for Dr. Fadi. Okay, so without further ado, we can move to the next speaker, Dr. Saeed Ravi. He is consultant medical oncologist, well known with extensive experience in in different specialty in the oncology. His training was based in UK. He is working as a consultant in Mediclinic Hospital, and he is the secretary of Emirates Oncology Society. So his talk will be about transforming outcomes for patients with PIK3CA mutated advanced breast cancer in EVO 120 phase 3 clinical trial. Please, the stage for you, Dr. Saeed.
Good morning, everybody, and very welcome to this 5th annual conference for Emirates Oncology Society. This talk is sponsored by Roche. I'm very pleased to actually say that I was involved in design of this clinical trial as well. Basically, we know that in hormone receptor positive HER2 negative disease, we have transformed the overall survival of these patients by addition of CDK4/6 inhibitor to endocrine therapy. Now, as a result, the combination of endocrine therapy and CDK4/6 inhibitor is the first choice in patients with metastatic hormone receptor positive HER2 negative disease. As you can see in this graph, this is the overall survival, Monarch 3 study and Monarch 2, which basically add abemaciclib and ribociclib to endocrine therapy, and both they have shown significant benefit. The issue is that, as you can see, the first part of this Kaplan-Meier curves, unfortunately, there are a significant number of patients who do not benefit from addition of CDK4/6 inhibitors to the endocrine therapy. And I think we need to know who are these patients and how can we improve their survival. This also shows the progression of the disease in this group of patients. So you see that a significant number of these patients, they do progress while they are taking endocrine therapy and CDK4/6 inhibitor, around 20 to 30% in the first 12 months as we progress, even up to 60% of patients during the first 24 months of treatment, they progress on these medicines. And patients who are actually become endocrine resistant and they progress during the treatment with CDK4/6 inhibitor and endocrine therapy, they do worse, as you can see on this graph. So the orange line is the endocrine sensitive on this Kaplan-Meier curve. On the top, you see that they do better compared with the patient that they have endocrine resistant disease. The issue is that we do not really actually have a very good and solid consensus of what is the primary endocrine resistant, what is the secondary. Nonetheless, as you can see, is that ESMO guidelines have come up with the consensus that if a patient relapse while they are taking the endocrine therapy during the first time of the treatment, or progression of the disease within the first 6 months of the first-line endocrine therapy for advanced disease, we can define them as endocrine resistant disease. Again, this consensus has been also solidified in the 6th and 7th international consensus guideline for advanced breast cancer. But who are these patients? Who are these endocrine resistant patient, basically? We do not actually know a lot about them. What we can see is that at least a group of these patients, they do have mutation in PI3 kinase pathway in hormone receptor positive. Up to around 35 to 40% of these patients, they have a PI3 kinase mutation. So the question is that, if you have a PI3 kinase mutation, do you do better or worse? And this Kaplan-Meier curve, you can see very clearly that if you do have PI3 kinase mutation, you actually do worse, around 8.4 months shorter overall survival in this group of patients. So this makes PI3 kinase actually a very attractive target for the treatment, and as you can see, we have now 3 medicines approved in these. We started actually with everolimus quite a few years ago, which is basically targeting the downstream pathway in the mTOR. We have had alpelisib, which is a PI3 kinase inhibitor, and recently cabergotinib, which is a AKT inhibitor. And quite a lot of other medicines, they are currently in the process of clinical trials. The problem is with this pathway is a very challenging pathway to target because of the toxicity of these medicines. Some of these previous medicines, they were pan-PI3 kinase inhibitors, and they basically targeted the alpha, beta, gamma, subunits of the PI3 kinase, and thereby starting to cause a lot of significant side effects. As we have come away, we have developed more and more alpha-specific subunit inhibitors, such as inavolisib, which is currently in clinical trials. We have seen some of the data. We will review the data, but there are few of these agents also in development as well. The problem is that, like I said, the toxicity is because of the inhibition of mainly gamma subunit and some of other non-specific subunits of the PI3 kinase, causing a lot of GI toxicity, rash, hyperglycemia, and stuff. So if you look at alpelisib, which was the first PI3 kinase inhibitor which was developed by Novartis, we can see that there is definitely an improvement in progression-free survival from 5.7 months to 11 months. So it's almost twice as much. The issue is that it does come with a lot of side effects as well, such as hyperglycemia, diarrhea, stomatitis. Up to 2/3 of these patients, they have some significant side effect with alpelisib. So can we do better? Obviously, inavolisib was basically designed to be able to specifically target the alpha subunit of the PI3 kinase, which is PIK3CA, basically. And there have been clinical trials, early phase clinical trials and preclinical data showing that this is combinable with CDK4/6 inhibitor. As you can see in this graph, addition of inavolisib to CDK4/6 inhibitor, it reduces the chance of the growth of the cells and the recurrence of the disease. So based on that, I was very lucky to be involved in designing of this clinical trial. Basically, that's the combination of inavolisib or placebo with palbociclib and fulvestrant in patients who have PI3 kinase mutation, PIK3CA mutated, hormone receptor positive, HER2 negative disease. And this is the design of trial basically. So patients who have PIK3CA mutated, hormone receptor positive, HER2 negative advanced breast cancer, this could be either determined on the ctDNA or in the tissue, as we will see later on. They had to have measurable disease. They had to have progression of the disease during or after 12 months of adjuvant endocrine therapy, no prior therapy in the advanced setting, and fasting blood glucose of less than 125 milligram per deciliter or HbA1c of less than 6%. So these patients, they were randomized into 2 arms, the standard of care arm or the control arm basically. It is the palbociclib plus fulvestrant and placebo, the experimental arm, triplet therapy, inavolisib, palbociclib, and fulvestrant. The treatment continues until disease progression. The endpoints, primary endpoint, PFS by the investigator, secondary endpoint, overall survival, objective response rate, and a bunch of other secondary endpoints, including the quality of life, basically. The stratification factors, they were whether patient they had visceral disease, yes or no, endocrine resistant, whether they are primary or secondary endocrine resistant, and different regions of the world. So these are the patient characteristics of notes. Around 40% of these patients, they are premenopausal. 56% of these patients, they are postmenopausal. At least around 50% of these patients, they have 3 sites of metastatic disease. So these are advanced disease patients. Around half of them, they have liver disease. half of them, they have lung metastases. 32% of these patients, they have primary endocrine resistant disease, and 67% they have secondary endocrine resistant disease. So these are not low risk patients. They are fairly high risk patients as well. Looking at the prior therapies, 82% of these patients, they received either neoadjuvant or adjuvant therapy. As you know, patients who are high risk, they are the ones that we usually give either neoadjuvant chemotherapy or adjuvant treatment. Again, this is another measure that these are high-risk group of patients. Almost nobody had prior CDK4/6 inhibitor, only 1.9% on the experimental group. So this is the primary endpoint of the study, which was the progression-free survival assessed by the investigator. And as you can see that the median progression-free survival has improved from 7.3 months in the standard arm to 15 months on the triplet therapy, doubling the progression-free survival for this group of patients. At 6 months, 82% of the patients, they are free of the recurrence of the disease. At 12 months, 56% of the patients, and at 18 months, 46% of these patients, they are free of progression of the disease, compared with the red line that unfortunately at 18 months only 21% of these patients they are free of progression of the disease, meaning that around nearly 80% of these patients at 18 months they do progress on the treatment. The interesting stuff is just in that green arrow that you can see this separation of the curve so very early at the beginning. So this is basically the first imaging that we do. We see the difference between the two. So that tells you that inhibition of PI3 kinase, it basically starts to impact from the early onset. Remember that when we are looking at Monarch E, Monarch 3 and Mona Lisa 2, we had a long way that the Kaplan-Meier curve, they were running very close to each other and then it started to separate after a couple of years. So this is the difference here that you can see. In terms of the subgroup analysis, you can see that almost all of the subgroup analysis, they do benefit the same way, whether they are low ECOG performance status or performance status 1, premenopausal, postmenopausal, liver disease, primary endocrine resistant, secondary endocrine resistant, and so on and so forth. The overall survival is not mature yet. As you can see, we have had only 42 events by the time of the reporting of this data at San Antonio last year. So we have to wait a little bit longer to see more mature data. Nonetheless, you can see that in the median overall survival in the placebo group is 31 months, but it is not yet reached in the experimental triplet group. And again, you see this separation of this curve very, very early on in the OS by addition of inavolisib to CDK4/6 inhibitor and endocrine therapy, which is very important. In terms of the objective response rate, the objective response is more than doubled by addition of inavolisib to the palbociclib and fulvestrant. The clinical benefit rate is also significantly improved as well. The secondary endpoint, duration of response, again, it is assessed by the investigator. It is also prolonged by addition of inavolisib to CDK4/6 inhibitor and endocrine therapy from 9.6 months to 18.4, doubling the time. The important one is that, look, when you progress on this disease, then you start another treatment and then you progress on the second one, we really want to increase that progression of the disease. We call it a PFS2. We do not have that data yet because, obviously we need a longer follow-up, but we can actually use another surrogate, which is time from randomization to the end or discontinuation of the next line of therapy. And again, you see that by addition of inavolisib to CDK4/6 inhibitor endocrine therapy, we have improved this from 15 months to 24 months as well. The time from randomization to first subsequent chemotherapy. So you want to actually, in this group of patients, to delay the chemotherapy as long as possible. And again, you see that it has not reached in the inavolisib group versus 15 months, which is basically the time between this discontinuation until you start the chemotherapy, if you are only using the doublet, which is CDK4/6 inhibitor and endocrine therapy. So post-progression therapies, they are always very, very important for us because, you know, we want to make sure that these patients, they are actually receiving a proper treatment after they progress so that we can assess the impact of these post-progression therapies on the overall survival of the treatment. So it's very, very important. If you look on the placebo groups where they did not receive inavolisib, around 30% of these patients, they did actually receive some sort of PI3 kinase inhibitor. Only we have 1 or 2 PI3 kinase inhibitor available at the time of this study enrollment. Capivasertib was not available, so obviously nobody could receive this one. But you know, a lot of people probably they receive everolimus and alpelisib at that time as well. How about the safety? So obviously, addition of inavolisib, we are expecting to see more side effects in this group of patients, mainly those side effects that we discussed before, including hypoglycemia, diarrhea, and rash. And as you can see, there is definitely more toxicities related to addition of inavolisib in that group. Nonetheless, the severe toxicities, which we call them grade 3 and grade 4, they are fairly limited, between 0.6% to 5.6%. We obviously know a greater number of patients, they have low-grade toxicities with that. These toxicities, they do resolve pretty quickly, and you see that a lot of patients, they actually have the resolution of this side effect as we go along with the treatment. And I think, you know, these graphs, they show you that majority of these side effects, they do happen early. Yes, there are odd number of patients that they have side effects coming after around 3 years of being on treatment, but majority of these side effects, they do happen early, and they start to subside as we go along with the treatment as well. So how about the discontinuation rate? So if these side effects, obviously they are high grade, you do expect that the investigators started to stop the treatment. You see that the dose reduction and dose discontinuation has actually been fairly low, around only 2.5% in the experimental group for the hyperglycemia, diarrhea only 1.2%, and rash 0.6% of patients, they had to have a dose reduction. Even a smaller number of patients, they had to stop inavolisib because of the side effects. So the discontinuation rate and the dose reduction rate with inavolisib is fairly low as well. This graph basically shows you the concomitant medication, which is basically for supportive care, for diarrhea, hyperglycemia, and stomatitis. Quality of life. So if you look at this graph, basically they depict the clinical meaningful deterioration in worst pain severity in this group of patients. And as you see that is for the control group is only 18.1 months, whereas it is improving to 30 months for triplet therapy. So these patients, they have much longer period of time until they reach a point that they actually have a worsening or deterioration of their pain as well. So symptomatic toxicities between different arms, whether it is the stomatitis, sore mouth, or decreased appetite, vomiting and nausea, not much difference really between the two arms. And they actually did something interesting. They asked the patients, you know, in the last 7 days, how bothered were you by the side effects of your treatment? And like you see in this graph, there is not much difference, to be honest, between the placebo and inavolisib. There are slight differences in terms of, you know, the botherness that the patient felt as well. This is really a very good indicator that, you know, the impact of the treatment on the quality of life of the patients. And over the time, you can look at the quality of life measured by ERTC, QLQ, C30 score, which is a standardized score in terms of measuring health-related quality of life. And you can see there is no significant difference between the two treatments. So addition of enavasilib to CDK4/6 inhibitor and endocrine therapy did not actually significantly worsen the quality of the life of the patient. So I'm just going to wrap it up very quickly here. This is the first report that addition of enavasilib to palbociclib and fulvestrant demonstrated a significantly improvement and a statistically significant clinically improvement in the progression-free survival of this patient in the group of patients who have a PIK3CA mutation, hormone receptor positive HER2 negative disease. Median progression-free survival improved from 7.3 months to 15 months, hazard ratio 0.43, and that is basically translating to reduction of the risk of progression of the disease by 57% in this group of patients. The overall survival is not mature, but there is a trend with a hazard ratio of 0.64, so we are eagerly waiting for the updated overall survival, and it has a manageable toxicity profile. Also, enavasilib, it delayed the need for subsequent therapy by a delta of 8.9, and also longer median time to deterioration in terms of the pain severity by delta of 12.8 in that group of patients. So it's a very, very promising new medicine for this group of patients, and we are eagerly waiting to have an updated report of this, and hopefully we'll update it with the overall survival soon. Thank you. Yes, improving survival outcome in hormone receptor positive HER2 negative advanced breast cancer. I don't know if Dr. Dalia is, oh yes, yeah, we have Dr. Dalia.
Assalamu alaikum, everyone, and good morning. And thank you for being here today with us, and congratulations for Dr. Humaid for this meeting, and thank you so much for Novartis for inviting me for today's meeting. So my talk is not new. I'm going to speak about the improving survival and health-related quality of life outcomes in the first-line treatment for patients with hormone receptor positive, HER2 negative metastatic breast cancer. So I will take you through this topics, introduction, quick introduction, and a few slides. The Mona Lisa versus Palbo, Mona Lisa versus Monarch, the quality of life endpoints, and the most updated guidelines. So I think we all agree about the CDK4/6 inhibitor. It's clearly changed the treatment landscape of patients with metastatic breast cancer, the hormone receptor metastatic breast cancer, not only in metastatic setting, but also in the coming years in the early setting as well. So when we decide to treat this patient with hormone receptor breast cancer HER2 negative metastatic setting, we have to keep in consideration different factors. Not only the long-term and the short-term efficacy endpoints in the form of PFS and OS, but also we have to take in consideration the safety profile of the treatment, The health-related quality of life is very important. As we know, the median overall survival for patients with hormone receptor positive, HER2 negative metastatic breast cancer, they reached more than 5 years. So they lived very long time. And thanks for the new medication and the new strategy of treatment. However, to keep this patient on this type of treatment, long-term benefit, we have to consider the quality of life of our patients. Not only that, but we have to be carefully balance also the patient or individual features. And when I talk about the features, I mean the comorbidity, the drug patient is receiving, and the patient preference. So the shared decision making is a very important feature, should be considered and taken into account before the decision as well. So the randomized clinical trials, as we all know, it is there to set the clinical guidelines, to give us the efficacy, whether short or long-term efficacy endpoints. So it takes into consideration, of course, 100%, very important endpoints, so the long-term outcome in the form of overall survival. And progression-free survival is one of the most important. So we need our patient to live long, yes, but also to live in a good quality of life, plus the quality of life endpoints. And this, when the trial met these endpoints, long and short, and the quality of life, so it led to the change of the practice or the change of the current practice and the approval of the trial or the medication into the treatment landscape. So overall survival is the gold standard endpoints for the efficacy measures in oncology trials overall, and that's why the FDA consider it the most reliable cancer endpoints and the preferred endpoints as per the FDA. And it means that it's important, but also we need to take into consideration the progression-free survival. It's acceptable surrogate endpoints as well for our patient, but not usually translate to overall survival benefit. Could be related to post-progression treatment effect, maybe. So overall survival overall is very important too in our clinical trials. So a very important question we used in the oncology field, especially after the CDK4 inhibitor introduction, we have 3 medications. We have to ask ourselves in the clinical trials whether all the patients across the first line setting, they have the same criteria. This clinical trial involved the same clinical feature or baseline patient characteristics. I think there is something wrong in the slides, but overall, for this slide, actually, the ASCO Clinical Oncology Cancer Research Committee decided to consider the efficacy of overall survival to be more than 20% in the hazard ratio in terms of overall survival. So the increment, if it is more than 20% from the standard therapy, they consider the trial as positive for overall survival. And when we look to the Mona Lisa trials, including the ribociclib, whether in the pre or post-menopausal first or second line treatment, I think you can appreciate the difference and the significant improvement for our patients. So, for example, in the Mona Lisa 2 trial, 24% increase in the HR and the hazard ratio. When it comes to the pre-menopausal in the Mona Lisa 7 trial, 29% increment in the hazard ratio, and in the Mona Lisa 3 trials, 27.6%. When it comes to the Monarch trial, I think the efficacy it was 24.6%, but according to the criteria of the trial researcher, it didn't meet the statistical significant difference at this point. Why numerically it was better in comparison to the comparator. In the palbociclib trial, the increment was 4.4, as you can see here, and it didn't match the overall survival endpoints. Okay, so a lot of discussion about the patient inclusion criteria, patient characteristics, and I want just to highlight here a few points. If you can see here with me, the patient with treatment-free interval in the 3 trials, the Mona Lisa 2, the Paloma 2, and the Monarch 3 trials, the treatment-free interval of less than 12 months, which this group of patients, we usually consider them as endocrine resistant subgroup. So it's almost similar, 18% in the Mona Lisa 2 trial and around 22% in the Paloma 2 trial. What about the de novo metastatic breast cancer? Almost similar, around 30-34% between the two trials as well. So visceral metastasis, almost similar, around 50-55% in the CDK4/6 inhibitor. What is important to me here in this slide, actually, I'm not looking to the experimental arm, but I want you to look to the control arm. So the median overall survival was similar across all the three trials, 51 months. So it means that the patient criteria, I don't think it affects the outcome in this setting. So because we don't have head-to-head comparison in the CDK4/6 inhibitor trial in general, so in a way to compare the data or the results, it's for us to know which of which and which patient fit which medicine. So they did this analysis using this way of statistical analysis called matched adjusted indirect comparison. And this is to look for the efficacy or the comparison between the two trials. They use it for progression-free survival and overall survival between the Mona Lisa and the Paloma trial, as well as the quality of life endpoint between the Mona Lisa and the Monarch trial. So simply speaking, they collected the patient criteria and the parameter of the comparison, and they're driven usually by the published summary data. And they match the patient between the trial, and when the criteria of the two trial matched, they start to analyze the data accordingly. So for the matched adjusted indirect comparison for BFS and OS, in comparing the Mona Lisa trial using the ribociclib and Femara versus the palbociclib and Femara in the first-line treatment, they analyzed data according to the BFS and OS in these two trials as published and presented by Professor Kamal, I think in ASCO 2022. So the individual patient data from the last Mona Lisa 2 were matched to the last available aggregate for BFS and OS, as you can see here. And then from the Paloma 2 trial, excluding the patient in the Mona Lisa who wouldn't qualify for the Paloma 2 trial. And then after matching and weighting, the effective sample size for the Mona Lisa 2 trial was around 150 received ribociclib, and for the control arm was around 112 patient for the placebo arm. And here is the result. So using this type of analysis, the matched adjusted indirect comparison, it didn't show a significant difference in terms of BFS between the two treatments, the ribociclib and the palbociclib, as you can see here, and it was expected the BFS was around 0.8. But when it comes to the overall survival, I think you can appreciate there was a statistical significant difference between the two treatments by about 32% reduction in the risk of death by using ribociclib and letrozole in the first-line treatment for patients with hormone receptor positive and HER2 negative disease. So this is the Monarch 3 overall survival. Unfortunately, it didn't match the primary, the overall survival significant, but numerically it was better. The median overall survival was 67 months versus 54 months for the control arm, but the p-value was 0.75 and it didn't match the significant level. So we have here are the randomized control phase 3 trial of the CDK4/6 inhibitor in the first line treatment with significant improvement of the overall survival. We saw it in the Mona Lisa 7 in the premenopausal setting, as well as in the Mona Lisa 2 in the intention to treat population. The overall survival hazard ratio was 0.7, and in the Mona Lisa 7, the hazard ratio was 0.7 as well. In the Mona Lisa 3 trial, the longest overall survival reported in the advanced breast cancer setting with a hazard ratio of 0.64. However, the Paloma 2 trial, as I mentioned, it was, in terms of overall survival, it was not significant, but and the Monarch 3 trial using the abemaciclib and aromatase inhibitor in this setting showed numerical but not statistically significant as per the final analysis published in the San Antonio 2023 meeting. What about the visceral metastasis? There also was a concern regarding the patient with visceral metastasis, whether the benefit the same from all the CDK4/6 inhibitor, and would we treat this patient differently if they had visceral metastasis or not? And here is this table showing the current phase 3 randomized trial using the CDK4/6 inhibitor in this group of patients. I think you can appreciate that the patient receiving the ribociclib in the first or in the second line significantly with liver or lung visceral metastasis in general, significantly have overall survival benefit in the first line as well as in the second line, as well as in the Monarch 2 trial. As you can see here, the visceral metastasis patient also benefited from getting the abemaciclib. However, the statistical didn't show a significant difference by the final analysis. Here is the overall survival data. They did an exploratory analysis for all the Mona Lisa phase 3 trials in the first and second line in the premenopausal and postmenopausal patients. So 1,229 patients received the first line treatment in the Mona Lisa trial. Out of them, around 57.7% had visceral metastasis. And here is the data, the Kaplan-Meier curve for the overall survival. 22% risk reduction in the deaths by using ribociclib with letrozole versus the placebo with the hazard ratio of 0.78. Coming to the liver metastasis, specifically the liver metastasis, 1,889 patients included in the Mona Lisa trial. 26% of them had liver metastasis, significant reduction of the risk by about 29%, and hazard ratio of 0.71. Overall survival in the Monarch 3 trial by visceral metastasis, I think, as I mentioned, at this interim analysis, the statistical significance was not met, was not reached, but numerically it was better. Median overall survival 65 months versus 48 months in the control arm. The hazard ratio was 0.70 and the p-value was 0.03, and the p-value to be significant should be less than 0.0032. Elderly patients, so this is actually the treatment of elderly patients. This abstract was presented, I guess, in the San Antonio using the ribociclib and the endocrine treatment or endocrine monotherapy in the clinical outline as a real-world evidence from the RIPANA study. As you can see here, also the older patients, so I mean here by the older patient, the people with more than 65 of age, they also didn't show a detrimental impact in their quality of life endpoints, as you can see from the right side of the slides. And they also benefited from adding the ribociclib to the aromatase inhibitor and with good tolerance. So this is the summary of this abstract, the treatments of the elderly patient with the first-line ribo and endocrine treatment or versus the endocrine treatment in the clinical routine. This is the RIPANA study, the fifth interim analysis of this study as published. It's showing that the majority of these patients didn't require any dose reduction because of their age, and the data suggests that this elderly population don't have any increased risk of dose reduction and consistent with the other Mona Lisa data finding in other population. So the ribo plus endocrine treatment, the BFS rate was higher in the elder subgroup of more than 75 of age, and the treatment with riboendocrine treatment led to a maintenance or improvement in the patient quality of life across all subgroup and elderly patients. Treatment adherence was very important, and it was independent of patient age. The toxicity was tolerable and manageable without any new safety signal observed in this real-world trial. So here is the Mona Lisa 2 subgroup analysis, response by age, the overall response rate, and the clinical benefit rate were consistent regardless of the age, whether the patient had less than or more than 65, with an objective response rate as seen in this table, about 44% in the less than 65 a year and 37% in the more than 65 years. What about the health-related quality of life? In another way, using the same analytic method of matched adjusted in direct comparison, but in this time they use it between the Mona Lisa and the Monarchy 3 trial, and adjusting for the quality of life endpoint. This is the chart of the Mona Lisa and the Monarchy 3 trial, ribo versus placebo and the abemaciclib versus placebo, plus the non-steroidal aromatase inhibitor. Here is the inclusion criteria, almost similar inclusion criteria when it comes to the no systemic treatment for the advanced breast cancer setting. Patients should have a measurable disease with acceptable toxicity, and the treatment-free interval more than 12 months after prior neoadjuvant or adjuvant and aromatase inhibitor. So again, the same concept of matching the criteria and then weighting it. So inclusion, exclusion criteria were well balanced after matching and weighting the population of the two trials. And after weighting the effective sample results for the ribociclib were around 205 patients, reduction of about 38% from the baseline trial, and the around 149 patients in the placebo group with a reduction of about 55%. And here is the result of this trial. So as you can see, they used the ORTC health-related quality of life questionnaire C30 in this trial. You can see here the first-line ribociclib plus aromatase inhibitor associated with better symptom-related quality of life in comparison to the first-line abema and aromatase inhibitor in postmenopausal patients with hormone receptor-positive, HER2-negative advanced breast cancer in terms of less appetite, less diarrhea, less fatigue, as well as less arm-related symptoms. So the matched adjusted indirect comparison of quality of life trial showed a significant difference in symptoms and adverse events associated with a better symptoms-related quality of life in comparison to the first-line abemaciclib and aromatase inhibitor. The diarrhea was about reduced by 75%, fatigue reduced by 74%, and the loss of appetite reduced by about 54%, with moderate to severe impact on the quality of life endpoints. So that's because as I mentioned earlier, that we are using this medication for at least 3 years now. This is a patient median overall survival prolonged. So it is important to be incorporated into the guidelines, and that's why the ESMO guidelines, the international consensus guidelines for the advanced breast cancer, when they applied the magnitude of clinical benefit scale to each drug medicine in the field of oncology, they consider not only the long and short-term efficacy endpoints, but also they included the quality of life endpoints to be taken into consideration when we decide to approve the medicine in this treatment setting. And here is the quality of life data among the different clinical trial setting using the CDK4/6 inhibitor, whether the ribociclib, the palbociclib, and the Monarch. I think you can appreciate all the CDK4/6 inhibitor didn't, and practically speaking, it didn't affect the quality of life of our patient. However, we have a trial that showed improvement of the quality of life, as you can see here from this analysis. Mona Lisa 7 showed improvement of the quality of life in terms of pain score, time to deterioration, diarrhea, and work productivity. So the pooled analysis of patient-reported quality of life for the Mona Lisa 2, 3, and 7 trial of ribociclib plus endocrine treatment in this setting was published, and here is the Kaplan-Meier curve. The time to deterioration was improved by about 10% in the global health status, and the hazard ratio was 0.78. 8 in this pooled analysis in comparison to the placebo plus endocrine treatment. And this pooled analysis actually irrespective of the pre-specified subgroup, whether the patient age more than or less than 75, whether the patient has visceral metastasis or not, and whether the patient had liver metastasis or not. So considering these points into the discussion, so the efficacy and the comorbidities and the quality of life and the unique clinical scenario, so the ribociclib in terms of efficacy is the only CDK4/6 inhibitor have overall survival data at this point, and using it with aromatase inhibitor. The PALOMA 2 and 3 trial failed to show the overall survival significance. However, it was numerically better, and the Monarch 3 trial, I think we saw the data in San Antonio. It was a negative in terms of overall survival. The QTC concern, there is some concern we should take in consideration before starting. As I mentioned, the patient selection is very important based on the patient comorbidities and the criteria. So the QTC, the neutropenic concern, so the ribociclib versus palbociclib or abemaciclib. So this should be putting into consideration before we select the patient, as well as the organ function, whether the patient has liver or renal impairment or not. Quality of life, as I mentioned, maintained across all the CDK4/6 inhibitor trials. However, in the ribo, in the premenopausal setting, in the Mona Lisa 7 trial, it did show significant improvement of the quality of life endpoints. Question still the CNS disease, what we do with this group of patients. I think the abema we have data, but in later line as a single agent in patient with CNS disease. Ribociclib is the only phase 3 trial with CNS patients. What about the premenopausal and brain metastasis? So a lot of questions still not yet answered, I think maybe in the coming future. So this is the magnitude of clinical benefit of the ESMO guidelines. I think, as we all know, it is out of 5-point scale, and the ribociclib is the only drug in metastatic breast cancer setting that achieved the score of 5 for the ESMO magnitude of clinical benefit scale. As you can see here, all the CDK4/6 inhibitor have progression-free survival benefit. However, only the ribociclib in the Mona Lisa 7 and other trial and other Mona Lisa trial showed a significant improvement of the overall survival, as well as in the Mona Lisa 7 the quality of life, and that's why it's labeled as a score of 5. The NCCN guidelines, as you know, it gives the category 1 label for the ribociclib with endocrine treatment irrespective of the partner, whether aromatase inhibitor or Faslodex, and give the other CDK4/6 inhibitor a category 2A unless otherwise indicated. So summary of the overall survival data, I think it's very clear the overall survival met in the ribociclib trials. It didn't show in the palbociclib. However, in the Monarch 3 trial, I think it was negative but numerically positive. In the Monarch 2 trial, it met the overall survival endpoint. So the overall survival still remain the gold standard endpoints and efficacy endpoints in terms of oncology clinical trials. And the ribociclib showed a consistent overall survival across all the 3 trials in this setting, in the premenopausal or postmenopausal, in the first line or second line. So abema has shown also overall survival in the Monarch 2 and numerically better overall survival in Monarch 3, but didn't reach to a significant value. The palbo unfortunately failed to achieve the overall survival in both PALOMA 2 and PALOMA 3 trial. The visceral metastasis disease have poor prognosis overall and considered hard to be treated population, while ribociclib and abema shown a significant overall survival in the first and second line respectively. The quality of life is a very important endpoint to be taken into consideration when we decide the patient treatment. So ribo and palbo achieve the improvement of the health-related quality of life. So ribociclib considered by the NCCN and the other guidelines to be the recommended CDK4/6 inhibitor in the first line treatment setting with aromatase inhibitor. And the ribo and abemaciclib category 1 with fulvestrant in the early relapsed patient. By this, thank you so much for your kind attention, and I'm happy to receive any questions. Thank you.
Thank you very much, Dr. Dalia. Highly appreciated. Now it's my pleasure to introduce Dr. Mark Verrill, who is a senior consultant medical oncologist at Northern Cancer Care Center in Newcastle, United Kingdom. He's also medical oncology lead for national breast cancer in England and Wales. Dr. Verrill is going to talk about Verzenio, giving confidence for node-positive high-risk early breast cancer patients. Dr. Verrill.
Thank you very much for that introduction. It's a great pleasure to be in Dubai and to have the opportunity to share how we have a video.
Dear colleagues, my name is Jade Jay and I'm the Medical Director for Oncology South Africa at Eli Lilly and Company. Welcome and thank you for dedicating your time to attend this meeting organized by Eli Lilly. At Lilly, we are committed to following both the letter and the spirit of the laws, regulations, policies, and procedures that govern the pharmaceutical industry. We would like to remind you that today's discussion will be dedicated only to information that is consistent with the product label that is approved in our country. Any questions relating to unapproved drugs or unapproved indications, dosing regimens, populations, or other information not consistent with the PI will not be answered in this meeting, but forwarded to our medical department. Thank you for your understanding, and I wish you a good meeting, and I hope that the topics discussed today will bring learnings that will be useful for your clinical practice.
So I will open by promising to behave. I'll not talk about anything that's unlabeled. So it's a great pleasure to be here, and as you may have guessed, this presentation has been sponsored by Lilly. These are my disclosures, which for the purposes of this presentation include all the companies that make CDK4/6 inhibitors. So I'd like to start just by getting you to think a little bit, because in cancer we spend an enormous amount of time talking about high risk, and everybody's version of high risk differs slightly. So this is a great white shark breaching off the coast of South Africa, and that's pretty dangerous, that's pretty high risk. But actually when you dig into the numbers, it may not be as high risk as you think. And then here we've got a nitty-bitty little mosquito, and when I had to swat one off when I was having my dinner the other night, and I wasn't overly concerned because I didn't think it was going to cause me any significant harm. But when you look at the stats, on average, 5 or 6 humans are killed every year by sharks. There's been a bit of a spike in the waters around Egypt recently because of changes to the ecosystem, but around 750,000 people are killed as a direct result of mosquito bites every year. So I think we have to be a little bit canny about how we think about risk, and everybody talks about risk and high risk, and we should be very careful about how we assess it. So the first factor is the likelihood of the event, which for cancer, it's probably the cancer coming back. The second is the impact of the event, which again in cancer is likely to be catastrophic. And then we need to think about our mitigation strategies, which are the treatments that we offer people with cancer. And I think risk assessments need to be quantitative rather than qualitative, because everybody's high risk is slightly different. So we need precision rather than perception. So that's my philosophical bit. So this is a case of breast cancer, which I want to hang the following data on. So this was a relatively young, fit, premenopausal woman. She actually had somewhat irregular periods, and she'd been recalled from the NHS breast screening program in April last year, and had a relatively small 22 millimeter mammographic abnormality in the right breast. It was a little bit smaller on ultrasound, but there was a second satellite lesion, both of which were biopsied, and she had radiologically a single abnormal axillary lymph nodes. So lesion 1 was an invasive ductal carcinoma of grade 3. It was ER and PR positive with scores of 5 and 4 using the all-red score, respectively. HER2 was 2+ but non-amplified. We need precision about HER2 for sure going forward. Lesion 2 was ductal carcinoma in situ, and the axillary lymph node contained cancer cells. So how are we going to assess this woman's risk? There are a load of different ways we can do that. So the surgical pathology was an invasive ductal carcinoma of grade 3. The final size was 24 millimeters. The DCIS was actually a field, so the second apparent lesion was part of the primary tumour, and one of the 5 sampled lymph nodes were involved. And that would be the detail that we'd have and what we'd use for making decisions in our multidisciplinary team meeting. If you use TNM, it would be T2N1, so stage 2B. If you use the Nottingham Prognostic Index, which some people still do, she would be in the poor prognostic group. We could also assess her genomic risk. She actually had an oncotype test and had a recurrence score of 40. Or we could use one of the models. This is the NHS Predict risk assessment tool, version 2 of the risk assessment tool, and shows that with surgery alone, she has a 69% chance of being alive in 10 years. With the addition of hormonal therapy, another 7%. With the addition of chemotherapy, another 6%. She still has a risk of dying of breast cancer with all of those treatments. And there's a small risk of dying of other things. So we've got all of these things that go into the mix, but how are we going to use them to treat her? One of the considerations, of course, which we can't model yet is the effect of the CDK4/6 inhibitors, so none of the risk assessment tools do that. And Verzenio has been tested in a group of what are called high-risk patients, but the definition of high risk for the purposes of Verzenio in the adjuvant setting and this talk are patients with at least 1 to 3 axillary nodes involved under the arm. And then they had to have another risk factor, and the risk factors conventionally were tumor size greater than 5 centimeters, or histological grade of 3, or 4 or more involved axillary lymph nodes. And all those patients were eligible for what was known as cohort 1 in the monarchy trial. And then there was a small group of patients who had 1 to 3 nodes but didn't meet any of the other risk criteria, but had a high Ki67, and that was known as cohort 2. And the cohort 2 indication isn't licensed in many places. So how high is the risk of patients who would be eligible for the monarchy trial of adjuvant Verzenio? Well, this was an article that was driven really by the trial eligibility criteria. David Nelson is an employee of Lilly, and it was a population-based study using the SEER database in the States. It looked at patients diagnosed with breast cancer between 2010 and 2015. There were more than 300,000 of them, and as you would expect, around 2/3 of those patients had ER-positive, HER2-negative disease. And in that group, and I think this is really interesting, in that group of all comers in a US health system, bear in mind there will be screening intensively and picking up a lot of very early stage cancers, but only 12% of ER-positive, HER2-negative breast cancer patients would be eligible for inclusion in the monarchy trial. If you then look at breast cancer mortality by hormone receptor and HER2 status, you can see at the top in red, hormone receptor positive, HER2 negative have the best outcome, followed by hormone receptor positive, HER2 positive. The hormone receptor negative HER2 positive patients are doing a little bit less well, the green line in the middle, and triple negative breast cancer are doing the worst. So that really fits in with our perceptions about what biological subtypes are more threatening. But if you look at the data in a slightly different way, and I apologize, I couldn't change the colors to make it a bit more logical, but this is all of the HER2 negative subsets. So the red line at the top is hormone receptor positive node negative, so none of these patients would be eligible for inclusion in the abemaciclib adjuvant study. And then there's a hormone receptor positive N1 group who would be ineligible, and that red and green line are doing very well. We've got triple negative in there as a control. And if you've got hormone receptor positive HER2 negative breast cancer in the blue line, and you were eligible for inclusion in monarchy, your breast cancer mortality is in fact tracking along the breast cancer mortality of a triple negative breast cancer. This gives us survival up to 80 months. So the likelihood is that where the triple negative group is leveling off, we will still see recurrences in that ER positive group. So this is a group of patients who, by the definition of the trial and applied to population data, have a significant risk of the cancer coming back in the future. And I think that's an important point to make because it highlights the importance of intensifying treatment in that subset of patients. So what was the monarchy trial design? As I've already said, cohort 1 was 91% of patients, so node positive with an additional risk factor, lots of nodes, or grade 3 and tumor greater than 5 centimeters. Patients were randomized 1-to-1 to either endocrine therapy of choice, which in the trial could include tamoxifen and any of the aromatase inhibitors, with abemaciclib at the standard dose of 150 milligrams twice daily, or the same endocrine therapy alone. There was a 2-year treatment period chosen somewhat arbitrarily for the purposes of the trial, and the primary efficacy endpoint was invasive disease-free survival. And then secondary endpoints included cohort 2, so the Ki67 patients, and a subset of analysis of patients with high Ki67, and then a range of other efficacy outcomes, including distant recurrence-free survival and overall survival. So there have been a number of different analyses, and it's the pattern of care in adjuvant studies. We see evolution of the data over time. This was interim analysis 3, which was the first planned look at overall survival. So there was follow-up out to a median of more than 4 years, and it gives us, I think, confidence that if they are still divergent, that there is a carryover effect after the end of the adjuvant treatment. We're used to seeing that with tamoxifen and the aromatase inhibitors, but I think it's been a key question about CDK4/6 inhibitors, whether they prevent recurrences just while you're giving the treatment or whether there's this carryover effect. And all of the patients have been off abemaciclib for some time at the point of this data cut. So this is invasive disease-free survival in the intention to treat population, and you'll see the hazard ratio is 0.68. The p-value remains highly statistically significant, and at 5 years follow-up, there is a 7.6% absolute difference between abemaciclib and control arm. So a clinically meaningful difference in invasive disease-free survival. If you then look at subgroups, there is no subgroup that differs statistically significantly from the mean treatment effect. And what you find is where there are lines that seem to be outliers, it's based on very small numbers and they're very wide confidence intervals. So my take here is that there's no subgroup that is behaving differently from the overall trial population. And this is the distant recurrence-free survival, again, in the intention to treat population. So at 5 years, that delta is 6.7%, hazard ratio broadly the same as in the overall trial population. And you can see that those lines are continuing to diverge, certainly out to 5 years following the 2 years of treatment with abemaciclib. And then numerically, there have been fewer deaths in the abemaciclib arm, but I think adjuvant endocrine therapy trials are a very long game. If you look at ATOM and ATLAS, that were the 5 versus 10 years of tamoxifen studies, we actually had to wait nearly 20 years to see a difference. So seeing a difference is important, but are we surprised that there's no survival advantage? No, and as we heard in the last talk, probably shouldn't say this, but as you heard in the last talk, if you actually have a recurrence and start a CDK4/6 inhibitor, you're going to live another 5 years. So survival from first diagnosis of 5 years is not a clinically meaningful endpoint. So this is the evolution of events. So various different presentations, additional follow-up. One was the second presentation. So the first presentation was an ESMO presentation. It was followed up at San Antonio the same year. This is IA2, and you can see there are quite a few patients alive with metastatic disease, and there seem to be fewer patients with metastatic disease in the abemaciclib arm. We've got deaths not related to breast cancer at the bottom, which are the same. Deaths related to breast cancer, there's a gap emerging. But I think it's interesting to see that we're not seeing the recurrences translating into deaths. So there are more patients alive with metastatic disease than deaths. And it'll be interesting to follow this as time moves on. Finally, safety data. Well, I think we are all used to the side effect profile of all of the CDK4/6 inhibitors, and we are aware that neutropenia is in fact the most frequent toxicity with all of the drugs, but from a clinical perspective, diarrhea is I think the preeminent toxicity in patients with abemaciclib. We see very little in the way of neutropenia, but a large number of patients have low and intermediate, so grade 1 and grade 2 diarrhea. Few patients have grade 3 diarrhea. I regard grade 3 diarrhea as quite significant because you wouldn't be comfortable sitting in this room unless you knew where the toilet was if you had grade 3 diarrhea. But it is manageable with lifestyle changes, bland diet. We use loperamide, certainly low-dose codeine in places where it's looked on favorably can be quite helpful. And we manage these patients with very few patients having to stop treatment. We have an occasional interruption to hit the reset button. In the trial, 60% of patients had dose holds, around 40% had dose reductions, and around 20% discontinued treatment. That is an interesting discontinuation rate for two reasons. It's relatively high compared to things like chemotherapy studies, but a lot of people whose treatment was discontinued didn't have a dose reduction prior to treatment stopping. And I think that's a sign that if we manage the side effects more assertively, then we would be able to keep more patients on treatment. There was an excess of venous thromboembolic disease. That's one of the reasons that tamoxifen is not favored as a partner alongside abemaciclib. So this is the incidence of diarrhea and the number of dose reductions. And I think this just shows you that after the first couple of cycles, the patients with diarrhea, the overwhelming majority of them have just grade 1 diarrhea, which does appear to be manageable. And it's in the first few cycles where we need to get the dosing right and get the antidiarrheal medications in. And you can see dose holds, dose reductions are much more frequent early in treatment than over time. With the median onset of diarrhea about 8 days. So we see everybody after a couple of weeks on treatment just to check on their symptoms. There's also been a patient-reported outcomes sub-study that was presented by Nadia Harbeck last year. This is the trial design, just as a reminder. And this is quality of life during the two-year treatment period. So you can see mean quality of life at baseline is very much matched in the two trial arms and stays matched during the treatment period. And then this is longer term, and this is one of those asking the patients a question about being bothered by side effects. And as you can see, the treatment period I've ringed in red here, but at the start of treatment, there are quite a lot of patients reporting side effects, and the expectation, the assumption is that those are side effects from anti-endocrine therapies. And I think we need to remember the morbidity of taking an anti-endocrine therapy for 5 years with respect to musculoskeletal morbidity, menopausal symptoms, cognitive dysfunction, and the rest. And there's very little additional burden of side effects when you add in the abemaciclib, and then once the abemaciclib is continued, those patients continue with similar levels of reported side effects. Where there is a difference, of course, is in the diarrhea question, because abemaciclib can cause diarrhea. And there are clearly patients who are troubled by diarrhea as they go through treatment, and I don't think we can get away from that, but we can manage it. So going back to our patient, we recommended her to have an anthracycline and taxane in sequence, but she was very worried about missing work. She was largely self-employed, so we compromised and gave her 4 cycles of docetaxel with cyclophosphamide. She worked from home during her chemotherapy, which was terribly important to her. She had adjuvant radiotherapy, which she completed at the beginning of this year, and she started on abemaciclib. She was actually biochemically very comfortably postmenopausal after her chemotherapy, but we'll be keeping an eye on it, so she's on letrozole. And although by CTCAE criteria, she's never had gradable diarrhea because it's all about the frequency of diarrhea. She has reported that her stools are softer and she has a bit of urgency, which for a while she managed with, but by month 3 she was troubled by the pattern of her bowel function changing, and we reduced her abemaciclib dose from 150 to 100 milligrams twice daily with complete resolution of her symptoms. And she's currently completely well, living a normal life, going to work, which is what's important to her. So what's the significance of dose reductions? This is from Matt Goet's paper associated with the monarchy trial. And if you look at the dose intensity achieved, in fact, those patients who require a dose reduction have, without there being any statistical difference, but they have a trend towards actually better outcomes. So if you go all the way back to when the abemaciclib studies were first running, the dose that was recommended was 200 milligrams and was cut back because of side effects to 150 is the standard dose. So I think there's some suggestion here that 150 may not, from the efficacy point of view, be quite enough for some patients. So if you're needing to dose reduce, those patients are doing very well. That's a completely different picture from what you would expect to see with chemotherapy. So in conclusion, at the 5-year milestone, there was a continued improvement in invasive disease-free survival and distant recurrence-free survival, with those curves continuing to diverge. So the hazard ratio has been pretty stable. The actual increment has increased. There have been fewer deaths in the abemaciclib arm compared to the endocrine therapy arm, but that's not, at this stage, statistically significant. And there have been no new safety signals, so diarrhea and some neutropenia, things that we need to look out for. And the quality of life data are broadly similar between the treatment arms. So these data support the use of adjuvant abemaciclib in a patient group whose risk is defined by the eligibility criteria for the trial, and that group without abemaciclib is clearly having a risk of recurrence over time, and it's worthwhile adding the treatment in for those patients. So thank you, and I'd be very happy to take any of your questions.
Thank you so much, Professor Mark, for the interesting presentation. And the floor is open for questions. Anyone want to ask a question? Please raise your hand. Any question from the audience? Okay, I have a question. I think it's very common, and sometimes we find this group of patients with BRCA mutation, and we know that this group of patients will benefit from the adjuvant PARP inhibitor. So how you place it and how you decide about this treatment and selection when you decide to treat the patient with the high-risk features in the adjuvant setting? Would you add it together, or you sequence them, or you would give one or not the other? How you approach the patient?
So, living in the UK, I live in a world where you get one or the other. And I think that there are a couple of factors that come in. The first one is that it's pretty rare for ER-positive patients to have BRCA mutations if you just test them. We can routinely test anybody with 4 or more involved axillary lymph nodes. But it's important to do that. We know from the Olympia trial that there is a survival advantage with similar duration of follow-up. As you said yourself in your own presentation, overall survival is the gold standard of care, so we should be prioritizing the intervention that has an overall survival advantage. There are no data that I'm aware of that talks about combining the drugs, I think that you would be somewhat concerned about hematological toxicity because it's possible with both drugs. So I think that you should prioritize olaparib over abemaciclib in that very, very small group of patients who overlap. But everybody who's eligible for adjuvant olaparib pretty much would be eligible for adjuvant abemaciclib, and I'm sure that there will be people who will sequence the two drugs and will give a year of olaparib and then abemaciclib, which is completely non-evidence based and very definitely off the label for abemaciclib. But people will do it because they'll feel the need to do that. But I think that because there's an overall survival advantage, you have to prioritize olaparib if you can choose only one.
Thank you. So if you have the opportunity to give both treatment for our patient, you prefer the sequence because of the toxicity. If it is, we don't have data to support it.
I don't think we have that data. The other slight concern is there are some suggestions that the CDK4/6 inhibitors may not be as effective in BRCA mutated patients. But I think it's scientifically a very, very important question. In practical terms, it's not a scenario that we face very often. So I think we've got to look out for it. And yes, we are now routinely testing anybody with 4 or more nodes for BRCA. How many patients are we going to need to test for BRCA to find one who's eligible for Olympia, and it's going to change our treatment? And I guess the other thing is that if you were to do one of your make analyses and compare the results of the study, they're probably giving about the same. It's just that we have that little sniff of a survival advantage with olaparib. But I think that, as I say, it's very important, but it's not, broadly speaking, a relevant question.
Thank you so much. Any question from the audience? Any question? Okay, thank you so much, Dr. Mark. Thank you so much.
Okay,
thank you for sponsoring the meeting. Thank you. Thank you so much. Thank you. Nice. I'm very happy.
Thank you. Now it is my absolute pleasure to introduce our plenary session keynote speaker, Professor Chris Booth. Professor Booth is Director of Division of Cancer Care and Epidemiology at Queen's University in Canada. He's a medical oncologist and clinician scientist, and he's a professor at the Department of Oncology at the same university. He's going to talk to us about common sense oncology, moving to what it actually matters. Professor Booth was supposed to be here in person. Unfortunately, because some family matters, he couldn't be, so his talk is virtual and it is recorded. So maybe we can just start playing his presentation now. Thank you.
Good morning. My name is Chris Booth. I'm a medical oncologist and professor of oncology and public health sciences at Queen's University in Kingston, Canada. I apologize I cannot join you this morning in person, but I look forward to giving this lecture virtually. I'm just going to get started here with my slides. Great. This morning I'm going to tell the story about the Common Sense Oncology Initiative. I have no relationships with the pharmaceutical industry, but I do want to make 2 important disclosures. And that is, I've had the privilege of working with patients and their families with cancer now for 20 years. And in fact, it's one of the true privileges of being a physician to be able to walk with patients and their families during this very important journey of their lives. And I just want to emphasize that over the next few minutes, while I might be critical of some elements of our field, it comes from a very deep place of caring and a belief that we can do better for our patients and families. Over the next 20 or 30 minutes, I'm going to cover a few topics. I'm going to start with 3 paradoxes, which I think will be familiar to those of you in the audience who look after people with cancer. I'm then going to make some comments about the cancer value crisis. And finally, we'll close with an update on the Common Sense Oncology Initiative. The cancer medicine paradox relates to the fact that on the one hand, we have substantial overutilization of marginal, toxic, and expensive medicines, especially near the end of life. But at the same time, due to problems with access and affordability, most patients in the world do not get those cancer medicines, which make a big difference in outcome. The three buckets paradox relates to a communication failure on the part of our field. If one only learned about cancer treatment through the newspaper, you might wonder why we even have oncologists, cancer conferences, or even cancer hospitals, because everything in the newspaper makes it sound like our treatments cure all of cancer. And we, of course, know that while we do have some remarkable treatments, the reality is very different than the front pages of the newspaper. And the three buckets paradox relates to the fact that we do have medicines in the red bucket, and these are those medicines which are really transformational. They markedly increase the cure rate or help people live for many, many extra years. And we have those medicines. They are really remarkable. We also have medicines that fall into the green bucket. They're not transformational, but they really are very good, and they offer very large benefits to our patients. The problem is the blue bucket, and this is the bucket that's growing larger every year. In fact, most of our newly approved medicines fall into this blue bucket, but we don't talk about it that much. The problem with the blue bucket is these medicines generally have no proven benefit to help people live longer or better lives. Generally, they're approved because they can delay growth of a tumor on a CAT scan for a period of time. And the reality is we should be aiming higher so that we have more treatments in the green bucket and red bucket. And those treatments which are in the green and red bucket, we should strive to make them widely accessible to all patients who could benefit from them worldwide. And finally, the NGS and communication paradox. In 2024, we have the ability to know more about the molecular makeup of our patient's cancer than we ever would have imagined 10 or 20 years ago. We can deep sequence tumors, we can predict biomarkers, we have really remarkable biologic advances. However, while we know a tremendous amount about the tumor of our patients, studies over and over again have shown that we have failed in the basics of communication, and that many patients who have incurable disease still believe that treatments that we are giving them will cure them. And so we have this paradox whereby we know remarkable level of detail about a patient's tumor, but the patients lack a fundamental understanding about the intent of their treatment. So I just want to pause for a moment and recognize that over the 20 years of my oncology career, there have been tremendous successes. And I think it's worth emphasizing these and celebrating these, especially before the next few minutes where I might be critical of some elements of our field. We've certainly had remarkable advances in the knowledge and understanding of cancer biology over the last 20 years. And this has led to some really remarkable treatments. We do have treatments now over the last 10 or 20 years that go into that red or green bucket category. This has led to the improvement in outcomes for some cancers, but not all. While we still have a long ways to go, we can do a better job, but we are improving to have patients truly engaged in the research ecosystem and policy and treatment decisions. We again have room for improvement, but we have paid more attention to psychosocial aspects of care and palliative care over the last 10 or 20 years. And finally, in the global space, oncology is now recognized as a public health problem. However, we find ourselves in the cancer value crisis, and this is a convergence of 5 factors. We have some problems with some clinical trials. We also have many excellent clinical trials, but some clinical trials we have problems with their design, interpretation, and reporting. But it's worth emphasizing that the trials that have problems, these problems are self-inflicted by us as investigators and those who read and interpret trials. There's nothing inherently wrong with the randomized controlled trial, which I believe still remains the best tool we have to identify new treatments that benefit our patients. We have an explosion in primary endpoints that may or may not matter to patients. We have a lot of very large trials that are designed and powered to detect very small benefits. We have a staggering and unjustified problem with rising prices of cancer medicines. And finally, we fundamentally have a breakdown in communication, both at the micro level in the way that we discuss treatments with our patients, but also at the macro level about how we discuss these issues within our community, more broadly with the public, with the media and policymakers. I conceptualize value as the interface between the magnitude of benefit and the cost. And there's been a lot of discussion in the last 20 years about the denominator here, which is the cost. And I have a few slides to focus on the denominator, but most of my lecture this morning will focus on the numerator, the magnitude of benefit. And this is where actually as individual oncologists, investigators, and trialists, as well as those who are writing guidelines and advising policymakers, we can actually have a lot more impact on the numerator than the denominator. This is a paper we published just a few months ago in Lancet Oncology. I live and work in Ontario, which is the largest province in Canada. It has a single-payer public health system, which includes cancer medicines. We worked with our colleagues in the Ministry of Health to report spending by the public health system on cancer medicines over the last decade. And you can see that it's gone up by a factor of 4 over the last 10 years. The figures here are in Canadian dollars. The absolute numbers are not that important. It's the shape of the curve. And so while health spending in general in our system and many others is growing at about 5% per year, the spending on cancer medicines is increasing at a rate of 15% per year. And so this is highly unlikely to be sustainable in any health system for very long. This is another study we published 6 or 7 years ago, also in Lancet Oncology, where we asked whether there was a relationship between how well a medicine works and its price. And we found that not only is there no association between the magnitude of benefit and the drug price, we found that if anything, there's an inverse relationship whereby the drugs with the smallest benefit have the largest price tags. And certainly I don't think you need a PhD in economics to know that is a very broken model of drug pricing. And finally, this is a piece of work led by one of my former students, who's now an oncology fellow at the University of Manitoba. Dan Myers and colleagues addressed a very simple question I had, but they had to do a lot of work to sort the answer out. And my question was, what is happening in the global pharmaceutical space when it comes to cancer? And what we did was we identified the 10 largest pharma companies in the world, and the team of students and residents reviewed their annual financial documents for each of those 10 years to identify just really 2 pieces of information. In any given year, we wanted to know what was the proportion of sales revenue that was from cancer medicines and what proportion of sales revenue was from all other diseases. And you can see the very powerful trends on this figure. You can see that over the last 10 years, there's been a major pivot of global pharma into the cancer space. The proportional increase on cancer revenues from medicines has gone up to 70%, and the sales revenue for all other medicines has decreased by 18%. And certainly on the surface, this would appear to be good news for people with cancer, and certainly it is encouraging to see innovation in our field, but I think there's probably 2 reasons for us to pause and have some reason for concern. The first is that there's been a major gamble here on the part of global pharma, and I think all of us would agree that there are many other important diseases and public health problems where we also need innovation and new therapies coming down the pipeline. The second issue is I think most of us would recognize that most scenarios in life do not become better with more and more and more and unlimited amounts of money. And I think some of the problems that have arisen in our field are due to the very large financial pressures which shape much of what we do. So shifting now to the numerator of the value paradigm, which is the magnitude of benefit, we're going to speak briefly about endpoints and then the effect size. This is a slide from one of my teachers, mentors, and colleagues, Dr. Ian Tannock from the Princess Margaret Hospital, who taught us in training that there are really only 2 goals of any treatment for cancer or any therapy. Us as either current patients or future patients of a health system would expect and would want a new treatment to help us live longer lives and help us live better. And accordingly, the most important endpoints of phase 3 randomized controlled trials should be overall survival and quality of life. However, you can see the trends in our field are indeed worrisome. This is a paper we published in JAMA Oncology 2 or 3 years ago, where we've been tracking a cohort of RCTs of systemic therapy in breast, lung, and colorectal cancer going back into the 1970s. And you can see in the 1980s and 1990s, most RCTs in oncology were being designed to see if the new therapy could help patients live longer lives. But you can see that's decreased, whereby in the modern era, only about 1/3 of trials are being designed to see if they can help people live longer. Instead, the new king of oncology is progression-free survival. And now almost half of all the randomized trials in our field are being powered and designed to see if we can improve progression-free survival. Progression-free survival, of course, is a composite endpoint that includes death, but largely the events are driven by imaging-based measurements of cancer on a CT scan. And progression-free survival was invented by the architects of the RESIST criteria, including one of my close mentors and colleagues, Dr. Elizabeth Eisenhower. And RESIST and definitions of progression and progression-free survival were invented to be used to guide decision-making in early phase trials, phase 1 and phase 2 trials. PFS was never designed to inform phase 3 trials or clinical practice or policy, yet that is the paradigm we now find ourselves in. Finally, the other major trend in our field is that more than 90% of RCTs in medical oncology are funded by the pharmaceutical industry. Now, I don't want to suggest this figure should be zero, because many of our most remarkable treatments and some of the best clinical trials in our field have come from partnerships with the pharmaceutical industry. However, the pendulum has swung too far to one side, and now almost everything is controlled by pharma. This makes it very difficult to identify other funding sources to answer other questions which matter to patients but do not matter to pharma. For example, randomized trials of communication approaches or psychosocial supports in oncology, randomized controlled trials of lifestyle, diet, exercise, meditation, or what about randomized controlled trials of treatment de-escalation? Can treatment be reduced in intensity but preserve outcomes, reduce cost, and reduce the side effects and toxicity for our patients? These are all really important questions that are very difficult to answer in the current research ecosystem. So why did progression-free survival move into the phase 3 space? And this happened in the late 2000s, really in the early kind of 2010-12 era. And again, it was with good intentions. It was felt that improvements in progression-free survival would predict outcomes and improvements that matter to patients related to overall survival and quality of life. It was also felt that using progression-free survival would allow us to get new treatments to patients faster. Of course, all of us, including the doctors and patients, like to be able to say the cancer on the CT scan is stable or shrinking. And we also thought many years ago progression-free survival was easy to measure. However, fast forward about 10 or 15 years, and we've learned that these are problematic assumptions. In fact, while there are circumstances where progression-free survival is an excellent surrogate and in fact a very appropriate primary endpoint, these are exceptions and not the general rule. So generally, progression-free survival does not predict improvements in overall survival or quality of life. We've learned that we can get treatments a little bit faster to patients, but it's not as much as we thought. It's not measured in many years. It's typically measured in months. While patients and their doctors do like hearing the cancer is stable on a CT scan, our group and others have done mixed methods work interviewing patients with lived experience of palliative systemic therapy. And when we presented hypothetical scenarios to them of a drug with toxicity, which will not improve their overall survival or quality of life, but which will delay the time until a tumor grows on a CAT scan, a majority of patients say they have no interest in treatments that only delay progression on a CT scan, have side effects, and will not help them live any longer. And finally, we've learned because of a form of bias called informative censoring, it's actually quite difficult to accurately measure progression-free survival. In fact, our group and others have done modeling exercises showing that at least some proportion of the apparent gain in progression-free survival seen in clinical trials is likely a statistical artifact and not real. However, I think in 2024, progression-free survival is not going to go anywhere anytime soon. I think, again, just to emphasize, there are very appropriate contexts where using PFS as the primary endpoint makes a lot of sense. But I think in most circumstances, we should really ask ourselves, is this the best thing for this trial and for patients? Because there are risks if we ignore overall survival. And at a minimum, if we're going to measure progression-free survival, we should also be powering and measuring for overall survival. And the three risks include, the first risk, which I think many of us have thought about quite deeply, is that we might only be giving patients side effects, clinical toxicity, time toxicity, and financial toxicity without really helping them. But on the other end of the continuum, there's examples published by the FDA where drugs that were approved based on PFS with subsequent follow-up led to inferior overall survival. So we actually could be causing not just clinical toxicity, financial toxicity, and time toxicity, but we could actually make people live shorter with these new drugs. And finally, on the other end of the continuum, there's examples from some of our most impressive new treatments in melanoma and lung cancer where the early signal, the early benefit of PFS was very small, and we might have thrown those drugs out the window. However, with longer follow-up and patients, we saw transformative and very large gains in overall survival. So at a minimum, if we're going to be measuring progression-free survival, we should also be measuring overall survival. We've reviewed the fact that most newly approved cancer medicines have no evidence they improve overall survival, but some of them do, about 25% of them do. And within that small cohort, some of the gains in progression-free survival are really remarkable, many, many months or many years of added life. However, in aggregate, this is the average improvement in median survival in a clinical trial with new cancer medicines. For those minority that actually improve overall survival, it's 3 months. And certainly as someone who looks after patients with advanced GI cancer, I would not want to take away the meaning of an extra 2 or 3 months for a patient and family. But we need to remember that this comes with some important caveats for our patients. They are the ones that need to live through the clinical toxicity and side effects of our treatments, which we know are always higher in routine practice than in clinical trials. Depending on what health system or where the patient lives in the world, they and their family can endure massive financial toxicity. In fact, in many countries, a diagnosis of cancer is a leading cause of bankruptcy, and certainly health systems also are exposed to financial toxicity. And finally, our patients are at risk of the emerging concepts of the gap between efficacy, which is outcomes observed in trials, and effectiveness, outcomes in the real world, as well as time toxicity. The efficacy to effectiveness gap is driven by the fact that patients in clinical trials are very different from patients in routine practice. And therefore, we've seen over and over again that the benefits of therapies in trials are always attenuated in routine clinical care. So if a treatment in a clinical trial improves survival by 10 or 11 weeks, we know it's less in routine practice. Is it 4 weeks? Is it 9 weeks? Is it 3 weeks or 5 weeks? We don't know, but we know it's less, and it's important for patients to know that. And finally, our group and others have done a lot of work on the concept of time toxicity. Time toxicity relates to the amount of time that we invest in seeking healthcare. And if someone is going to live for a long time, or the therapeutic intervention has a very large benefit, that time trade-off is probably very reasonable for most people. However, where time toxicity becomes most important is in the last year of life. When time is short, every day matters, and this also happens to be the circumstances where our treatments have the smallest benefit. And so certainly it's not up to me or any individual oncologist or group to determine how and where a patient spends their time in the last 6 or 12 months of life. But certainly I think patients want to know this. And in fact, we've done some modeling exercises where for clinical trials showing an improvement in median survival of 30 days, if you add up all of the extra days the patient will be at the chemotherapy unit or in the emergency room or dealing with toxicity, there's almost a direct trade-off. So every extra day of life in some clinical trials can be traded off with an extra day seeking healthcare. And different patients will view this in a different way, but we need to measure time toxicity and tell patients how they will spend their time, especially when time is short. So with that background, a number of us decided to launch the Common Sense Oncology Initiative. And this came from a place of recognizing that there are things that we do very well in our field, but there are also areas that we need to talk about. There are problems and challenges that we should not and cannot ignore, and we want to be solution focused and work towards improving these problems. So about a year and a half ago, in April of 2023, we invited 30 people to my university, Queen's University in Kingston, Canada, to have an extensive conversation about these issues. These 30 people came from 15 different countries, and included patients and patient advocates. There was a mix of academics, oncologists, policymakers, and editors, in addition to our patient partners. And for 3 vigorous days, we debated what were the greatest challenges in our field, where did we think we could have an impact, and how would we organize ourselves to try to make things better for patients. And this culminated with the publication of what's been called the Common Sense Oncology in Lancet Oncology in July of 2023. And the mission of this initiative is to ensure that cancer care focuses on the outcomes that matter to patients. Our vision is that patients have access to the cancer treatments that provide meaningful improvements in their outcome regardless of where they live. In essence, Common Sense Oncology is addressing the yin and the yang of the global cancer space. For those treatments which make a real difference in the lives of our patients, we want to advocate and ensure that all patients have access to these, regardless of where they live. And on the flip side, we also want to have honest discussions about some of the treatments that are routine and standard in our field, which offer very small benefits and in fact might cause harm. And we want to do this so that we can raise the bar to deliver treatments and outcomes that matter to patients. We have a series of guiding principles that will guide this movement, including access to quality cancer care as a basic human right. Patient and societal needs should drive cancer research and delivery of care. Patient and public involvement is essential when making policy decisions. We think that when a patient walks into a cancer hospital, they should be able to expect that the treatments offered to them will help them live longer lives and better lives. Obviously, every patient will view these complex issues very differently, and it's not up to us to provide any specific answer for a specific patient about how they choose to pursue cancer treatment. But all of this should be grounded in evidence-based medicine and critical appraisal, and really and truly informed shared decision-making between the patient and their care provider. We believe that cancer treatment should be fairly priced for the context in which they are used. We also believe that equity into the treatments that we already know work should be prioritized just as much as new fancy robots, radiotherapy machines, and cancer medicines. And finally, recognizing that while cancer medicines gets a lot of attention in our field, comprehensive patient-centered care involves much more, including access to high-quality radiotherapy, surgery, psychosocial oncology, survivorship, and palliative care. The Common Sense Oncology Initiative has arranged our work around 3 core pillars. We seek to improve how we generate evidence, how we interpret evidence, and how we communicate evidence. Evidence generation is working to ensure that clinical trials in our field use and report outcomes that matter. Evidence interpretation is an educational work stream seeking to empower the next generation of oncologists with skills in epidemiology, critical thinking, and critical appraisal. And finally, evidence communication relates to how we talk about these complex issues with patients at the bedside, and more broadly with the public and the media, as well as policymakers. So we have populated 5 teams, and I should mention that patients and patient advocates are represented in all of these teams, and in fact have leadership positions on the patient priorities team. We have a clinical trial team, which is being led by a world-leading trialist seeking to improve how we design and report RCTs. We have a group of educational scholars and clinicians and oncologists working on how we train the next generation of oncologists. We have a group doing stakeholder engagement to speak with oncologists and other stakeholders around the world to learn about the barriers and enablers of practicing oncology and undertaking research in keeping with the CSO principles. We have a group, again, co-led by one of our patient advocates, which is spending time interviewing and doing focus groups and outreach with patient communities to understand what are their priorities and where do they think we should be working in this space. And finally, we also have a health policy and health delivery care team looking at how we can improve the way that we deliver cancer treatments. In closing, I'll just paraphrase from the last paragraph of our essay in Lancet Oncology to give you a sense of the ethos of this group. Common Sense Oncology will promote interventions that measurably improve the lives of patients. We will celebrate well-conducted trials and promote effective treatments, but we will also speak up about and challenge interventions that might cause more harm than good. We seek to decrease global and regional inequities in access to affordable, high-quality care. Improvements in the generation, interpretation, and communication of evidence will help close these gaps and move our field closer to a future in which a patient's outcome is not determined by where they live, what they can afford, or the strength of a marketing campaign. And with that, I'll close. And again, thank you for the invitation to speak here. And I'm sorry I can't attend in person this morning. I would encourage you to please look at our website, read some of our publications, and please get involved. Although this initiative started with a small planning meeting of 30 people, it's really exploded globally since then. And we have members from dozens and dozens of countries all over the world. You can learn more about us at our website. You can join to become a member of the Common Sense Oncology Initiative. There's no fee to become a member. We just ask for your name and email address, and you'll receive educational materials, newsletters, and other updates about the work we're doing, and also learn how to get involved. Certainly, the challenges that we're tackling are large. We're going to need the collective input of all stakeholders from the global cancer space, and I look forward to hearing and collaborating with many of you in the future. Thanks again for the opportunity to be with you today, and I hope you enjoy the rest of the conference.
Today, maybe the microphone is not working, but it's okay, my voice is very strong. So I'm very grateful that I am here today. Thanks to this opportunity. Thank you, Dr. Humaid. Thank you to the EOS community and association. Actually, we are gathering here today, not only sharing information, but stand by those who are impacted by cancer and breast cancer. I'm wearing pink and white. It's just not a symbol of standing by the breast cancer people, men or women who are affected with this disease, but because I am in deeply support them until my bone. First of all, let us rise in respect and gratitude for our UAE national anthem. So welcome to the grand opening of the 5th EOS Annual Conference 2024. It's a tremendous honor to stand before you today as we gather for this significant event dedicated to advancing oncology care. I would like to extend a special welcome to our distinguished VIPs who have joined us today. His Excellency Dr. Amin Al-Amiri, I welcome you. Sheikha Dr. Noura Al-Qasimi and Dr. Marwan Al-Mulla and Dr. Mawza Al-Sharhan and also Professor Humaid Al-Shamsi. And of course, our esteemed EOS members and medical teams, caregiver, health caregiver, doctors, and all the medical members here. Today marks not an usual day, not an ordinary day. I have 3 C words. I put it in my dictionary, actually, especially for the cancer patient. First C word is control. Second C word is curiosity. And third C word is courage. Control, you have to see and screen from time to time your body. If you control your body, you can live in a lifespan, healthy, no disease. Curiosity, you have to know your DNA. Your DNA. You have to know your inherited disease. You have to know your family cancer story. You have to know everything. And courage, you have to face your fear. As Winston Churchill said, fear is a reaction, but courage is a decision. And we have to have this decision in our fight, in our battle for cancer. We invite now Dr. Amin Al-Amiri. He is the Assistant Undersecretary of Public Health Policy and Licensing Sector in UAE Ministry of Health. Please, can you join us, Dr. Amin?
بسم الله الرحمن الرحيم والصلاة والسلام على سيدنا محمد وآله وصحبه أجمعين. Good morning, ladies and gentlemen. It's my profound honor, it's my pleasure to be here with you today in one of the precious days, Friday. I'm so happy and so encouraged that today we are discussing a subject which is very important for the human being, for the people, our beloved people, for the people that we should take care and we should support as health professionals. And whenever I said health professionals, because each single person at hospitals or other industries has a great role in supporting our patients. Doctors, physicians, nurses, paramedics, and not to forget the private sector, which is the pharma industry. Thank you. Thank you, that's a technology. Today, we admire each single one of you because you are doing a great job for the humanity, for the people who needs us, for the people who really are in need of our support. If I will share with you manual, it's okay. If I will share with you one of the main slides in my presentation today, the number of the people who dies due to the NCDs, non-communicable diseases, reached to 41 million worldwide, which stands almost 74% of the total death worldwide annually. And this is the estimation as per the World Health Organization. And there are 4 main causes of death in the world. The second main cause of death is the cancer cases, which stands for 9.3 million people every day. Although the others are very important, but today we are discussing about one of the main subjects which really it's a threatening, and we should be careful and we should make sure that we as a health professionals, as a government, as a pharma industry, as a people, social industry, join the efforts together in helping this category. I know in my country, we were the first country in the region which we started the cancer registry, and have one of my great colleagues here joining us today, Dr. Falah Al-Khatib, in which I do admire. This registry started in Tawam Hospital long time back. Today we are so proud to say that we have huge number of units, health professionals, professors, doctors in this field, and we have many of the cases is being brought from outside the country as a medical tourism or as a support to them from the region that to take their treatment here in the UAE. Which it means this is the importance of making sure how we jointly will be able to help this category of the people. Although this slide will show you something threatening, that the number is huge, 9.3 million people annually a year, they pass away, they leave this beautiful life. But on the other hand, there is a good news that the number of the patients which were able to be cured is really increasing. The curve here, it decreases because this decreases the number of the death for different type of cancers, mainly the stomach cancer, the lung cancer, pancreatic cancer, and the others. If you look at the screen, that the numbers are decreasing. And a question will come up here. What's the reason behind? Reason behind, number one, the advanced diagnostic system. Number two, quality of care which was given to our patients among our hospitals and specialized centers. Three, the pharma industry, R&D, which were so helpful by doing R&Ds, clinical trials, to discover the new drugs, either biological or non-biological drugs for our patients. And fourth comes the lifestyle. The most healthiest lifestyle, it's the best, as the lady said here, to prevent and predict different type of diseases in your life. Not only the NCDs, and also the non-NCDs, which is the communicable diseases, including avoiding as we say, a junk food, or a food which really it has a negative impact on our health. And therefore, this slide will show to you that we can predict by new diagnostic programs, and we can prevent huge number of cancer cases if we were able to take care of our health. The lady who wears pink, she said very beautiful say from Churchill. Allow me to say a beautiful say from our Prophet Muhammad, peace to be upon him. Our Prophet Muhammad said, نعمتان مغبون بهما كثير من الناس. النعمة الصحة والفراغ. نعمتان مغبون بهما كثير من الناس. الصحة والفراغ. Translation. The Prophet Muhammad said, there are two valuable things in our life has been forgotten or ignored by many people in this life. Health, time, which it means you should take care of your health. You should have a healthy lifestyle and healthy food, and you have to learn and teach your children, your grandchildren to follow you and to be even better than you. And therefore, as I said, almost 30 to 50% of the cancer cases can be prevented by avoiding the smoke, tobacco, by enjoying the healthy diet, going to the greens, and also by the early test, early diagnostic, periodical diagnostic, by exercising, by vaccination for your children and us with different type of diseases, HPV and hepatitis, and also by avoiding anything external which it affects your health or your family members' health, reducing the exposure of the carbon dioxide or carbon monoxide, and also to make sure that physically you are fit and you follow your daily exercise, which has been stated scientifically minimum 2 days per week. And we have to make sure that we have to be a part of the social program, that our people, our patients will be well supported by the social program. Such programs and the prevention steps is well taken care by the government of United Arab Emirates. And this has been implemented in the UAE long time back. And we, as the healthcare sector, whenever I say we, which includes our Ministry of Health and Prevention, Dubai Health Authority, Abu Dhabi Department of Health, Sharjah Health Authority, and not to forget the private sector, which they play a great role in our country, and also the pharma and the medical industry, which they are very supportive, and not to forget Emirates Medical Society, and the social societies belongs to different Emirates. I don't want to go in details with this busy slide, but I can say those are the main pillars, 6 pillars that we have to be in a position to implement, to follow, evaluate, and then to develop new policies which really it will help our community. Those are some of the programs which is being implemented in UAE. And those programs we do manage with the United Nations, with the World Health Organization, with the Arab League, and the GCC Medical Council. Includes the international pharma and medical companies, which really, they have a great support to our beautiful country, the United Arab Emirates, taking into consideration that I do believe almost before COVID, we used to allow the clinical trials phase 3 and 4. Today, since COVID, we are aggressively involved on the clinical trials phase 1 and 2, and we were the first country to produce our own COVID vaccine. And also, I can give you a small report that in 2017, almost 6,000 plus number of the R&D performed in the UAE. By end of 2022, we reached to 14,000 plus number of R&D clinical trials as accumulated activities being performed and done in the United Arab Emirates among governmental private hospitals with the support of the international pharma companies and international organizations. And I just show you at the left side of, or it's your right side, my left side slide, the number of tobacco uses in the UAE has been clearly declined during last couple of years. Ladies and gentlemen, I will repeat what have been said at the beginning of my speech. Today, I'm happy that we are discussing about one of the most important subjects to our patients, which really they need our support, either medically, diagnosis, socially, and the rest, and we have to give them hope. Hope is something that we should have it until our end of life. End of life, it's our destiny in the hand of the Holy Allah, Holy God. And therefore, we should not leave any sort of, even a single hope to support our patients. There are many patients which were sent abroad. They have been told that in 6 months, he will pass away. With hope, with the support of the government, with the new treatments, your support guys from pharma medical industry and the health professionals, still now they are living for more than 12 to 20 years with a healthy lifestyle, and they are really enjoying lives. And therefore, we would like you to join us, our hope. And this hope, it has been said by our leader, the most visionary leader in the world, by Sheikh Mohammed bin Rashid Al Maktoum, Vice President, Prime Minister, ruler of Dubai, that hope is the power, is the name of the power, that if we will give a hope to our patients, to our people, we will be able to give more, performance more, we will be more productive, and we will be more active in supporting our community, our country, and our region, and the humanity in general. Once again, it is my profound honor once again to be here with you and to speak to you about one of the most important medical disciplines in our life, which is the cancer. God bless you. Assalamu alaikum wa rahmatullahi wa barakatuh.
Thank you, Dr. Amin, for your very brilliant speech, and really it encourages us. Thank you. As I told you, today we are marked the beginning of a special and unique initiative which unites the 7 Emirates. It is stronger together. Yes, we are stronger together when we have hope, when we stand by those impacted by cancer, when we share their journey. It's not only a medical journey, it's a personal journey which affects our families, friends, and communities. Ladies and gentlemen, there is a special video I would like to share it with you to see about the Stronger Together, this campaign. Let us see it together. Stronger Together. We invite you to join us for informative conference on Saturday, October 26th, at 3 p.m. to 6 p.m. at the Mohammed bin Rashid Library. This conference will highlight the powerful stories of breast cancer patients and survivors, providing a platform for open dialogue, empathy, and also understanding around their life experience. Thank you for being here today. Now let us welcome Dr. Humaid Al-Shamsi, Professor Humaid. Of course, Professor Humaid, he is the president of EOS, and also I have a lot of TV filming with Dr. Humaid. He is a very supportive man. He supports all people, and he also gives us a very correct information with his acknowledgement and everything in the oncology field. Welcome.
Bismillah ar-Rahman ar-Rahim. Bismillah ar-Rahman ar-Rahim. I would like to welcome everyone to our annual Emirates Oncology Society, which is the 5th edition. And we are very pleased to have you all. I would like to have a very special welcome to our distinguished VIPs, His Excellency Dr. Amin Amiri, Sheikh Dr. Noura Al-Qasmi, the President of the Emirates Medical Association, Dr. Moza Sharhan, and everyone who came from across the GCC and also the MENA region. Just waiting for the screen to turn on. Yes, it's working. Yes, it is fine. It's completely fine. Yeah. Dear all, we know that cancer is the third leading cause of death in the UAE. And as Dr. Amin Amiri mentioned, the incidence of cancer will continue to increase. In 2021, according to the Ministry of Health data, 5,800 cases recorded with cancer in the UAE. But having said that, the total number of deaths actually has declined. And this is in keeping with the UAE government commitment to reduce mortality. So despite the number increasing, we're seeing decline in the mortality because of the, alhamdulillah, the importance and also the implementation of early screening and detection. Unfortunately, the number of cases in the UAE as per WHO is expected to increase by around 200% in 2040. And it sounds crazy, but if you look 20 years ago, we used to have 1,500, 2,000 cases in UAE. Now we're almost 6,000 cases, so there are no surprises. So we'll continue to see increased number of cases in the UAE. So for that, what are we doing as a community to fight cancer? The Ministry of Health and Prevention, MOHAB, and other health regulators like DHA and DOH are working very closely to reduce cancer mortality through improving access to cancer care for all citizens and expats, through supporting new drugs approval, early detection screening, supporting clinical research, as Dr. Amin Amiri mentioned, and also access to innovation and advancing the cancer care in the UAE. So what does the EOS do in reality? So under the umbrella of EMA, We work very closely with the Ministry of Community and Development. We do complement the role of the regulators, trying to become advisors, and also with our partners, and also with our patient, and also the GCC community, trying to advocate for improving the access to different modalities for treatment, and also increasing the awareness about cancer, especially early detection and screening. We also work very closely with the regulators, including the Ministry of Health, trying to implement new regulations and also trying to implement an advice regarding the latest advances in the cancer care. We've been working very closely with with the DHA, and more recently, the DHA has established the oncology the advanced standards for oncology services, which has been implemented in Dubai a few months ago. And this is again the effort to improve the cancer care in Dubai and also in the UAE. The EOS has been also partnering with international societies and organizations, in this picture with the president of ASCO, which is one of the largest organizations in the world, and supporting research and also trying to advance the cancer care in the UAE through collaboration with such entities. In research, we have published proudly more than 100 publications over the last 5 years. We are one of the most publishing organizations in the MENA region, and I don't think really anyone else has published that much. We publish in all the big journals, including JAMA, Lancet, the JCO. In fact, we had a publication last night in JCO addressing challenges in surveillance for breast cancer and also challenging the current standard of care, which we believe it's not in keeping with the best practice. The EOS also has been working closely with other EMA societies, especially with the Urology Society and also with Thoracic Society. We do webinars together, we publish together, and this is also in our vision to collaborate together trying to fight cancer. The EOS also has introduced for the first time in UAE the awards for individuals and organizations who are been contributing for the cancer care, and this is again in keeping trying to promote the culture of working together and also to advance the cancer care through collaboration across the UAE and across the region as well. We also published the first book about cancer in the Arab region. I remember when I approached different individuals, organizations more than 6 years ago, many said, this is too big, this will not happen. This book has been downloaded more than 500,000 times, more than 500,000 for free, and I would like to thank Merck for their support to make this book available for free. Many people have been using this book actually, and also organization to advance cancer care, not only in the UAE, but the entire MENA region. The EOS has been very active. We have done more than 100 webinars over the last few years. We've been partnering also with ASCO, with ESMO also, to advance the cancer care in the region by increasing the knowledge for all healthcare providers. And again, we've been doing this actually, all these activities for free. And this is part of the commitment of the Emirates Oncology Society and also Emirates Medical Association to advance the healthcare in the UAE as well. We also conducted the first graduation for patient survivors from cancer 2 years ago. This has been a very positive experience for our patient, and in fact our patients are looking forward every year for this event, which again brings hope. As Dr. Amin mentioned, we need to implant hope in our patient despite their stage of disease. Also, we've been working very closely, as I mentioned before, with the Ministry of Health. Currently, the Ministry of Health is working very closely, trying to advance the cancer care in UAE through mandating the MDTs for these patients. We are very positive for such progress in this field, working closely with the Ministry of Health. As Emirates Oncology Society, we're also been working closely with Emirates Medical Association societies to publish the first book about healthcare in UAE. This book in the final stage, it will be published inshallah first quarter of 2025. Again, it will be available completely for free, and in this in the effort for advancing the healthcare in UAE and not only cancer care. We're also very proud to introduce, and we're currently on the final phase, to introduce an application for our patient, where this application will be their one-stop shop. They can find ways to go for screening modality. They can find their providers. They can also book their appointment. They can also put their recommendations regarding where to go for treatment, and also to log their treatment, including their chemotherapy sessions. This is going to be one-stop shop for all the patient and healthcare providers in the UAE, trying to make it easier for anyone who wants to know where to go and what to do if they have cancer. The Emirates Oncology Society continues to be very committed toward the community in the UAE and the region, and will continue, inshallah, to work with our partners and colleagues from across the region as well, trying to advance the cancer care, inshallah. With this, I would like to thank you for your attention. I would like also to welcome everybody, inshallah, for our first palliative care conference, which is going to happen in the next 2 weeks. And this palliative care, in our effort to promote the culture of accepting palliative care as a very critical component of any healthcare system. With this, I would like to thank you. Wassalamu alaikum wa rahmatullahi wa barakatuh.
Thank you, Professor Humaid. We are also honored to have Sheikha Dr. Noura Al-Qasimi, EMA President, Emirates Medical Association President, with us today. Please join us, Sheikha. Thank you.
Assalamu alaikum wa rahmatullahi wa barakatuh. Your Excellency, Dr. Emil Amiri, Dr. Ramoza Sharhan, dear guests and esteemed speakers, welcome to the 5th Annual Conference of the well-distinguished Emirates Oncology Society. This gathering underscores our shared commitment to advancing oncology care in the UAE and globally. Your presence today reflects our collective drive to improve patient outcomes, inspire scientific innovation, and compassionate care. I extend a special welcome to His Excellency, Dr. Emil Amiri. Your unwavering support for the healthcare sector, especially in oncology and other specialties, have been vital in advancing our national agenda. We are grateful for your leadership and dedication. Thank you very much. Reflecting on the EOS journey, as Professor Humaid has illustrated beautifully all the achievements, starting the Oncology Society from humble beginnings into a formidable platform by all means for collaboration among local and international experts. It has achieved significant milestones such as groundbreaking research initiatives, contributing to better treatment protocols and patient care strategies. Society's commitment to public awareness campaign has helped educate the community about cancer prevention and early detection. This year's conference highlights the latest advances in cancer management and their integration into clinical practice by focusing on innovations that can be readily applied to care and to serve our patients within UAE. As President of Emirates Medical Association, and from this podium, I would like to extend my thankful and gratitude to Dr. Moza Sharhan, who paved the road for the success of the Emirates Medical Association. With the help of her legacy and the other colleagues, we have in the Emirates Medical Association around 49 scientific societies and full of experts. So I'm really proud and thankful for you too. As I'm proud of the progress of EOS has made in fostering an environmental that promotes learning, collaboration, and innovation. It became a beacon of excellence in the region, and I'm really, as an Emirati, I'm so proud of that. And I'm confident this conference will continue to elevate our standards. Welcome again, and I wish you a blessed day, a blessed Friday, and enjoy your conference. Thank you all.
Thank you, Dr. Noura, for your wonderful speech. Thank you so much. Ladies and gentlemen, the stage is set for an incredible journey of knowledge sharing, innovation, and collaboration at this year's Emirates Oncology Society Annual Conference as we celebrate excellence in the oncology field and healthcare sectors. Today, we honor those whose unwavering dedication and groundbreaking contributions have made a profound impact of the well-being countless lives. Let the awards ceremony commence. I now invite His Excellency Dr. Amin Al-Amiri and Sheikha Dr. Noor Al-Qasimi and Professor Humaid Al-Shamsi to the stage, please, to honor those fighters. Either they are healthcare givers, doctors, and fighters. I now invite EOS Lifetime Achievement GCC Oncology Dr. Kanaan Al-Shammari, please, to the stage. Now, EOS Lifetime Achievement UAE Oncology, Dr. Norbert Dreer. Women in Oncology Award MENA, Dr. Atlal Abu Sanad. And now I invite EOS Women in Oncology Award, UAE, Dr. Muna Al-Alian. Researcher of the Year, Dr. Aida Al-Awadi. Aida Al-Awadi. Member of the Year, Dr. Saeed Rafi. EOS Cancer Awareness Advocate of the Year, Dr. Iman Al-Shamsi. EOS Oncology Pharmacist Award, Dr. Anas Hamad. العربي. سهام العربي. Now special EOS Special Recognition Award for Dr. Sheikhanura Al-Qasimi. And also EOS Special Recognition Award for Dr. Amin Al-Amiri. Special Recognition Award also for Dr. Mouza Al-Sharan. Industry Research Partner of the Year, AZ, AstraZeneca. And also EOS Cancer Awareness Partner of the Year, MSD. I don't know this abbreviation. MSD. Cancer Awareness Award of the Year to Novartis. Education Partner of the Year for Merck. In this campaign, we encourage to go green. Now I thank you, Dr. Humaid, Dr. Noura, and Dr. Amin. You can come again and have a seat, please. Lastly, and in addition to our mission in oncology, we are proudly announcing EOS dedication to sustainability and boosting environmental responsibility. We are adopting 6 key steps for sustainability. First, solar-powered charging station, digital materials, plantable pencils, gender ratio on speaker panel, plastic bottle-free initiative, and sustainable booths in the exhibition area, as we are categorize booths into 4 levels: disposable, bronze, silver, or gold, based on the extent which materials are reused or recycled. Awards will be distributed to the gold level booths at the end of the exhibition tour. Now we have a slide, I think, for Eco Champion slide. I think we have it. This is the last. So now I want to thank you all for being with us today. I want to say that I'm so happy that I am with you here, and I am so honored that I am with this distinguished figure, Professor Humaid, Dr. Amin, and Dr. Noura, and the other distinguished healthcare. Thank you so much, and let us now go for our conference to see the exhibition outside for the tour. And thank you, and we will meet you, inshallah, on 26th of October for our campaign, Stronger Together. Don't lose hope. We are standing by each other, and we have to win the battle of cancer. We are fighters. Thank you so much. Thank you.
Assalamu alaikum wa rahmatullahi wa barakatuh. We'll resume now our second part of today, and we kept this part for after lunch because this is a very important session which highlights the research activities across the region. We will be listening to 3 top abstracts. We received more than 53 abstracts from across the MENA region and also from Europe, and the abstract committee selected top 3 abstracts. Will be the clicker, please, on the, if you can, next slide. So we have Dr. Fuad Atiyah from Lebanon, Muhammad Afif from Egypt, and also Dr. Shakzada, who is a 4th-year medical student at Rashid University, Mohammed bin Rashid University. So we'll be listening to their presentation, and then the committee, Dr. Saeed Hamad is here, Dr. Aida and myself will decide who is the first, second, and third. The first prize will be 10,000 dirham, and second is 5,000, third one is 3,000. And I would like to thank our sponsors for their support to make this generous awards, which is the highest in all the conferences here in the UAE and the region as well. And again, this just to push the envelope to get our students and trainees and also cancer researchers to acknowledge and also to be acknowledged for the contribution for cancer research. First, we'll have Dr. Fuad Atiyah, who is a medical student at St. Joseph University, Beirut, who will be talking or discussing association of CSMD3 mutation with response to immune checkpoint inhibitors. Can we have him online and start presentation?
Hello.
Hello, Dr. Fuad. You can start.
Okay. So, hello, my name is Fouad Atiyeh, and I am presenting our research today from Lebanon, entitled Association of CSMD3 Mutation with Response to Immune Checkpoint Inhibitors, with my colleague, Dr. Mark Boutros and Dr. Hampi Kouri. During the last decade, immune checkpoint inhibitors have changed the way we manage cancers, with an increasing use in many clinical trials and approvals for most cancer types. Despite its recent popularity, many cancer patients do not actually benefit from immunotherapy. To be precise, only about 30 to 40% of patients present a long-lasting clinical response. Moreover, patients who do not benefit also experience many severe side effects. There is also a considerable financial toxicity, with about 20 to 30,000 US dollars per month as the cost for treatment. So for all these reasons, there is a need to find an optimal biomarker that can define which patients benefit most. There have been a lot of approved biomarkers such as PD-L1, TMB, and MSI, and also experimental ones such as microbiome and circulating biomarkers. However, all of these biomarkers present many limitations. For example, PD-L1 can only be done when tissue biopsy is available, with the problem of tissue heterogeneity. Moreover, PD-L1 cutoffs can actually vary depending on which kit is used, further affecting which patients are labeled as responders or non-responders. Thus, we should look for a biomarker with constant parameters, and it should also be detectable in liquid biopsy. MSI is limited to a couple cancer types, with varying cutoffs between different detection methods. And so, to develop a new marker, it should be actually very common and applicable to all types of cancers. Now, for TMB, there are no standardized measurement methods, and it presents a high cost. Therefore, if we want to determine a new marker, it should be convenient and accessible. Now, gut microbiome might seem promising, but the evidence is weak and variable across studies. We should therefore try to find more robust clinical and biological evidence for our new biomarker. Another prominent biomarker is RNA expression. However, the latest research has shown that RNA is unstable compared to DNA markers. Another biomarker, circulating markers such as ctDNA, have been proposed, but they also show low stability in circulation with no reliable large-scale studies. Now finally, somatic mutations might seem like the best option. However, past studies have been limited by low sample size and they were underpowered. Therefore, there is an unmet need for a new biomarker that fulfills all of these criteria. In order to do that, we analyzed the TCGA pan-cancer cohort, which contains 33 different cancer types, and we included 11,000 patients in our study and more than 70 publications in the past decade. And thus we got the clinical data, somatic mutations, mRNA expression, neoantigen and immune abundance. So now the clinical characteristics of our study. You can see the cancer type distribution, sex, overall survival and treatment distribution, and cancer stage distribution. And so we looked at the data and chose CSMD3 as our potential biomarker, which has not been investigated before in pan-cancer studies and is mutated in 21% of cancer patients. It is indeed a common mutation in a lot of cancers, as we see here, with CSMD3 being 40% mutated in NSCLC and melanoma. Besides being a common mutation in many cancers, CSMD3 is irreversible, like all somatic mutations. It has also the advantage of being detectable in liquid biopsy, which is very convenient. CSMD3 mutation is also very convenient to detect through targeted gene panels, which are cheap and have a rapid turnaround time. Now, having determined CSMD3 as a potential immunotherapy biomarker, we need to demonstrate a high level of biological and clinical evidence. However, in order to do that, we should understand how immunotherapy actually works to see if CSMD3 can actually predict response. So, when cancer progresses, TMB, which is the sum of all mutations in the DNA, increases. The resulting proteins of these mutations are called neoantigens, and they too increase in parallel with cancer progression. After that, the neoantigen is presented on the MHC, which binds to the T cell receptor to activate lymphocytes. However, the PD-L1 complex inhibits the immune reaction, and we thus need to send an anti-PD-L1 or the anti-PD-L1 antibody. After that, the immune cells are free to attack cancer cells by releasing interferons and other cytokines. However, this is a small snapshot. Actually, many immune cells are attacking the cancer through different complex mechanisms. So, to study the role of CSMD3 as a potential biomarker, we should investigate each mechanism of immunotherapy response. So, we should start with the immunomicroenvironment, interferons, immune checkpoints, and finally TMB and neoantigens. So let's start with TMB. We calculated the sum of all non-synonymous mutations, and we found that TMB was much higher in the CSMD3 group compared to wild type, with a p-value less than 0.001. Similarly, the CSMD3 group showed a statistically significant increase in neoantigens compared to wild type. After TMB and neoantigens, we compared the RNA expression levels of immune checkpoints, T-cell receptors, and interferon genes, and we found that all immune checkpoints were increased in the CSMD3 group. So, PD1, PD-L1, PD-L2, CTLA4, LAG3, and many others were highly increased. Also, T-cell receptor genes were all expressed at higher levels in the CSMD3 arm. Now, let's look at multiple interferon and cytokine genes, and they were all significantly increased in favor of CSMD3. Now, our final biological analysis focused on the tumor microenvironment, which can be classified into 4 types based on the expression of PD-L1 and CD8 lymphocytes, as shown here. The first group, characterized by positive PD-L1 and CD8 expression, represents the best potential response to immune checkpoint inhibitors. And we found that CSMD3 mutation rates were higher in this group with the best response, while lower mutation rates were observed in the second group, which had the worst ICI response. However, we did not limit our analysis only to CD8 lymphocyte, but evaluated all the possible immune cells implicated in the tumor response. So we calculated a total immune score, and we found that a higher proportion of immune cells in the CSMD3 group were present compared to wild type. Now, we have presented a lot of convincing biological evidence. However, that is not enough to say that CSMD3 can be clinically used as an immunotherapy biomarker. We need to clinically validate this marker and observe a survival benefit. So, we needed to find a cohort with a large sample size where all patients were treated with immunotherapy to validate CSMD3. And thus, we chose the Vanderbilt University Cancer Immuno cohort, which contains more than 20 trials of immunotherapy. So we can see here all the cancer types and the treatments included in this cohort. And then we wanted to see, first of all, immunotherapy response. So we wanted to see if the tumor is more likely to shrink with immunotherapy if CSMD3 mutated. So here are the characteristics of the patients included. And we saw that there was a rate of complete and partial response that was much higher in the CSMD3 group compared to the wild type group, which actually showed progressive disease. So the tumors are more likely to decrease in size after ICI if CSMD3 is mutated. Now let's see if there is a progression-free survival benefit. Here are the characteristics, and we can confidently say that there is a statistically significant PFS benefit as seen here with 0.5 hazard ratio. Now what about overall survival? We adjusted overall survival to age, and we similarly found a clinical benefit. Finally, we are proud to declare CSMD3 as a potential biomarker for immunotherapy that is mutated in most cancers, easy to detect, and is backed by robust biological and clinical proof. This is the first CSMD3 pan-cancer study with consistent results across genomic, transcriptomic, and clinical analysis. There is also potential for CSMD3 integration in scores and algorithms. Nevertheless, our study is limited by heterogeneous ICI cohorts, and there was no investigation of underlying mechanisms and signaling pathways behind CSMD3. You can find our references. And finally, despite all the hardships and obstacles we face in our beautiful country, we are proud of the achievements of the Lebanese people and honored to be part of this resilient community. Thank you for welcoming us and giving us the opportunity to present our research at the 2024 5th EOS Conference. Thank you.
Dr. Fahd, can you hear me?
Yes.
Presentation is great, but actually we're way too fast for us. Can you please go back to the table which you highlighted your own data? We just want to have a look at the data about the variables that you included.
At the Vanderbilt Immuno table, yes, I can do that.
And this represents your own data, correct? The second part.
No, this is a data
the second part.
Yes. So I'm sorry if it was too fast. We went to databases, and we found a database in the Vanderbilt University. So they took 20 studies, 20 immunotherapy trials, and they combined them into one.
Okay, can you go to that table? Show me the table.
Yes,
this one. Let's just have a look here.
It differed between the response and the PFS. So depending on which data was available.
No, but this data is your own data, correct?
No, this is from the Vanderbilt University. They grouped 20 different trials, 20 international clinical trials. Okay. They grouped them together, and they made them homogeneous, so they removed anything that could disrupt the data.
Okay. Dr. Sayed, Dr. Aida, any questions?
Yes, I do have a question. First of all, thank you so much.
Dr. Mike.
Yes, thank you so much. This was a very important topic, and we continue to look for the best biomarker to identify responses to immunotherapy. So in your, I've noticed that you accumulated the full spectrum of cancers in your cohort. So the responses were not specified, because we know different types of cancer has different immunophenotype and different responses to immunotherapy. So can we generalize these results on all tumor types? I feel like we have to be more specific.
Okay, I completely agree with you. Due to the limited time we had, we did a sub-analysis for each cancer type. So we did a sub-cancer analysis for neoantigens, and we saw that neoantigens were more increased. Considering survival benefit, more increased in all cancer types. Now, for survival benefit, we found that it was mainly in NSCLC, renal cell carcinoma, melanoma, and esophageal carcinoma. For the rest, the clinical cohorts were too small to make a conclusion from that. But from the robust and big cohorts, we could make a statistically significant overall survival. So this is a great starting point for this biomarker. However, I totally agree with you that it should be evaluated in bigger cohorts for each cancer type. But there is a definite potential considering the biological evidence. So TMB and neoantigen were all increased for each different cancer type. So we analyzed for each cancer type alone. But we did not include this in our study because it would take a lot of time.
Thank you very much. This is Dr. Hamad here. Just a few questions. Just tell us and the audience as well, what is CSMD abbreviation used for, so that we know a bit more. And the next step, what is your next step after this? How are you going to take this forward? Are you planning to do any further research on this? So any future plans?
Okay, thank you for this great question. It is actually abbreviated as Kappa and Sushi 3 gene. So CSMD is actually a gene that was found out, it had a correlation with autism, first of all. And then we by mistake, we were looking at the data and we found that it was so common in cancers. However, there was very little studies to it. So it was actually a gene that was studied in neurology more than oncology. But it seemed interesting having such higher rates of mutations in cancers. So we tried to include that. Now, for further studies, maybe we're trying to do more, let's say, preclinical studies, so actually to understand which pathways are actually increased and which pathways are actually activated, and maybe go from that way, we can select better patients, or maybe in a futuristic way we can implement AI algorithms. So the way I see it, that maybe it's not CSMD3 alone that will be a key to defining patients. Maybe we'll take 5, 10, or 20 genes, create a panel with AI, and that gene will actually be way more personalized than PD-L1. So that's how I see maybe it will be implemented in the future, in the 10, 20 years when the targeted gene panels will actually be cheaper. Thank you for your question.
Thank you so much, Doctor. Can we go to the next speaker, please? And the topic is the case of investment in C/CA and EMRR. Dr. Mohammed Afif from WHO East Mediterranean Regional Office, Cairo. Welcome, Dr. Mohammed, and the mic is yours.
Hello, good afternoon, colleagues. Thank you so much for organizing this beautiful event and for having me with you here. And it's a very good opportunity, although after lunch is not always the best time to have the presentation, but we'll try my best to make it a light presentation regardless of the happy topic that I will be presenting about investing in women cancers in the Eastern Mediterranean region. Our estimations at WHO tell us that we believe that every 2 minutes a woman dies because of cervical cancer worldwide. So if we pause for a second here and think from the beginning of the sessions in the morning and the opening ceremony of this esteemed conference, how many women have lost their lives to cervical cancer worldwide. And in our region, it's different than the global situation, but still a very serious one, because we estimate that every hour we lose a woman to cervical cancer. And the issue is that cervical cancer now, with the developments in medicine and technology, is a largely preventable cancer. But if we do not take action, we foresee that by 2050, if no action is taken by governments in the region, and this is specific to the Eastern Mediterranean region, a woman would die every 15 minutes because of cervical cancer. But what are we doing at the global level to address women's cancers in general? Already it's high on the agenda of policymakers, and in the World Health Assembly there are several resolutions and agreements that were signed by ministries of health worldwide, including the ministries in our region, as it relates to primary health care, to research, to quality of care, to technologies, and to social determinants of health. which affect big time the access that women has to these services in our region. So it's already there at the global agenda. And also we have two key global initiatives, one dedicated for cervical cancer and another one for breast cancer that we are trying to regionalize and promote at the regional level from our side, and have already contextualized the global strategy for cervical cancer elimination to become a regional strategy. And the first intervention that is promoted in this strategy is to have HPV vaccine introduced and rolled out throughout the region. In order to supplement the technical evidence that's available on the efficiency and effectiveness of HPV vaccination, we are complementing this evidence with economic arguments. So ministries of health and decision makers and ministers of finance, they make decisions, important decisions regarding vaccination programs and financing those programs. So we worked with health economists and health financiers to develop the economic argument and to understand the return on investing in eliminating cervical cancer in line with the global cervical cancer elimination strategy. We looked at three elements in this study. We looked at the economic burden of women's cancers. We costed the interventions that are promoted in the global and the regional strategy, and we conducted a return on investment analysis. Three key interventions were looked at in line with the global strategy. The first was the vaccination with HPV for 12 years old girls, the diagnosis and treatment programs, and last but not least, the screening for cervical cancer. And we grouped the countries into three different groups according to socioeconomic indicators that are available to us. And we had the analysis that looked at the burden, the economic burden, and the distribution. For the health burden, our analysis showed us that by 2050, if no interventions are undertaken now to promote the agreed upon interventions to eliminate and to fight cervical cancer, we would have more than 500,000 women dying because of cervical cancer by 2050. For the economic burden, the analysis showed us that the cost by 2050 would mount for $67 billion if no actions are taken now and implemented in full force. And when we looked at the distribution, it gave us what we know as the iceberg phenomenon, because we only see the tip of the iceberg. And what we estimated that governments see, because these are the direct healthcare costs, is only 3.4% of the overall financial burden that's related to cervical cancer, and 96.6% the indirect costs are not seen by governments. And this is a key message that we are trying to promote and to send to policy and decision makers on the need for investing in eliminating cervical cancer at the regional level. And when we looked at the health benefits, we looked at the cases to be prevented and deaths to be prevented as well. And you see from the graph that it is serious investment that will contribute positively to eliminating cases as well as mortalities that would result. And we estimated it by 2050 to be around 500,000 or more than 500,000 deaths that can be largely prevented if we invest in promoting the elimination interventions. The return on investment showed us very interesting and very promising outcomes that result from investing in cervical cancer elimination programs now. And we looked at the three pillars that we talked about earlier in the presentation and that are highlighted in the global and regional strategies regarding the vaccination, the screening, and the early diagnosis and comprehensive treatment. And it showed us, as you see on the slide, very positive return on investment results, especially for the HPV vaccination. We have the range from 2.2 to 6.2 because it's a different country assessment, so we have a range. For screening, it was 0.4 to 0.8, and for the early diagnosis and comprehensive treatment, reaching the 90% agreed upon as the global and regional target would go up to 11.5 times return on investments made in this area of intervention. And finally, what do we recommend as the outcome of these interventions and analysis is to significantly increase investments in introducing and scaling up HPV vaccination programs. Luckily, all the Gulf Cooperation Council countries have introduced HPV vaccination. We are working now heavily with middle income and low income countries in the region to introduce it, or at least to pilot test HPV vaccination programs, hoping that it can be financed and sustained in the future and introduced into sustainable financing mechanisms. We also recommend to look at it as part of the overall continuum of care. So the whole health system should be ready to promote the vaccination, diagnosis, and treatment in the different levels of the healthcare, primary, secondary, and tertiary. The third investment that we are calling for is to invest in data systems, because health information systems are at different stages of development in the region. Some countries have very well developed systems, others do not. So this is very key for informing program planning and development. And last but not least is to promote a comprehensive approach to women's health. We're trying to move away from the vertical programs that promote a single intervention and to look at women's health comprehensively, because in the end, it's a whole person that we are trying to improve health of the women in the region and beyond. Thank you so much for your attention and for the time dedicated for this. Thank you.
So thank you. This was a very good presentation. Let me ask you a few practical things.
Sure.
As far as efficacy, of course, there is no question, and we have data from the US at least in the last decade that it has made certainly big impact, not only on cervical cancer, but other HPV-related cancers. However, the problem in our areas, you know, in so-called third world countries, that this vaccine is still very expensive, and unfortunately many governments did not agree to sort of provide it to its people. So that's one point, is how are we going to overcome the costly impact of the vaccination at the mass media, you know? Because to be effective, you have to really give it to all eligible teenagers. You start at the teenage group.
Yes.
And the other part of my question, what about the negative things we hear every now and then? That, well, there is some cases of neurologic diseases that appeared maybe a year or two later that kind of make people really afraid to take any vaccine, especially after the COVID era and all the publicity of the negative effect of COVID vaccination, etc. So how do you defend those two things?
Yes, thank you very much. For the first point, that's actually why we worked on developing this investment case. But as you said, some countries in the region can afford it. Yes, it is relatively an expensive vaccine, at least at this stage. Maybe in the future they will develop more affordable technologies to develop the HPV vaccine. But for now, it's still, yes, a challenge to secure funds for vaccinating all the age groups. And you know, and also it's not only for girls, because ideally it should be provided for boys and girls in this particular age group. But gradually we are trying to promote it and also to identify with countries alternative financing mechanisms. Because I don't know how familiar the audience will be with the Gavi mechanism. This is a global alliance for supporting vaccination programs in developing and least developed countries. So at WHO, we are trying to work with Gavi to have global mechanisms to support countries introduce and to help them also to develop sustainable financing mechanisms. We know that it is not seen as a priority for governments. They have competing priorities, but we are trying to promote it as part of a women's health package, because in the end, this is a preventable cancer that we have now, and we truly feel very lucky that in this era we can prevent a cancer, and we have the technical and technological means to do it, yet we do not have the financial means to do it and to fulfill women's and girls' rights in this particular area. So this is one thing that we are trying to work with the Ministries of Health and Ministries of Finance to secure funding and to have also country-level case studies. So it can be presented to ministers of finance and those who make these important decisions. So they see that there is a return on investment in terms of saving lives. And we looked also for the economic returns. So we can present these to those who talk money, not health. This is the reality of life. So we show to them that it is contributing to economic development as well. It's not just something that we see it as a health strike for women and girls, but also it has a financial return for the government to invest in. The second point regarding the potential side effects and issues around COVID vaccine, we believe that this will continue forever. And we know that the COVID vaccine, it came out with certain limitations. And when WHO cleared it to be given during the global pandemic that we had, it was issued with this sort of disclaimer that it did not go through sufficient research, so it can be securely promoted, but it was cleared under certain emergency recommendations that are approved by the World Health Assembly.
Doctor, thank you so much. Just for the sake of time, we have to move on actually for the next presentation. Thank you, and stay with us online, please.
Sure. Thank you so much.
The last topic is being here on with us. Conserved rule of FOXC1 in triple negative breast cancer is parallel to FOXA1 in ER positive breast cancer. Welcome.
Thank you. I just want to see my slides. Okay. Thank you so much for attending. My name is Shazada Ibrahimova, and today I would like to focus on the study that we published about a month ago, which we focus on conserved role of FOXC1 in triple negative breast cancer. Sorry. I don't know if the pointer is working. Yes. Okay. So, sorry. So the main motivation for the study was that breast cancer is the most commonly diagnosed malignancy in women, and the incidence of breast cancer is steadily rising globally. So as many of you may already know, breast cancer, there are different molecular subtypes of breast cancer, with triple negative breast cancer having a very limited targeted therapies, and it's the most invasive and aggressive subtypes with the lowest survival rate. So recently, transcription factor FOXC1 has been identified as uniquely overexpressed only in triple negative breast cancer across other subtypes. So naturally, FOXC1 is a key player during embryogenesis. However, when FOXC1 is overexpressed, it drives different types of malignancy, including breast cancer. So during our study, we asked main questions: what is the functional role of FOXC1? What are genes FOXC1 regulates in triple negative breast cancer, how pathways are controlled, and what protein cofactors assist FOXC1 in triple negative breast cancer. So during our study, we used multi-omic approach where we looked at the different FOXC1 targets on the genome, changes in the transcriptome, and we also looked at the proteome. So we utilized CRISPR-Cas9 system to completely knock out FOXC1 gene in multiple cell lines of triple negative breast cancer. So when we knocked out FOXC1, we have observed that the proliferation is dramatically being inhibited across all the subtypes that have been used in the study. As well as the invasion and migration capacity, if you look at the panel, is also dramatically decreased in the absence of FOXC1. So then we have performed chromatin immunoprecipitation followed by the sequencing to identify the binding sites of FOXC1 on the genome. So this is how the data usually looks like. If we look at the peak, this is the binding site of FOXC1. So we mainly focus at the core binding sites of FOXC1 across all the cell lines that were used in the study. So having this data set, we have run RNA sequencing between FOXC1 knockout and the wild-type triple-negative breast cancer cell lines to identify the panel of differentially expressed genes. So when we had our ChIP-seq and RNA-seq data sets, we combined them together to know the true core targets of FOXC1 in TNBC. So we came up with this list, and we stratified the list by oncogenes and tumor suppressors. So in a nutshell, FOXC1 in TNBC suppresses these sets of oncogenes these sets of tumor suppressors in red and activate sets of oncogenes in blue to drive the progression of TNBC. We have also looked at the patient data with a KM plot and the genes, the 17 genes that FOXY1 upregulates in all cell lines of triple-negative breast cancer. When they overexpress, it results in a lower survival rate in the patient. So as transcription factors don't act alone, they need cofactors to assist their activity to drive the differentiation and tumor genesis. We have done RIME, which is a technique that is based on the mass spectrometry. And we identified all these proteins that assist FOXY1 in TNBC. And what was interesting to us, FOXY1 interacting with key transcription factors that drive luminal breast cancer progression. So we wanted to see more into a luminal breast cancer to see how it resembles the FOXY1 activity. So FOXA1 and NR2F2 that it also interacts with FOXY1 in TNBC form a complex that would make the chromatin more accessible. And when the chromatin is more accessible, estrogen receptor alpha binds on that open chromatin and drive the luminal breast cancer further. So when we looked at the FOXY1 targets, they are having very high commonalities with FOXA1 targets in different subtypes of breast cancer. Sorry, I know it's a busy slide, but we then went back to our ChIP-seq data and we looked at the core binding sites of FOXY1. So what was interesting that core binding sites of FOXY1 are also present in luminal breast cancers, but in luminal breast cancer, they're occupied by FOXA1, where FOXY1 isn't expressed. And on the other panel, you see the binding intensity, and the binding intensity is only the highest at the core sites, either FOXY1 in TNBC or FOXA1 in luminal breast cancers. So to conclude, what we have found that the core targets of FOXY1 are differentially expressed across all different subtypes of breast cancer, and it has a prognostic and therapeutic value, as well as the FOXY1 is a master regulator in TNBC, and its role mirrors by FOXA1, but in luminal breast cancers. And I would like to thank the organizers for the event, and I also would like to thank Al Jalila Foundation and Mohammed bin Rashid University of Medicine for funding this research and my PhD, and also Dr. Fahad Ali, my mentor, and our lab, and also want to thank Dr. Revati Ramachandran for leading this study. Thank you very much.
Thank you so much. Actually, impressive work, and it's a novel marker that may have therapeutic implication in the future. So, do you know of any lab that have started developing targeted agents, that utilize the same pathway?
So, actually, we are doing it right now in our lab. So, since I know there are so many protein coding genes, but there's only 1,200 transcription factors, and they're a very strong initiator of the transcription. So we cannot really directly target it because there can be a lot of off-side effects. So what we're trying to do, we're trying to break the bond, the interaction between these cofactors right now in the lab. So that might be the option, that might be the key. Yeah.
Thank you. Dr. Shakhzadeh, and I think Revati and Fahad, if they are here, for this excellent work. We work together. Just a question from the team itself. What's the next step? Where are you taking this forward?
So at the moment we have a data, we haven't published it yet, but we are looking at the chemotherapy resistance. We know that the triple-negative breast cancer have a very high rate of the chemotherapy persistence. So we have identified that the FOXY1 actually results in chemotherapy persistent, a specific chemotherapy agent. So we're looking into mechanism, why does TNBC is so tolerant to chemotherapy through the FOXY1 perspective. Yeah.
Thank you.
Okay, thank you.
Thank you so much. Thank you.
So it was very difficult to choose the top 3 from out of 53 abstracts, but certainly that, the knowledge that, has been disseminated is outstanding. And we decided that, the first award will go to Dr. Shakzada and her team. And the second award will go to Dr. Fuad Atiyah. And the third award will go to Dr. Muhammad Afifi. I would like to invite the entire team actually to come over, not only you, because it's a teamwork. So please. Yes. So thank you, Mabruk, for the winners, and we'll inshallah send you your awards through your preferred way of communication, inshallah. Now we'll be moving to the next session, and would like to introduce Professor Nuhad Ibrahim, who is our professor from MD Anderson, coming all the way from Houston. So thank you for being with us today. Professor Ibrahim does not need much introduction. He's an expert in breast cancer. Myself and Dr. Aida, we both had the pleasure working with him very closely in his clinic at MD Anderson. Besides his knowledge, experience, his compassionate skills in dealing with patient and the way he approached patient actually made us, feel more confident in taking care of patient with breast cancer. He trained in Lebanon, and then he moved to Houston long time ago, not very long time ago, but he is one of the prominent physicians in US when it comes to breast cancer. Would like to welcome him, and I would like to thank him also coming all the way to give this lecture and be with us during the event. He will be talking about refining new ways to care early HER2-positive breast cancer, a clinically oriented discussion. Welcome, Doctor.
Thank you, Professor Ahmed, and I prefer to call you Friend Ahmed for this nice introduction. And also, I want to thank Tony Abi Khalil and Rania Kafrouni representing Pierre Fabre, who allowed some support to coming here to present some data. And I want to start from a very summary that I got from this morning, saying together we are stronger. Indeed, and why we need to be stronger is because if you look at the statistics, at least of 2022, there were over 2.2 million newly diagnosed breast cancer globally. And during the same year, over 650,000 women globally died of breast cancer. Out of those who were newly diagnosed, over 650,000 are or expected to be ER positive and HER2 positive. And certainly early treatment of these patients in HER2 positive and ER positive will help reduce the number of deaths of the year. And this is how I'm trying to move these slides. how do we move the slides? Here it is. Yeah. And the advances are indeed incremental with the introduction of anti-HER2 therapy. The backbone is trastuzumab, and we see that over the time it really improved the rate of recurrence and the overall survival. I'm trying not to preach to the audience the benefits of the anti-HER2 therapy, but going through, because I want to move quickly to see how we can get the patient on board with us to be treated in a better way. There are many agents that are used against anti-HER2, and here in this diagram I show a list of those agents. Most of them are in a clinical practice and approved. And here are the most recent studies that proved to be very effective in improving the disease-free survival and overall survival in early breast cancer patients. As a quick summary, we noticed that pertuzumab and pertuzumab indeed help improve the overall survival of patients who receive it in the adjuvant setting, particularly in patients who have node-positive residual disease, and also the introduction of TDM1 in the adjuvant setting continue to improve the intent to treat invasive disease-free survival significantly by about 14%, and the overall survival also again impressively by 4.7%. And this benefit were across the board, whether the patients were ER positive or ER negative. This is just like a memory refreshment for you. XNet that introduces neratinib in the adjuvant setting also served to improve further the benefits. And let me get a little bit more into details here, because it remains to be very underutilized, and really we do not understand the reasons for that. The intent of this treatment that used neratinib after trastuzumab in the adjuvant setting with intent to treat data, which include patients whether with PCR or non-PCR patients after neoadjuvant therapy, by about 2.3 to 2.5%, both for the invasive disease-free survival and the overall survival. About the pre-planned subset analysis of the data of patients that were hormone receptor positive showed that the patients who received the neratinib within 1 year, not longer than that, within 1 year of finishing trastuzumab, indeed did very well in terms of improvement of the invasive disease-free survival at 5 years of 5.1%, and overall survival of 2.1% at 8 years. And the same applies with the invasive disease-free survival as well. The numbers hold very, very well, as well as the distant disease-free survival. And here we're talking about 7 to 9% of the patients. Good enough that it entered the algorithms both in Europe and the United States, documenting that the patients need to receive neratinib, particularly if they are HER2 positive and hormone receptor positive, and most importantly is to start it within 1 year from finishing trastuzumab to be able to capture these benefits. And here is the problem. In one of the real-world data suggested that while 60% of the patients who are not positive continue to receive pertuzumab and Herceptin adjuvant therapy, only 30% did go with neratinib. It's a big difference, although the benefits are very, very clear. And this is, we don't know why. We know the data, we by heart, everyone in this room know the data by heart. It remains how we may transfer this data to the patients, or how the patients would look at these issues. The other benefit of neratinib, which is closer to my heart, is its effect on the CNS metastasis. It's closer to my heart because it's one of my research pathways that I do for a very long time, but also we know that, and we see it in the clinic, we think many times that probably we cured this patient. Now she's cancer-free for 10, 5, 15 years, and then she comes with a brain metastasis, and here we lose her quickly. So in my opinion, the head of the monster here is the brain metastasis more than anything else, because we continue to develop drugs for systemic disease, and we continue to improve patients' outcomes, but very little is being done to brain metastasis. And here you go. We treat these patients with adjuvant anti-HER2 therapy, and brain metastasis remain the risk factor that hanging over our head. Particularly so, I would draw your attention to Catherine trial, where CNS events represented 7% out of the 15% of the patients who were observed with distant metastasis. This is a huge number, and many times, to me, brain metastasis can be equal to very immature demise of the patient. With the narrative studies, we noticed that there are significant improvement in delaying or preventing CNS metastasis, and here we see that this is can be up to 2% in overall data compared to prior adjuvant therapy with anti-HER2 therapy, and whether the patient achieved PCR with neoadjuvant or did not. And these observations led to the trial looking at neratinib and capecitabine with lapatinib and capecitabine. However, one of the patient's inclusions were stable brain metastasis, and the secondary analysis, pre-planned secondary analysis of these patients showed that the time to progression of the brain metastasis on this study, we know that established brain metastasis, stable brain metastasis, to prevent its further progression was prolonged from 8.3 months to 12.4 months, about 4 months. Not too long enough, but at least will give us the idea that this combination cross brain-brain barrier and help the patient at least partially. Another study looking at neratinib with TDM1 as well, they looked at the brain metastasis issues, and here it shows that the overall response rate in brain metastasis of patients, it's about across the board of the different cohorts of this study that I thought I did not have enough time to go through details of it, but it shows that this overall response rate is about third of the patients benefited from this combination. So after all, what is neratinib? What are we talking about here? We're talking about a small oral molecule that is a pan-HER2 tyrosine kinase inhibitor that blocks HER1, HER2, and HER3. It also crosstalks with the ER-positive tumors, which generally get upregulated with the HER2 signaling. But when we block the HER2 signaling, in addition to blocking the ER signaling, this will have an additive effect in the control of the disease. Maybe one of the obstacles for not using this drug is its well-known side effect, which is diarrhea. And early on, after this drug was approved in the US, and also we noticed that during clinical trials, that diarrhea can be a main source of patients not willing to take it and drop the drug away. But with a controlled study, which was also pioneered by one of my colleagues at MD Anderson, showed that if we pre-medicate the patients with loperamide and give also the drug, the neratinib, at a lower dose and gradually increase it. That is, we start at 120 milligrams for 2 weeks, then we'll go up to 160 milligrams for 2 weeks, and then starting the following month, we go to the full dose of 240 milligrams per week. This regimen has showed very good tolerance with significant improvement in the diarrhea without affecting the clinical effect of the drug. So the issue of diarrhea has been well controlled so that patients who take it can capture the additional benefit of improving of disease-free survival and overall survival, and also potentially reduce the effect, reduce the rate of CNS metastasis. This drug is being now on guidelines of several agencies across the world, particularly in Europe and in the USA. Now I want to come to another issue that will help us address the third component of this talk, which is how patients look at taking more drugs and why they want or do not want to take more therapy for their cancer. And most of this is coming from real-world evidences that are published. And this real-world evidence is usually, in contrast to randomized clinical trials, they look at groups of patients that usually they are not looked in details in randomized clinical trials. For example, older patients, perimenopausal patients, men for that matter, CNS, patients with comorbidities, and not to mention here also the social and the financial situation of the patients. Earlier we came across the issue of vaccination and its expenses, and this is what now we term it as financial toxicities. There is no clear answer how to handle it, but definitely we need to benefit from the data. In the written real-world data are many, but I am coming across a couple of slides from the Eleanor study only to highlight a couple of things. First of all, the disease profile of patients who were addressed in this study, looking at why patients may or may not need more therapy and how they look at it. It shows that about 67 or 68% of the patients were more than stage 1 and non-positive or non-PCR. Really, they are the high-risk patients, and these are the patients where we were more open to talk about additional therapy. And among those patients as well, and these were mainly French patients, they wanted efficacious treatment in about 63%. Patients' preference of taking more therapy because they don't want to leave any stone unturned were 8%, and physicians' preference is 11.8%. And this diagram really hits me in two ways. One, the high percentage of patients that they're looking at efficacious treatment and willing to take it, and the other one is that the patient's preference of giving more therapy to help the patients is very low. I don't know why. Myself, I might forgot one time or the other to discuss one issue for the patient, but definitely it is not a perfect world, and here we need to put some effort. We are not talking about a prescription. We are not talking about a patient. We are talking about the patient's perspective here, and we should keep in mind that when we talk to these patients about these issues, most of the time they are open. There could be some cultural issues. The French patient is different from the American patient, is different from the Japanese, or from a Middle Eastern patient, but definitely, in my opinion, they are open for this discussion. Considering all the above, again, the German group is now listing, not now, for a while, they are listing the neratinib on the guidelines too. So when we meet with the patients, and I find this study very revealing because it points out several questions that are very, very relevant to the patient, and divided the patient into really three groups. The one in the dark blue says, no information preferred, fully reliant on the healthcare, pretty much like some of the Arab patients. Whatever you say, doc. And the other group are fully involved with need information and decision preferred. These are 41%. These are pretty much like the American patients. They come with Dr. Google, and here you go. They put you on the grill instead of giving you the chance to educate them. But it takes time. Sometimes it takes more than one visit to be able to convince the patient what is her interest. And 55% of the patients, they like the information, but after all, I think when they digest the information, they will say, doctor, if you prefer this, I will do it. So basically, majority of the patients are open for discussion, and we need to take our time. It is time consuming sometimes it is nerve consuming, but after all, our job is to salvage these patients, because we know one day they may succumb to problems by shorter survival or from a brain metastasis. So what are the main items of discussion with these patients? Usually they wanted to know about recurrence. Pain is a huge issue. Am I going to have pain when I have a recurrence? What are the side effects of the management? And even side effects might be bad, but the more you open about it, but not only be open about it, be also offering what you are going to do about these side effects if they happen. It makes the patient more comfortable. Patients now ask you more about immunity related, because they hear a lot about immunotherapy and its side effects, and they want to make sure they are not going into that route. Quality of life is very, very central for most of the patients, and some of them, at least in the United States, they ask about what other alternative medicines. Is there anything that they can do without going into the doctor's intervention? So we need to adopt a communication word with the patients, be open. If you see that the patient is not taking a decision in a way that you favor her to do, I always offer her to meet again. The patient needs time to digest the issues, particularly when they need to take longer therapy, because most of them, they see, oh, I'm done with Herceptin, or I'm done with the DM1, I'll be finished. So don't leave it to the last minute to discuss this issue. We start introducing neratinib, even like probably after surgery, when we know that she has a residual disease, and we are going to give her more maintenance therapy with anti-HER2. And at that time, we tell her, you know what, when you finish this 1 year, we are going to talk to you about another pill that will increase your benefit, having in mind neratinib. We provide her with information about the drug and prepare her mentally so that when time comes, she would be ready for that. So when you look at the patients and the data and development of drugs, there is always the known four phases of drug. We know the real-world data, but also there are circumstantial issues, like what are the patient objectives? She tells you, oh, I'm 90 years old, I'm done, I don't want to take anything. And another one tell you, I'm 40 years old, I have two kids, I'm ready to do anything that it takes. What would be her source of information? Dr. Google is our headache in the clinic, but also her neighbor, her taxi driver, or anybody else can give her wrong perception of anything else. And also, we sometimes are the problem, because many times we follow up the one patient experience, one patient series, and you only remember the worst case scenario that you came across, and say, oh no, I'm not going to go through it again, it's going to generate a lot of phone calls, I'm not going to deal with it. Unfortunately, I admit that this is bad, at least for me, but we are human beings, and we need to fight these issues and always pursue the patient's benefit. So what are the major, I have still a couple of more slides. According to this study, the main questions on the patient's mind, according to study were, where would I receive a treatment with the fewer side effects? What does it mean if a slightly greater chance of cancer recurring or worsening? When I am doing everything I can to overcome cancer, even if the side effects are difficult to tolerate, and what allows me to avoid unnecessary treatments. These are the major issues that the patient are concerned about, and this is displayed in this graph here, the bar graph here. And this represents the patients from 3 different countries of the world, and they are really very real questions. So the patients are very reasonable, and they want the doctor to work with them about it, but it is working with the doctor is not only one event, meeting with her for 2 minutes in the clinic. It's a continuous process. It's an educational process. And this reminds me, when I was a fellow, my mentors used to say at those times, you know, you start talking about hospice care or autopsy from the first day you see the patient. And now I would say this is not relevant, but also more relevant. You start talking to the patient about what are your future next steps. Number 1, you gain the patient's confidence that you are with them, you want to help them. And number 2, you are preparing them to get more medications, longer medications, but to their benefit, and never surprise them the last day about more options. I would stop here, and I hope that I helped with some ideas that I gave today, and thank you very much. Actually, I had a case story, but you all know it. I covered it all. Yes.
All right. Thank you, Nuhad. My question, so this drug, you know, I was in the US for many years, and I was actually in a phase 1-2 trial more than 15 years ago. So it's not a new drug, but it was searching for a niche or an approval. And unfortunately, when we had the approval based on the Extenet trial, this was before the era of TDM1 and before even pertuzumab even just started to come into place. So one criticism we always hear, how do you know the benefit is sustained when you already have the data without any TDM1 and 80% did not have exposure to pertuzumab even? That's one. And second, in the metastatic setting, even where it's approved, again, unfortunately, we have so many approval in the HER2 space where neratinib is pushed backward mainly because of the higher potential GI side effects. You know, it always carry with it the diarrhea, etc. As patients are afraid, and same thing you mentioned, if you come and tell a patient after a year of being on therapy, oh, by the way, I want to give you this pill, but it will do this and that. So I absolutely agree with you. If you had neratinib in mind, don't leave it till after 1 year to tell the patient about it. But main question to you, how do we convince ourselves and then the patients that yes, even if you had pertuzumab and even if you have TDM1, we still think neratinib is important to you?
Very nice question, and I hope I have a couple of more minutes, Aida, to answer this, maybe less. Now, we cannot, you know, care development is a continuous curve. And now we all, for example, give pertuzumab and trastuzumab in the adjuvant setting, but we don't know if it is better than trastuzumab alone. But we jumped on it, but there is no clear data to say it is better because it was against placebo. And the same thing with TDM1. TDM1 was compared to trastuzumab, but not to trastuzumab and pertuzumab. So where do you put this? And number 3, we know that neratinib as a single agent after trastuzumab gives you the great data of improving invasive disease-free survival and overall survival. And also it showed that it is Definitely better than, for God's sake, better than capecitabine and lapetinib, which I never believed in it, honestly. And it also showed that it is very effective when it is combined to the DM1, but it's never compared yet against to the DM1 alone. So that will be, to answer your question, that will be the next step. Actually, I discussed this issue with Pierre Fabre, and they are interested in doing studies like this, at least in the USA. But still, you know, it's still in its early discussions. But no doubt about it, we have several drugs. I'm not negating that one is better than the other, but I know that TDM1 did not prevent CNS metastasis or reduce CNS metastasis, but I know the combination with neratinib was very successful.
Thank you so much, Prof. Ibrahim. My question, actually, neratinib, I remember at MD Anderson, there are many clinical trials with, specifically for inflammatory breast cancer, where they actually incorporated neratinib. I left before I have come to know any result, and I think they are still recruiting because IBC is a very rare disease. And I mean, there's going to be a challenge. But my question is, now with the plethora of options that we have, I mean, in the early setting, I mean, we don't know in the future, maybe trastuzumab deruxtecan is going to come in the early setting. Where would you fit neratinib in the early setting? Which patient would you consider, or would you consider it at all? Thank you.
Yeah. Which makes my question easy to address is it does not contradict with any of the standards of care with anti-HER2 therapy for early breast cancer. They are all finished with what we call maintenance therapy, whether pertuzumab, trastuzumab, whether trastuzumab alone, or TDM1 for 1 year. And neratinib falls in that period of time. When you're done with everything, add neratinib. To who? To the patients who did not achieve pathologic complete remission after neoadjuvant, exactly the same indications for TDM1 or Herceptin Perjeta. So whenever you think of continuing these patients on these medications and the patient is hormone receptor positive, then neratinib falls in. The only issue for the patient for rejecting it, because most of the time, and I witnessed it, if you present it to it later in the course, because mentally she is prepared. I'm going to be done in June. And then you come in May, tell her, you know what? You still have 1 more year. Oh no, I'm done. But if you tell her earlier, I'm planning to do this, then they accept it. And they accept it. For the side effects of diarrhea, although there is now with the modification of the schedule, with the gradual introduction of or escalating the dose, and also with using prophylactic antidiuretic therapy, honestly speaking, Hassan, it's not worse than abemaciclib. But you still give abemaciclib to everybody, right? Okay, thank you. Yes, Falah. You know, at the time you're going to start, the patient is an ED, obviously. She does not have any, but prior to that, is there any marker? And I think this is what you wanted to see. If there is any marker to select neratinib, unfortunately, there is not. Only HER2 positive and ER positive. No, we don't have this information, no.
Thank you, my dear Professor, for your excellent presentation. We're facing some cases with single metastasis in the brain with who received first-line anti-HER2 new.
There's a little echo. Can you pull it up?
We're facing some cases with the progression upon first-line anti-HER2 new with single brain mets. You recommend biopsy, surgeries in biopsy, or NGS for treatment? And if still anti-HER2 new, what is your recommendation?
You mean before progression, before evidence of metastatic disease, right?
Anti-HER2 new positive, but progress upon first line.
Progressed?
Yeah.
Okay.
Single brain metastasis only. I have some cases.
With brain metastasis only?
Yes.
We know the zolidatokitinib and Herceptin proved to be very effective. There are more protocols than standard of care for that matter. We know as a standard of care for patients like this in HER2 can be very effective in trying to control these patients.
Without pathology?
Sorry?
Without pathology?
Without histology?
Histology.
Okay. Ideally, to biopsy the brain and metastasis can be very helpful, but we have clinical data, not pathological data, to suggest that the markers between the primary tumor and the brain metastasis, and this study was published from MD Anderson about 10 years ago, did not change. It means if they are ERPR and HER2, whatever in the primary, in the brain it remains the same.
But according
so we don't need the pathology to.
But according to ESMO and NCC guidelines, the biopsy is recommended in second line.
For the brain metastasis?
That's it.
It is sufficient but not necessary. I like it. I like that tissue to send them to the lab to do more biological research on them. But if I do not have the biopsy, I do not push for it.
But what about the NGS in this case?
Yeah,
liquid biopsy.
Yes, I would initiate the treatment without a biopsy. Liquid biopsy would not help me take decisions on the brain metastasis. Liquid biopsies may be important to detect any genomic aberrations that will help with the selection of systemic disease, like ASR1 or PIK3CA or things like this.
Just one question, please. Sorry, I'm a breast pathologist. So with the emerging of HER2-DX.
What?
HER2-DX testing.
HER2-DX?
Yes.
I think, in my opinion, it's a great test. And I have on the table a project to try to reclassify a HER2 disease based on HER2-DX. In my opinion, I think HER2-DX is showing that not all HER2 positive tumors are born equal. There are groups of patients who do much better on anti-HER2 neoadjuvant therapy. There is another group that we can de-escalate that in that neoadjuvant therapy. There is another group we have to do like what we do now. And there is a third group that they do not respond at all, and the response rate is not better than the traditional non-HER2 based therapies. In my opinion, the HER2-DX test is a very, very important test biologically. I had a letter of intent with a couple of drug companies. Both of them are nervous about doing those protocols.
But what's the criteria when we want to test for it? I mean, Oncotype DX we know, but what about the HER2-DX? Have they set up any rules or any? No,
actually, basically it talks about risk of recurrence and risk of response, but it does not give you more information than that. I was hoping to take it further beyond that point in time, but again, we do not have non-industry support for that study.
Thank you. Thank you so much.
Thank you.
Professor Nahad Ibrahim, and I would like to welcome and introduce Dr. Saeed Hamad, who will be moderating the next session, who is the head of Oncology in Dubai Hospital, Dubai Health.
Thank you, Prof. Let me welcome Dr. Mark Viril, all the way from Newcastle. He graduated from Cambridge and then trained in Royal Marsden. He's the chair of the medical oncology at Freeman Hospital Cancer Center and has interest in breast cancer. He'll be talking today about the role of Verzenio in metastatic breast cancer. Dr. Mark.
Thank you very much.
Dear colleagues, my name is Jade Jayan. I'm the Medical Director for Oncology South Africa at Eli Lilly and Company. Welcome and thank you for dedicating your time to attend this meeting organized by Eli Lilly. At Lilly, we are committed to following both the letter and the spirit of the laws, regulations, policies and procedures that govern the pharmaceutical industry. We would like to remind you that today's discussion will be dedicated only to information that is consistent with the product label that is approved in our country. Any questions relating to unapproved drugs or unapproved indications, dosing regimens, populations, or other information not consistent with the PI will not be answered in this meeting, but forwarded to our medical department. Thank you for your understanding, and I wish you a good meeting, and I hope that the topics discussed today will bring learnings that will be useful for your clinical practice.
So, thank you very much for the invitation. I'm clearly very, very naughty because I need to be reminded to stay on label twice in the same day. So, this is a case-based discussion about the use of abemaciclib Verzenio in a patient with metastatic breast cancer and some of the evidence, some of which, of course, we saw early this morning when we were talking about ribociclib. And my disclosures haven't changed since this morning. So this was a lady who actually was diagnosed in 1999. She had breast cancer age 35. She had a very strong family history. In fact, she's got one of those really, really unusual family histories where there are both BRCA1 and BRCA2 in the family, and I've treated several family members. She had an 8mm grade 2 cancer, which was ER positive, and received chemotherapy. Now, I think that was quite aggressive at that time, but if you remember, around that time there were lots of different guidelines going around that said pretty much everybody should get chemotherapy, and we were miles away from things like Oncotype. She was subsequently found to be a BRCA2 carrier. Her father had had pancreatic cancer related to the gene. She had risk-reducing contralateral breast surgery and a bilateral salpingo oophorectomy. In 2015, so 16 years after her initial presentation, she noticed a lump under her arm, had a core biopsy, it was fat necrosis. She remained concerned, and in 2017 she had an FNA of a lymph node that showed what was described as granulomatous lymphadenitis. And 2018 she was still concerned, 2020 she was still concerned and was re-referred. Nobody was that convinced that there was anything going on, but she had what was described as a precautionary biopsy in which there was somewhat unexpectedly a grade 2 cancer, ER8, PR0, HER2 2+ without gene amplification. And the plan was to go in and clear her axilla after a staging CT scan. So this is the axillary mass that you can see quite clearly on the CT scan that was expected. But wasn't expected was all of these liver metastases, and she'd actually been having relatively regularly endoscopic ultrasound screening for her pancreas, so these were definitely new. So she was postmenopausal, lots of disease in her liver. Her liver function was slightly abnormal, but critically her bilirubin was normal. She would fit the ABC criteria for endocrine sensitivity, having completed her endocrine therapy more than a decade ago. She was ER strongly positive, as I said, PR negative, HER2 borderline. So she's probably, if you subtyped her, she'd probably be a luminal B. Now, prior to the CDK4/6 inhibitors, I think we would have all given all of these people chemotherapy. You wouldn't take a patient with big liver metastases and slightly abnormal liver function and given them an endocrine-based therapy. But when you actually look at the results of chemotherapy, they are pretty terrible. First of all, they're all very old, so these are papers dating back, all of them more than a decade, because nobody much is doing chemotherapy studies now, and looked at anthracyclines in combination, taxanes, anthracycline monotherapy, taxane monotherapy. You never really saw more than about a 35–40% response rate, median progression-free survival, 7 months first line in the most optimistic studies, and median overall survival about 18 months. And then when you look at second-line data, they're terrible. Most of these drugs probably wouldn't get registered now on the basis of short PFS, very little overall survival advantage. And then many of them were registered in unrandomized data, but we were desperate in those days. We didn't have any new toys to play with. So in a sense, it's counterintuitive to say we should be giving these people chemotherapy. So what helps us treat her? This is the Monarch 3 trial. Again, it was referenced earlier. This was a relatively small trial, 493 patients with ER positive, HER2 negative disease, no prior treatment for MBC. If they'd had adjuvant, they had to have completed it more than a year previously. And there was a 2-to-1 randomization to abemaciclib or placebo with a primary endpoint of progression-free survival. So this woman would have fitted into the trial, and just to go through the demographics as related to our patient, she was Caucasian, as were around 60% of patients in the study. She had measurable disease, that's 80% in the study. She was metastatic recurrent with visceral disease and had had prior endocrine therapy, but with tamoxifen, and her disease-free interval was greater than 36 months, which was the case in the majority of patients. So she fitted perfectly into the trial. This was the investigator-assessed progression-free survival, and we can see it's gone up from 14.7 to 28 months with a hazard ratio of 0.5, and is clearly highly statistically significant. If you then look at Matt Goetz's data on subgroups, these are patients with liver metastases, so you can see they're not doing quite as well as patients without liver metastases, but they're still doing considerably better. And the median progression-free survival was 15 months, which again, referring back, is much longer than you'd expect with chemotherapy. These are the waterfall plots of responses, and again, I told you chemotherapy, your best response is going to be about 35–40%. In measurable patients, the response rate to a non-steroidal aromatase with abemaciclib was 61%, with 3.4% complete responses, and the clinical benefit rate was close to 80%. So most people getting a CDK4/6 inhibitor are going to at least have disease stabilization. And then in selected subgroups, the delta in the response rate for those with liver metastases was 33%, and the same for PR negative disease. So if you want to beat up the subgroups, there is maybe a message that abemaciclib wouldn't be a bad idea for this patient. And there are lots of subgroup analyses. I urge you not to read too much into them. So what about side effects? Well, we all know about diarrhea and we all know about neutropenia, and that they are the two commonest side effects, and we've heard about that earlier today. And then overall survival, which is that kernel that we are constantly seeking. So this was ESMO 2023, late-breaking abstract. Actually, this wasn't the first time these data were presented. They'd been in the SPC, so in the patient information leaflet in the box for a number of months, which shows if you want to hide information from a medical oncologist, put it in the SPC, they'll never see it. They'll only see it when it's presented at a meeting. And this looks encouraging, hazard ratio of 0.75. The p-value is 0.03, but it was an interim analysis, so statistical significance could not be claimed. And it was updated just a few months later at San Antonio. So you see a delta of 13 months with a hazard ratio of 0.80, but this again doesn't reach conventional levels of statistical significance. And that's clearly important when looking at overall survival. And I don't want to get into the realms of how the difference in OS or lack thereof was rationalized by the fans of palbociclib, but I think that this is an interesting result, and just a quick reminder that this was a secondary endpoint, and this trial wasn't powered to pick up an overall survival difference of this magnitude. So The data are the data, the lines are where the lines are, but it doesn't quite reach conventional statistical significance. One of the things I think is helpful about the CDK4/6 inhibitors is you don't have to wait for the chemotherapy day unit. So if I see a patient in the morning, they can walk out in the afternoon with the prescription for the drug. The two limiting things are how long it takes to fill out all the paperwork the NHS requires me to complete and getting the liver function back. She came in at 2 weeks. She was absolutely fine. She's never had diarrhea. She picked up 8 weeks of treatment at the beginning of November. Remember, COVID was on the rise at that point. By January 21, she was well. She had a good symptomatic response. Her liver function was normal. Her CA15-3 had halved, and she didn't want to go anywhere near a CT scanner because she was worried somebody with COVID might have been the last patient in before her. So we booked a scan at 6 months and saw this response, so September 2020, April 2021, on the right, and you can see at least a partial response by either unidimensional or bidimensional criteria. We had a habit of surprises in this woman. So this was her spine, and you can see on the baseline there's no apparent disease in bone, but on the right she's got these sclerotic deposits which we felt were pre-existing deposits that were isodense with the normal surrounding bone at baseline and had become sclerotic through healing. It's one to watch out for. You see it quite commonly. So we had to tell her that she had disease in her bones, but we only knew about it because we were successfully treating her. Unfortunately, her response was relatively short-lived in our world of expectation of controlling these patients' disease for long periods of time. But by September, so after a year, she had disease progression again. And we thought, well, what can we do? Second-line endocrine therapy? Probably not. Chemotherapy? We elected to use carboplatin because she was known to have a BRCA mutation, and we didn't have any access to olaparib at the time. And she got another good response to carboplatin, but a lot of toxicity. So she had debilitating fatigue, peripheral neuropathy, dose-limiting neutropenia, and she stopped treatment after about 6 months. We tried to maintain her response with second-line endocrine therapy, and she didn't respond. She got capecitabine, she didn't respond. She got weekly paclitaxel and had a short-lived response. And in March 2023, she started vinorelbine, and she got no response and was then not well enough to receive any further treatments. But even though she didn't do brilliantly well overall, she did better on abemaciclib than any of the other therapies that we tried. So those are her time to treatment failure times on each of the treatments. And she got 11 months out of abemaciclib, so 12 cycles of treatment, but much less benefit from any of the other drugs that she tried. So my conclusion from this case was clearly, as we all know, that the CDK4/6 inhibitors have completely changed the treatment of ER-positive metastatic breast cancer. From a standing start, not only is a CDK4/6 inhibitor the most common drug I prescribe, but it exceeds all other anti-cancer therapy prescriptions combined. So more than half of all of my prescribing is CDK4/6 inhibitors. We've seen decent disease control on abemaciclib. Yes, not 2 or 3 or 4 or 5 years, but at these meetings we shouldn't always show the best patients, but the disease control with abemaciclib did exceed the duration with all other treatments. And I think that as we've used the drugs in harder to treat patients, we have growing confidence to treat those with rapid tumour growth, endocrine resistance, visceral disease, low PR. And I can't think of many patients, there'll always be 1 or maybe 2, but I can't think of many patients in her situation where in 2024 I would be reaching into the chemo cupboard, I'd be going for a CDK4/6 inhibitor. So I've rattled through that. If you want to read the SPC, click on the QR code, and I'm very happy to take any questions that you may have for me.
Thank you very much, Mark, for the excellent presentation. We'll have a few minutes for some questions. Maybe I can start with maybe a boring question that you probably asked many times. So when you're selecting your patient for first-line endocrine treatment and a CDK4 partner, so what factors are you looking before deciding what type of CDK4 inhibitor do you use, and how do you make that decision? And especially now, the data coming for the INAVA 120 as well. So do you do molecular profiling early on, or do you wait?
So I think in these patients, the treatment of choice will be a CDK4/6 inhibitor. And I chose this particular patient to present because she had some markers of endocrine resistant and she had liver metastases. And we've seen various different analyses, but she needed a response. And the evidence for abemaciclib is that she's likely to get a response. We don't have head-to-head comparative data with the other CDK4/6 inhibitors, but in that situation, I think abemaciclib was a very reasonable choice because of the distribution of her disease. It's also a bit more flexible, so it's slightly easier because you're not worrying about the 3 weeks on, 1 week off. In a patient where we're worried about myelosuppression, clearly abemaciclib you would favour. This woman never had diarrhea, so we talk about diarrhea as a major problem. Some people just never have diarrhea, so that wasn't an issue. At the time we started her, we hadn't seen the survival data. And I think it's interesting that we've got one trial with ribo that's positive. We've got one trial with abemaciclib where we don't have that magical statistical significance. But are the two drugs behaving any differently? No. If you analyse them, if you did a comparative analysis, would you see a major difference? I don't think you would. And nobody will ever do a head-to-head comparison of these drugs because they'll all be off patent by the time that comes through. So I think that it's a good choice, and I was happy with the way it worked in this particular patient. When you come to the plus fulvestrant, the data for abema that we haven't talked about today are much cleaner because the trial design absolutely maps onto where we would give the drugs today. So it's the patients who haven't had chemotherapy, who have proper resistance. And the trial design of MONALEESA-3, and we were an investigating centre in MONALEESA-3, the trial design of MONALEESA-3 is very much more permissive. So it's harder to work out the effect of the drug in the different subgroups. And if you've got a drug that you give continuously just from a practical purpose, if you're giving 4 weekly injections of fulvestrant, if you do have a dose delay for any reason, at least you don't have to mess about with the timing of the fulvestrant and dilute the efficacy of that. So I think there are swings and roundabouts, and we are, in a sense, spoilt for choice. I do think the palbociclib data has not done it any favours over recent years, though.
Thank you very much. Hassan Wazan?
Sorry, can I ask a question?
Yes.
I see that maybe PET scan, PET CT has no role in your staging or following up patient, because when she had that lymph node, you didn't know anything about the liver metastasis unless you have done something, other test.
I think up until the point that she had the biopsy, she was being seen in a surgical clinic, and they, on radiological grounds, were unconcerned about the lesion. So it would be, we wouldn't use PET in follow-up. We might use PET if there was diagnostic uncertainty. At the time that the liver diagnoses were made, we didn't need a PET CT to tell us her liver was full of disease. And one of my concerns about very detailed investigation is, certainly in the UK, it takes time. And if you've got somebody with bulky liver disease, I think you need to get them onto treatment quickly, rather than wait and investigate and do test the answers of the tests, or the answers to which you know. So I agree, if she'd had a PET earlier, it probably would have made the diagnosis earlier, but she didn't. We can't go back. And I don't think I would be saying to my radiologists in the breast team, who are very good and we work very closely together, every time we've got something under the arm that's, it's got a B3, are you going to do a PET scan? I think we wouldn't have the resource to do that. We'd do lots of negative scans. But you're absolutely right. We probably could have made the diagnosis earlier with PET.
Not only certainly when you've seen the liver, she could have had maybe other bone lesions or other systemic disease, right?
Yeah. But again, that puts a delay in, but it doesn't change our treatment.
So just follow-up question on your case again here. So I noticed you did not do any molecular testing because obviously first you have near 11 months of PFS, and those patients we know they still even with liver metastasis they can respond to other hormonal therapy, especially now we have the ESR1 mutation as well as the PI3K, P10, etc., AKT. Any reason why this was not, I guess, I don't know if at the time of this case it was not, no approvals for the drugs like capivasertib or alpelisib, or even drugs like mTOR inhibitor, you know, everolimus.
So there are a number of different threads to that question. The bottom line is the biomarker that is conventionally used and defines the patient population for treating with a CDK4/6 inhibitor is estrogen receptor. And there aren't any prospective trials that tell us that there's anything going to be better than a CDK4/6 inhibitor in a patient who's ER positive. And that patient, we knew she was BRCA positive. We could have done genetic testing, found an ESR1 mutation. If we had, I couldn't have accessed a SERD. So it doesn't make a difference to management.
I'm talking after the first progression. I'm talking when, when you went to chemotherapy.
At the time of first progression, we didn't have access to alpelisib. So there wouldn't have been any point in doing it. Later on, I didn't show you the slide, we did actually look for PI3 kinase mutation, and that was negative. So we do, if a patient is otherwise going to be eligible, then we would look. If she'd had fulvestrant up front in England, she wouldn't be eligible for NHS funding for alpelisib because she's already had the fulvestrant. So there is an art of oncology in trying to use the best options and also trying not to compromise next or subsequent line treatment. And that was one of the reasons for trying to hold off in case one of the newer drugs would become available for her. But we're in a healthcare system where financial approval lags some distance behind license approval, and that can be a frustration. But I don't personally think, even if I saw the same case again, I'd want to do an NGS, because it just makes noise and it slows you down.
Well, but we have capivasertib now with 7.8 months PFS. We have still the Afinitor data. I mean, we cannot ignore all of these.
But would capivasertib be better than a CDK4/6 inhibitor in first line?
No, I'm talking about after progression on CDK.
But
I'm arguing for the chemo choice, jumping to second-line chemo.
We still don't have capivasertib, we don't have elacestrant. So sometimes also, and this is again a frustration of working in the UK, we may be able to get the fancy test, but often when we've got the fancy result, we don't have the fancy drug that goes with it. So there's an element from the plenary speaker about managing expectation and practicing oncology sensitively. So don't create a demand that you can't fulfill.
Thank you so much, Dr. Verrell, on this excellent presentation. So my question to you is that I recently had a patient who progressed on adjuvant abemaciclib. Just 2 months after we stopped abemaciclib, she started showing symptoms of recurrence, and on the PET scan, only contralateral lymph node recurrence. So this patient also is HER2 low. Remains also ARPR positive on repeat biopsy. How would you approach this patient?
So that patient is heading towards chemotherapy. The data for TDXD, I think, are very encouraging. NICE won't pay for TDXD in HER2 low, so we would give that patient chemotherapy. But I think if you could give an antibody drug conjugate, you probably would in that situation. And there's obviously TDXD. There are data in ER-positive disease for sacituzumab govitecan. There are trial data coming along with datopotamab deruxtecan, although our experience of that in trials is that it makes TDXD look quite easy.
But if the patient only has isolated contralateral lymph node recurrence, if we started her, let's say, on systemic therapy with TDXD, and the patient has responded, I mean, excellent to the treatment regimen, would you at all consider debulking or doing an axillary dissection to the contralateral side, knowing that there was no primary on the contralateral breast?
I don't think there's a right answer, because there isn't an evidence-based answer, and I think it requires careful decision in your multidisciplinary team. And we have patients who've had axillary disease where we've used surgery. We've had patients where we've used radiotherapy to try and prolong local control. And our worry is always if the axilla is the site of first failure and it becomes very locally advanced under the arm, it's extraordinarily difficult to palliate that patient. But I think I can't give you the answer. I think it's the one for you to discuss with your colleagues in your MDT, and it's unfortunate, but certainly I think you need to treat the axillary disease slightly differently than if she'd developed liver metastases. And yes, definitely biopsy and think about NGS and see if you can get a signal that will help you. But I think in the case I've shown up front, follow the ER. Don't try and be too clever. It does never served me well. I think keep it simple and follow the evidence.
Excellent. Thank you. Any more questions?
Thanks a lot, Dr. Beryl, for this very good presentation. Actually, my question is much like the previous question. If we have a patient on CDK4/6 inhibitor and has isolated recurrence, could we can treat this recurrence with local modality and keep the patient on the same CDK4/6 inhibitor with hormonal therapy, as we have like limited treatment options after that in the metastatic setting, or we have to shift directly to the new drug?
I think oligopatration is an interesting one, and again, the evidence as they are don't necessarily support treating oligometastatic breast cancer with local therapy. Now, the trial that's tried to do that is NRG-BR002, which never got very big and was abandoned on grounds of futility. So in a sense, my answer to you is the same as my answer to Ada, which is if you've got somebody who's got funny disease that's not following the script, so it's not going off everywhere, and there is an oligo treatment option, then it's something that you need to discuss very carefully in your multidisciplinary team with the clinicians that you work with every day, and try and come up with a plan that's best for that individual patient, because you're not going to have a clinical trial of what to do in patients who are on adjuvant abema and throw up a lymph node under the contralateral arm. So I think that follow the data where it exists, and if there aren't data there, talk to your friends. We have in England, there's a group of us, we have a WhatsApp group where we discuss these patients, we discuss them in our MDTs, and I think that you put your heads together with your peers and try and find a way through that's the best for the patient.
Thank you very much, Dr. Mark. With this, I think we'll conclude the session. Thank you very much. I think Yemhad is supposed to. Okay. Let me introduce Dr. Emad Anwar, consultant medical oncologist, all the way from Tamam Hospital. I think Hassan talked.
Sorry. He forgot. Apologize. Good afternoon, dear all. So we will present this next session, and we will have Dr. Emad Anwar. This is a satellite symposium. So he will, Dr. Emad Anwar, he's a consultant medical oncology, working in Tawam Hospital. He's a colleague and friend. He has a big interest in clinical research. He had a lot of clinical research, and he will speak today about ovarian cancer. We know that ovarian cancer, when they become platinum resistant, it's really a challenge for every one of us. Then you have to present. I thought this was a different session. This is Novartis. I thought this is the next session. Anyhow, I presented Dr. Emad, so it will be sponsored by Novartis, so he will present the CDK4/6 inhibitor.
Thank you, Hassan, for this lovely introduction. And would like to thank the organizing committee for giving me this opportunity. So good afternoon, ladies and gentlemen. So my task today is to talk about the evolution of treatment in HER2 negative hormone receptor positive early breast cancer, and how we can extend this treatment for our patients. So this disclaimer from the company, and this is my disclosures. So we know that the breast cancer is the most common disease, and worldwide we have more than 2.3 million cases every year. And globally, most of the patients, up to 95%, they diagnose in early stage, while only 5% in metastatic, which is not the case in our patient population. In Gulf region, we have around 3,000 new cases per year, where stage 4 up to 15%, and 85% early stage. And if you dissect more, you find that 70% are stage 2 and stage 3 disease. So we have different patient population. They are already having more advanced and aggressive disease. So the question, why we need more treatment for ER positive, HER2 negative early breast cancer? So simply because those patients still they have a risk of relapse, and as an oncologist, we're looking for the 5 years mortality. So this group of patients already they have very well 5-year mortality, but when they relapse, unfortunately, they relapse late. And many of those patients, they relapse even after 15 or 20 years. So we need really treatment to prevent the relapse for those group of patients. So we are familiar with this curve. We have a group of patients those having very high risk of relapse, which mainly they relapse in the first 5 years. Another group of patients with less aggressive disease that we believe, and they relapse up to 20 years. And even if you're looking for those patients with, with lymph node metastasis, if there is a heavy lymph node metastasis like N2 disease or more than 50% of the relapse at 20 years of follow-up, down to N0 disease. We have almost 22% of the patients they relapse. So there is unmet needs for this group of patients. Why? When they relapse with more aggressive disease. Some of them, they have even estrogen refractory or hormone refractory disease or resistant, whether it's primary resistant or secondary resistant. Some tumors becomes triple negative or transformed to HER2 positive. And unfortunately, they develop visceral metastasis, so, which is impacting their outcome and survival. So as a physician, really, we need a more effective treatment to prevent the recurrence for those group of patients. But the second question, who need this treatment to prevent the recurrence? So how to select your patients? Well, traditionally, we using the anatomical classification to high risk and low risk. High risk, we give chemotherapy, endocrine therapy. For low risk disease, we give usually endocrine therapy. And then we move to gene profiling, such as Oncotype DX, and this to de-escalate the chemotherapy for those patients, so not over-treating those patients. But in the same time, we're escalating the hormonal therapy. We moved from the tamoxifen to aromatase inhibitors, from aromatase inhibitors and tamoxifen alone to add ovarian function suppression. And now we are moving to the CDK4/6 inhibitor for those patients. So which criteria you consider high risk of relapse? Is it only lymph node metastasis? There is some consensus from some countries, European countries. Probably in Italy, they consider grade 3, T3 and T4 lymph node, like N2 and N3 disease, high risk gene profile, and high Ki67. They considering this as high risk features. In UK, they have little bit differences, but most of these risk factors are considered. Grade 3, large tumor, heavy nodal infiltration, Oncotype DX more than 26, and they consider age less than 35 as a risk factors. So for N0 disease, which is considered less risk factors, but there is other risk factors that may impact this N0 disease to relapse later on. And that's why when looking for the N0 disease, we have 22% of the patients, they relapse at 20 years of follow-up. If you add one more risk, such as just tumor size, look for the risk of relapse. It's jumping to 29%. So it's not all N0 disease, they have no risk criteria. They might have high grade, they might have high Oncotype DX, they might have larger tumors. So they are still high risk of relapse with the longer follow-up. Some of these meta-analysis which confirming that there is still even the group of patients that we consider they are low risk disease, they still have a high risk of recurrence and they need more treatment. This is also from the ASCO guidelines. and from ASCO-ROR meta-analysis, and you can classify the patients of N0 disease. We have a group of patients with really low risk. There is no any other risk factors, and some N0 disease with other risk factors. And if you're looking for the outcome for these two groups of patients with N1 disease or N0 high-risk features, they almost behave the same. So coming to the CDK4/6 inhibitor in the adjuvant setting, and I know that you are familiar with this slide. We have 4 phase 3 trials, the Palace, the Penelope P, the Monarchy, and Natalie trial. 2 trials are positive, and the Monarchy and Natalie trial, they are 2 different trials, so the patient population are different. The dose of CDK4/6 inhibitor is different, duration of treatment is different, even the endocrine partner is different, so 2 different trials. That's why we cannot have the cross-trial comparison between these 2 trials. But the bottom line, if you look for the control arm from these 4 trials, the control arm without CDK4/6 inhibitor, at 3 years of follow-up, you can see at least we have 10 to 15% risk of recurrence for this group of patients. I will exclude the Penelope P because they give only 1 year of CDK4/6 inhibitor. Probably they have very high risk, which is 22% at 3 years of follow-up. So we need a treatment, effective treatment for those patients. We know that the Palace and Penelope P, they are 2 negative trials. And the first CDK4/6 inhibitors approved was the abemaciclib from Monarchy E study. In this trial, they included patients with very high risk of relapse, 4 lymph node positive, at least, or 1 to 3 lymph nodes involvement, but you need another risk features such as large tumor or high grade. And they randomized the patient to abemaciclib and endocrine therapy versus placebo and endocrine therapy. And you can see that almost 30% of the patient population, they received tamoxifen, not aromatase inhibitors, it's not mandatory. And ovarian function suppression was an optional, it's not also mandatory. The primary endpoint was invasive disease-free survival in this trial, and this trial was positive, and the updated analysis in the ESMO last year, the hazard ratio was 0.68, and the Kaplan-Meier curves start to increase, widening. So we have almost 7.6% gain at 5 years of follow-up for the invasive disease-free survival in favor of abemaciclib, and the trial was positive. What about the patient that had dose modifications? There's some numerical changes in the invasive disease-free survival, but it did not impact or compromise the outcome. So no matter you reduce the dose or not, the outcome is the same. Probably there is some side effects. We know that abemaciclib has some sort of diarrhea, fatigue, abdominal pain. This is the most common toxicity from abemaciclib. Moving to the Natalie trial with the second phase 3 trial, which is positive in this indication, just to highlight it that the allowed patient, those already on treatment endocrine therapy for 1 year to be included in this trial. They include patients with stage 2A, N0 disease, or N1, but if N0, you need more risk features, such as higher grade, high Ki67, and Oncotype DX of more than or equal to 26. They allowed stage 2B as well as stage 3. So ribociclib with the reduced dose already 400 milligram with the standard endocrine therapy, but in this trial, they mandate endocrine therapy. And also they mandate for perimenopausal to have ovarian function suppression. Primary endpoint, invasive disease-free survival, and distant recurrence-free survival and overall survival is second endpoint. Also, this trial was positive. With the longer follow-up, we see deepness in the benefit by giving CDK4/6 inhibitor, the ribociclib for those patients. And recently, in the last ESMO, we have the 4 years follow-up for this group of patients, and you can see we have almost 5% gain in the invasive disease-free survival in favor of ribociclib with a hazard ratio of 0.71. And this benefit was across all the subgroup of patients, no matter if stage 2 or stage 3. Probably stage 3, we know this have very high risk, so the benefit is more, 6%, and 4.3% for the stage 2. And no matter N0 or N1, still we have 5% improvement in invasive disease-free survival for both group of patients. This and disease-free survival and overall survival is still immature, and still we need longer follow-up. And even for those received endocrine therapy before recruitment up to 1 year, still gaining the same benefit. And just to highlight it, even with the dose reduction, because we already reduced the dose, 400 milligram. So if you reduce the dose to 200 milligram, if there's any impact on the outcome, you can see the two curves are overlapping. There is no difference with those modifications. So this is a summary of the CDK4/6 inhibitor in the adjuvant setting. So I choose the 4 years of follow-up as a cutoff point for the two CDK4/6 inhibitor, and you can see the NATALY as well as Monarchy at 4 years, the absolute benefit of 6% from both trials at 4 years of follow-up, and the benefit for stage 2 and even N0 or N1 disease, still we have 4 to 5% gain in the invasive disease-free survival. So in conclusion, the risk of recurrence in hormone receptor positive, HER2 negative early breast cancer is in both early and late recurrences. There is an urgency to treat early to avoid recurrence disease in more aggressive forms. The TNM status plus tumor grade genomic assay remain the building block for better risk assessment. In zero disease, still there is high risk patients with N0 disease which behave similar to N1 disease in terms of recurrence risk. And adjuvant abemaciclib with optimal endocrine therapy significantly reduced the risk of distant relapse in high-risk cohort, with a benefit still maintained at 5 years of follow-up. It's almost 7.6%. And also NATALY trial continue to support the benefit of adding 3 years of ribociclib to adjuvant aromatase inhibitors, spreading the population of patients with ER-positive, HER2-negative early breast cancer at risk of recurrence. With that, I will thank you and happy to take any questions.
Thank you very much, Dr. Imad, for the nice presentation. We have time for 1 or 2 questions. Dr. Aida and Dr. Okay.
Okay, for the first time, I'm starting with a question. Thank you so much, Dr. Imad. And with the recent approval of ribociclib in the adjuvant setting, how would you stratify the patient, and which CDK4/6 inhibitor you would choose for the overlapping, eligibility?
Thank you, Dr. Aida. We have 2 groups of patients. A group where only ribociclib is approved, so it's easy. I'll go for ribociclib. And there is a group of patients where the ribo and the abema are approved. I think every one of us, we face this situation in metastatic setting. So the same rules in metastatic setting will apply in the adjuvant setting. We have to look for the patient profile. Both drugs are very effective. So which patient will benefit? It's based on patient profile.
But don't you think the 5 years, having longer follow-up will play a role in your decision?
Discussions will not end because we'll have 6 years and 5 years, 7 years and 6 years.
It's always catch up.
It will not stop because one trial before the second trial. But we have been using abemaciclib with 3 years of follow-up, 4 years of follow-up, and 5 years of follow-up. So we accepted the data from the abema with a shorter follow-up. Yes, we have a longer follow-up, but now we have again for the ribociclib 3 years and 4 years. And if we come next year, inshallah, if we're still here, we'll see more benefits. So the 2 drugs are very effective.
Can you comment on the percentage that completed the 3 years was only 62%? Is this, even though it was 400 milligram, which is a reduced dose, is this more because of the tight, boundaries we have on a clinical trial versus what we do in real life?
Well, most of the discontinuation, it was, I think discontinuation was 30 plus, maybe 35%. 20% discontinue because of toxicity, which is acceptable in the trials. Even abemaciclib, around 19, 20%, they discontinue because of toxicity. We have patient lost follow-up, a patient they withdraw from the trials. So, in my opinion, this is acceptable percentage of the patient to complete the treatment at 4 years of follow-up.
Thank you very much, Dr. Imad, for the nice presentation. Thank you. I think we are running behind schedule, so if we can stick to the time, and and we'll have a few questions per each session if everybody is happy with this. Let me introduce Dr. Thorsten Fruder. He will be talking about a role of checkpoint inhibitors in early lung cancer. Thank you.
This doesn't work, but it works like that. Great. Thank you for the invitation. I'm happy to be here. Also happy that not everyone is breast cancer, focused on breast cancer, so obviously there's still someone in the room. So now, so now let's switch gears and talk about a bit of lung cancer, non-small cell lung cancer, and immunotherapy, and in particular early stage. Here are my disclosures, so I'm collaborating with everyone, so don't think I'm heavily biased. Today, I've learned that we can celebrate birthday of Keytruda or pembrolizumab. It's 10 years from now that pembrolizumab was introduced in our daily clinical practice. And when I'm thinking back, of course, we started in stage 4, initially in second line or third line, but very soon immunotherapy was moved to the first line setting in stage 4 non-small cell lung cancer. As all of you know, on the right-hand side of the slide, you can see the long-term survival data in squamous cell or non-squamous cell carcinoma in combination with pembrolizumab, or even with pembrolizumab monotherapy at the bottom of the slide. And for the first time, in my opinion, we have something like long-term survivors. So this has never been observed before in non-small cell lung cancer, that when patients are diagnosed with stage 4 disease, we really have long-term surviving patients. So when I studied medicine, so I'm not that old, but still in the textbook of medical oncology, there was nothing like long-term surviving patients for non-small cell lung cancer. And I think this is really the first success for immunotherapy, and in particular Keytruda in this setting. But of course, we didn't stop here. And the topic of my talk today is not metastatic non-small cell lung cancer, but rather early stage. And I want to do this as well, a bit of with a patient case. It's a 62-year-old male patient, excellent performance status. Unfortunately, a current smoker, 40 pack years. So I think smoking is still an issue all over the world, also in Europe or in Austria. In the heart of Europe, our people get heart disease of smoking and, of course, cancer. Here's a comorbidities, is just hypertension. We did a biopsy, and the histology told us it's a squamous cell carcinoma, PD-L1 expression of 15%. What we also do, despite squamous cell carcinoma, we do next generation sequencing also of all the squamous cell carcinoma patients, but there was no actionable mutation in this patient. So here we can see the image of this patient. You can see on the left-hand side and in the middle the lymph node and the primary tumor, which was staged with CT3, CN2, M0 disease. And of course, we have to discuss this in our multidisciplinary tumor board. As I'm not a surgeon, talk to the surgeons, of course, is this a potentially resectable tumor or isn't it a resectable tumor? And yes, the surgeon confirmed that this is, in theory, it would be resectable. And the next question is, I don't think we have a voting system or so, but perhaps you can tell me what is your treatment recommendation in this case. So it's non-small cell lung cancer, squamous cell carcinoma, 15% PD-L1, CT3, CN2, M0. Would you go? And those are all, I think, valid treatment options which are in the guidelines. Would you go up for surgery followed by adjuvant therapy, neoadjuvant chemo-IO followed by surgery, choosing neoadjuvant chemo-IO followed by surgery and followed by adjuvant immunotherapy, what we call the perioperative approach? Or are you a radiation oncologist I don't know, and say, okay, because our radiation oncologists in our MTD, they always tell us, you always want to go for surgery. I'm a radiation oncologist. Chemoradiation followed by durvalumab would also be an option. It's a stage 3B disease, at least, so would also be in the guidelines. I don't know, perhaps you want to raise your hands. Is anyone for chemo IO, or is anyone followed by immunotherapy? No opinion about that. You are? It's N2 disease. I know it's not a multi-level N2 disease. It's single level. Yeah. It's surgically resectable. C. Okay. That's good for the topic of the symposium. Yeah, and you're absolutely right. I think those are really our options in pathological stage 2 and 3 disease. We could, in theory, go for upfront surgery, followed by adjuvant chemo, followed by immunotherapy, go for neoadjuvant chemo only, go for surgery and wait, or choose the perioperative setting with neoadjuvant IO surgery and followed by adjuvant immunotherapy. And I just want to talk a bit about the clinical trials which established those regimens. And of course, as you can see here, and these are regimens which are partially approved in this setting, neoadjuvant chemo IO, which is checkmate 186, or surgery followed by immunotherapy, so no upfront immunotherapy in Power 10 or Keynote 9.1, or the perioperative regimens, Aegean, Keynote 671, or Checkmate 77T. All of those are phase 3 studies, of course. But let's make a step back before we talk about the clinical trial, just to give us a bit of a rationale and also a molecular rationale. What's in theory, what would be preferable, doing upfront surgery or not? There is no really head-to-head comparison in a clinical trial for lung cancer. There are head-to-head comparisons in melanoma, as you know. But for me, 3 years ago, this was very interesting at the ASCR meeting. You know, it's more early stage or molecular conference about the molecular behavior of cancer, and they did a very intriguing animal experiment with a lung cancer model, obviously. In animals, they did a resection followed by adjuvant immunotherapy and looked for the analysis, or they started with neoadjuvant immunotherapy, did a resection and looked for follow-up. And as you can see here on the right-hand side, the patients in blue treated here with a neoadjuvant dual checkpoint blockade did much better than those, not the patients, the animals treated with adjuvant immunotherapy only, so no, with upfront surgery. And I think we have established now also on the molecular level the role of neoadjuvant immunotherapy or perioperative immunotherapy. If the tumor is still in the body, there is much higher chance to activate the immune system and to increase the immune infiltration, activate the T cells, activate dendritic cells, and enhance immune response in general, compared to adjuvant immunotherapy only. And Keynote 671, I think, very nicely established the concept. As you all know, just to remind you of the study, it was a phase 3 trial in stage 2 to stage 3B disease. Of course, no prior therapy allowed, comparing neoadjuvant chemotherapy plus pembrolizumab, followed by surgery, followed by pembrolizumab for up to 13 cycles, versus placebo plus chemotherapy, followed by surgery and placebo. The baseline characteristics are quite well balanced in both arms, in my opinion. So there are non-squamous, squamous cell carcinomas as our patient. We have all clinical stages. We have lymph node positive, lymph node negative, about 50% N2 disease. PD-L1 distribution is also quite equal. Unfortunately, we don't have the activating drivers situation for everybody, so there are a fraction of patients with known EGFR mutations or known ALK translocations. And this was the primary endpoint, or one of the primary endpoint, event-free survival. And as you can see here in blue, pembrolizumab is definitely superior regarding EFS compared to placebo. This was published very recently in Lancet. Having a look at the subgroup analysis, which also confirms the superiority of pembrolizumab effectively in all tested subgroups. What we can also see, there's an improvement in MPR, so major pathological response rate for pembrolizumab, 30.2% versus 11%. And most importantly, there's also an improvement in pathological complete response rate, 18.1% versus 4%. If you look on the right-hand side, there's an analysis which has also presented this year when you look at this downstaging, and you can see here, it's not some elections analysis, it's really a downstaging regarding the lymph nodes. From N2 disease, for example, we have a very nice downstaging, and also in all other stages compared to placebo, where this downstaging effect is not that prominent. Patients who achieve a pathological complete response here in the upper part of this slide are doing much, much better than patients without pathological complete response. But still, in patients without pathological complete response, you can see that the curves still remain separated. So we have a hazard ratio of 0.69 for those patient population in favor of their perioperative immunotherapy approach. And I think this is really important and quite striking for this trial, because I think it's a bit unique, or still unique, that we have a statistically significant overall survival benefit. And you mentioned this, sir, in this setting, a hazard ratio of 0.72, statistically significant. And I don't know if you attended the morning plenary session with Professor Booth. And he also mentioned that overall survival finally matters. And I think this is a very, very valid and important comment Professor Booth made. I think overall survival is, of course, the most important clinical endpoint, and in particular in early stage and early settings, because what we want to achieve is that the patients have to live longer and not only live without a disease. And I think this really matters, and this is one of the most important findings in this study. And the subgroup analysis also confirms the overall survival benefit in effectively all subgroups analyzed. Regarding adverse event rate, I don't think there is really something new or something special. We have the known adverse event rate of chemotherapy. We know that there are immune-related adverse events due to pembrolizumab, but I wouldn't say this is something which is not manageable. We had 10 years now to learn about managing immune-related adverse events with pembrolizumab, and I think all of you and we are really quite experienced in doing so. But to be fair and honest, there is not only this trial evaluating perioperative immunotherapy in early stage of non-small cell lung cancer. Of course, there are different types of studies. On the left-hand side, you can see a CheckMate 77T, a trial with a very similar approach, but of course using nivolumab instead of pembrolizumab. On the right-hand side, you can see the Aegean trial, again a very similar study design of what we have already heard, but they substitute and they do not use pembro, but they use durvalumab, the PD-L1 inhibitor. Regarding event-free survival, both of those studies are positive as well. So there's a superiority of the perioperative immunochemo approach compared to the chemotherapy only. we have a superiority of PCR rate and MPR rates. This is both true for checkmate 717 and Aegean, but the difference is that there is still no overall survival benefit, which is statistically significant for this study. And I think this is still something why I personally do not prefer those regimens in this setting. Of course, there is also the neoadjuvant approach. So going from this perioperative approach using pembro upfront surgery and followed by adjuvant immunotherapy. There is also the Checkmate 186 study, which just use it 3 cycles of nivolumab chemotherapy only, followed by surgery without any adjuvant immunotherapy. Again, this trial was positive as well. Nivo chemo is superior to chemotherapy only. Just 2 slides, a comment on adjuvant only, so no upfront immunotherapy. Of course, we have an approval for those studies as well in Power 10. Adjuvant atezolizumab, which they didn't use neoadjuvant chemoimmunotherapy, but post-surgically. There was also some DFS benefit in this setting. In Europe, it's only approved in patients with a high PD-L1 scoring. And on the other hand, we have also pembrolizumab data with an approved DFS, disease-free survival, in this setting, which is in my country, it's approved in Europe for all comers, so which is a bit of a difference. What we don't know is why there is not so much of a biomarker dependence or PD-L1 expression dependence in this setting, but this is what it is. Okay, then let's return to our patient. As you suggested, we went for chemotherapy plus pembrolizumab 4 cycles, and you can see a very, very nice downstaging partial response after 4 cycles. Question is, should we do an imaging after 4 cycles anyway, or shouldn't we do that? Should we do a PET-CT? We did this imaging. I didn't show you. The patient had a new lymph node on the contralateral side, so everyone was nervous. What happened now? So we did a biopsy or bronchoscopy, and we biopsied these lymph nodes, of course, to rule out N3 disease. Fortunately, there was no positivity, so the role of imaging after finishing chemo IO is still, I think, to be discussed. I don't know what's the role is, because sometimes we all get nervous. What happens now is there's a lymph node flare, is it a progression? But in our experience, quite often it's just immune reaction and nothing else. This is the pathology report after resection. So I'm not a pathologist, but the pathologist told me this pink stuff on the left-hand side is necrosis. On the right-hand side, it's tumor, vital tumor cells. So not only talking about the very, very success stories, because then I would have presented you a pathological CR patient, but this is not the case. Patient has a non-MPR. Still, he has a response, but 30% vital tumor cells are still left. So what do we do now? Would you change your strategy? Would you say, okay, now follow up, wait and see, it's a non-MPR patient, do something with chemotherapy, say, okay, no, I stick to the study design, continue with pembrolizumab monotherapy, or any other options? You're nodding? You would continue. Yeah, this is what we did as well. I think it is the most reasonable thing. And just a few considerations, I think I will stick perfectly in time. But give me the next 2 slides for my last 2 minutes. This was a very recent analysis done in the lung cancer meeting in San Diego. They indirectly compared Checkmate 186, so neoadjuvant, to the perioperative regimen. Of course, it's an indirect comparison. You have to be very careful. They did some, of course, they did some matching, statistically matching. And as you can see, the perioperative approach is superior to the neoadjuvant only approach, hazard ratio 0.6. Yeah? On the right-hand side, you can see CTA DNA recurrence. And again, when we look at that and compare to the placebo group, there's a reduced risk of ctDNA recurrence. So And also when we have a closer look at the keynote 671, those patients who received adjuvant therapy, so adjuvant or perioperative pembrolizumab in blue, doing much better than patients on the right-hand side who did not receive adjuvant therapy. Of course, these are just indirect hints, but for me, it still confirms my approach when you're doing when you're making this approach, perioperative pembrolizumab is the way to go. So I think with that, I want to conclude. I think immunotherapy is now also the standard of care for early and advanced stage. For me, perioperative is preferred over adjuvant-only approach. Perioperative pembro chemo prolongs overall survival, but we still lack biomarkers, and I think biomarkers definitely are needed for further patient selection. So, thank you.
Thank you very much, Dr. Thompson. Excellent presentation. I think chest MDT has certainly changed. It used to be dominated by the cardiothoracic surgeon, but I think they're starting to listen to us now as medical oncologists as well. So we have time for one question. Is it okay? Because of we're running late. Yeah.
No, just one.
I'll be short in my answer because
Okay.
it will be a difficult question. I say, okay, I don't know.
All right. Can you comment on one of the, not critique, but say that you saw survival advantage because you have used only cisplatin, and that may not be applicable to all patients. Some patients have diabetes and mild renal failure where the GFR is around 50 and you don't want to give cisplatin. So what do you do with these patients? Or do you buy into that this was slightly biased to be positive because we only used cisplatin? And if you can comment on the PD-L1 positivity and the prediction of who's going to have a better response or not in the neoadjuvant setting.
So those are really two very valid questions. So as you know, the approval, I don't know which the approval is by the FDA, but in the EMA approval is for platinum-containing regimens. I think it's very similar for the FDA. So they did not stick on the cisplatin regimen. And personally, I think, yes, of course, it would be nice to have it, but I don't think it's mandatory that we use cisplatin in this setting. But I think carboplatin might be equally effective or is equally effective if we look at the broad spectrum of what has been published and what are the other data are available. So if a patient is cisplatin fit, I go for cisplatin because this is how the study was done. But if, as you say, we have a lot of patients who are not eligible for cisplatin, then I use carboplatin pembrolizumab combination in the perioperative setting. And yes, of course, as always, PD-L1 might be a biomarker for enriching responders, but I don't think it is necessary. The approval is for all comers, and I definitely would also use patients with this regimen in PD-L1 negative patients. So, and the next thing is, as you know, PD-L1 it might not be a biomarker which is homogeneous, distributed. What we quite often see in surgical tissues that the PD-L1 expression does not really match what we thought initially it is. It is a different story, but yeah, it's not the perfect biomarker. We have to look for additional biomarkers. Perhaps circulating tumor DNA is something which can we incorporate in our future trials, definitely.
Thank you very much for your kind presentation. So we'll move on to the next session. Let me introduce Dr. Dina Hamza, consultant medical oncologist, friend and colleague from Dubai Health. She'll be talking about, again, breast cancer, tackling ESR1 mutation, and from the Emirates study. Dr. Dina Hamza, thank you very much.
Thank you, Dr. Hamad, for the nice introduction. Thanks, EOS, for the invitation, and back to the breast cancer. So today's satellite, we're going, it's sponsored by Menarini, and we're going to talk about metastatic breast cancer and tackling the hormone-resistant metastatic breast cancer. So these are the living guidelines from the ESMO, as we can see, and all what we can agree on that patients with hormone receptor positive, HER2 negative metastatic breast cancer The first line of treatment is standard of care, CDK4/6 inhibitors and endocrine therapy. But whenever the patient progresses, we have a lot of factors which might be affected. So we don't know whether this patient is, for example, resistant to the AI. Do we need to switch the AI? Do we need to switch the CDK4/6 inhibitor? Or there is an underlying mechanism for that. For example, is there an ESR1 mutation which has developed? Or on another factor, we have data coming from the PI3Ka pathway, whether this is mutant and we need a PI3K inhibitor and another change in the hormonal therapy. We have to look also for the HER2 status, because we have data in the hormonal receptor positive about the HER2 status and about the antibody drug conjugate. So for example, if it's an HER2 0, we can use, for example, sacituzumab govitecan. If not, then it's a chemotherapy, which means that the patient became hormone refractory. Still, for the hormone refractory, we have the HER2 low, and we have another ADC, which is the trastuzumab deruxtecan. So where to start with and how to go through, it's quite a difficult situation. So let us agree on something. For the first line setting, we have a standard of care, which is the CDK4/6 inhibitors and the AI, and this have been proven in multiple trials. We have the Paloma 2, we have the Mona Lisa 2, we have the Monarch 3, and as mentioned previously by my colleague, Dr. Ahmed, that the progression-free survival is the same between the three trials, 0.56. As talking about the OS, which is quite debatable here, and the data coming from the OS, we have only one drug which had showed a benefit in the OS in the first line setting, which is ribociclib. The Paloma and the Monarch did not show a significant benefit for the OS in the first line setting, yet it is a secondary endpoint. So what is next? What are the limitations of the treatment options following progression on a first-line CDK4/6 inhibitor and hormonal therapy? First of all, we have a very low PFS and for sequential endocrine therapy after the CDK4/6 inhibitor. The fulvestrant, for example, we know quite well the PFS was quite short. We're talking about 3 months. Don't forget low bioavailability. It's an intramuscular injection burden. Combination therapies, lots of combination therapies have been there, and there is no significant benefit, and yet there is significant toxicities, and we really don't understand what is the mechanism of hormone resistance on CDK4/6 inhibitors. So that's why we need no frontiers in the receptor hormone positive metastatic breast cancer, which have been there throughout the years, starting from 1890. We looked for SERMs, we looked for SERDs, we looked for aromatase inhibitors, we looked for mTOR inhibitors, everolimus CDK4/6 inhibitors, and lately we have the elacestrant approved 2023 as the first and only approved oral SERD. So what are the mechanism of action of the hormone receptor targeted therapies? The established therapies that the estrogen is responsible for activation or cell proliferation of the breast cancer in hormone receptor positive. Here comes the SERMs in the 1970s. So the tamoxifen, it binds to the co-activator protein, preventing the activation between the estrogen and the receptor. And then comes the aromatase inhibitor in the postmenopausal women, where it inhibits the aromatase and inhibits the estrogen production coming through the fat or coming through the adrenal glands. So there is no estrogen being binding to the estrogen receptors. And since 2002, we have been looking for the SERDs, which are the degrader of the estrogen receptor. And we had only at the time the fulvestrant. So how can we go? This was an absolute unmet need. No specific trial had showed the specific benefit after failure on the CDK4/6 inhibitors. We have the PACE, we have the Palmyra, which had showed that if we, for example, change the CDK4/6 inhibitor, we might have some benefit, but there was no data, especially in the ESR1 mutation. We have the TRENT1 trial looking at the everolimus and exemestane and ribociclib in patients with ESR mutation who had previously received CDK4/6 inhibitors. And as you can see here on the right side of the slide, the patients with PFS with ESR mutation were 2.8 months versus 9.1 months, which showed that there is absolutely no benefit. The Capitello trial had looked for the capivasertib and the fulvestrant versus fulvestrant in the overall population and AKT pathway population. And as you can see, in the overall population, the hazard ratio was 0.6. In the AKT pathway, non-altered, it was non-significant, 0.79. So the significant was in the AKT pathway. So this is a summary of the second-line treatment. This is what the years have shown, that if we do not have a CDK4/6 inhibitor, we're talking about fulvestrant 4.8 months, everolimus 11 months. CDK4/6 inhibitor in the second line, we're talking, this was the maximum, it was 14 months. But once we put a prior CDK6 inhibitor, this benefit has reduced. Fulvestrant is 1.9 months, everolimus is 4 months. Another CDK4/6, we have a phase 2 trial for the maintain, which was 5.4 months. Alpelisib with the loss of toxicity for a specific mutation, PIK3CA, 8 months, and the capivasertib in the Capitello trial, 5.5 months. But don't forget that we don't have data for the ESR1 mutation. It's not approved. And that's why this is the unmet need. We need an oral SERD. Yes, why oral? Because we need improvement in the bioavailability. We need an improvement in the pharmacokinetics and reduce the burden of administration, trying to overcome or understand the underlying resistant mechanism. So what is the ESR1 mutation? ESR1 mutation, they are very rare in the primary tumors. As you can see, they are more frequently there in hormonal positive and after failure on aromatase inhibitors. It is not a truncal mutation. There's 0% to find it upfront, but it is an acquired mutation. So this is the consensus behind that the wild type estrogen receptor is bound by the estrogen ligand, leading to a ligand-dependent activation. So if we have the mutation after the ligand-dependent domain of the estrogen receptor, it becomes independent, and this will cause the proliferation and the growth and the metastasis of the cells. So does it differ the type of the hormone receptor? We have the SOPHIA trial, which had looked at the ESR1 mutation in the breast cancer and found that the progression-free survival in patients who are ESR1 mutant or who are SCR1 wild, and looked at the exemestane and the fulvestrant. And you can see here on the first part of the slide, the ESR1 mutation, and you can see that there is a progression-free survival with the addition of the fulvestrant, 5 months in comparison to the exemestane. But once they are wild, the curves overlap. So how can we find out the ESR1 mutation in the breast cancer? So the ctDNA has become the gold standard to find out or to assess the ESR1 mutation status. It can be an NGS or a PCR. Of course, we know that the PCR is easy and less financial toxicity, but actually the NGS, it is, I think, the standard in all of our clinic because it reduces the based position error rate and enables the analysis of another several genes. Yet, it's, of course, it's high cost, but if it's better, of course, if we can do a ctDNA instead of a specific PCR. So here, what do we need to do for SERDs? Are they affected in ESR1 mutation? Are they effective after the standard of care, which has been established for the last more than 5 to 6 years, which is CDK4/6 inhibitors in the first line? Does it have a tolerable safety profile? If we are able to get the 3, or hopefully the 3, then we mean that this drug is effective. So lots of trials have been there. Lots of them, as you can see on this side, have been negative. One is ongoing, one is positive and on registration. Let us agree there is only one data which came back as positive and registration, and this is the Emerald trial. So the Emerald trial is a randomized open-label phase 3 trial for postmenopausal women and men with hormone receptor positive, HER2 negative, advanced or metastatic breast cancer. These patients in the trial were actually heavily pretreated. They had at least 1 to 2 lines of prior hormonal therapy. They have been documented progressive disease on the standard of care, and this is the most important part of the trial, that they had all of them 100% CDK4/6 inhibitors. There were patients who had received a prior line for metastatic breast cancer, and this patient, the classification was ESR1 mutation by ctDNA and the presence of visceral disease, randomized to either elacestrant 400 milligram or any investigator choice for hormonal therapy, which was supposedly to be another monotherapy. So if you look here at the baseline demographics, the median age was 63. Patients were 100% female, and if we look at the visceral disease, we found that 70% of the patients, they had visceral metastasis. 62% have one prior line of endocrine therapy. 40% have 2 lines of prior endocrine therapy. 100% of the patients had a prior CDK4/6 inhibitors, which is the standard of care. How was it effective? Was it effective or no? So this is the progression-free survival in the patients who were ESR1 mutation. It was associated, elacestrant was associated with 45% reduction in the risk of progression or death in patients harboring the ESR1 mutation. We have a hazard ratio of 0.5. So are they effective after CDK4/6 inhibitors? We can see here that the patients who stayed on a longer duration of CDK4/6 inhibitors, more than 12 months, they have a clinically meaningful improvement in progression-free survival for elacestrant versus the treatment physician choice. And we have a hazard ratio here, which was quite significant, 0.4. We have a subgroup analysis of the median progression-free survival in patients who were less than 12 months, more than 12 months, and more than 18 months. And we found here that there was a significant improvement for the progression-free survival primary endpoint for the elacestrant in patients who stayed more than 1 year on CDK4/6 inhibitor. These are the subgroup analysis, more than 12 months. Not only we're going to go specifically, for example, patients who had bone metastasis, patients who had liver or lung metastasis, in the presence of an ESR mutation, whether they were HER2 low expression or HER2 zero expression, all of them benefited with a significant hazard ratio ranging between 0.3 and 0.5. So honestly, regardless the type of ESR1 mutation, we have multiple types. All the ESR1 mutation and all the subgroup analysis, whether liver metastasis, bone metastasis, specific type of mutation. Even if you look from 1, 2, 3 from down, the patients who had the PIK3EC mutation and ESR1 mutation, there was a benefit from adding the elacestrant with a hazard ratio of 0.4. So what about the toxicity? Because this is very important in hormone receptor positive HER2 negative. How about the safety profile? So let us summarize what was there. So the importance of delivering a personalized care, that we need first-line endocrine therapy and CDK4/6 inhibitor. We have to have a second line which is effective and should be a biomarker-driven, and this biomarker-driven should have like the least toxicity. So this led to the approval of the elacestrant in the second-line setting, hormone receptor positive HER2 negative, ESR1 mutation, and this ESR1 mutation is being an NGS testing or a PCR, maybe tumor tissue or blood. With this, I would like to thank you.
Thank you very much, Dr. Dina, for excellent presentation. We have time for a few questions. Maybe I can start with a question with regards to, obviously, for patients with breast cancer who have progressed on CDK4, very important to have the molecular profiling. So what is your experience with regards to doing this, and when you should do it, and just tell us overall, how often would you do it? Only once, or would you do it at each progression? What is your experience? Thank you.
Thank you, Dr. Hamad, for the nice question. Actually, there was a slide by Javier Cortez. He mentioned this, I think this was on last San Antonio. And his point of view, whether if we do a ctDNA, maybe the timing is not correct if the patient is not progressing that much. But when we do a ctDNA and it comes back negative, he mentioned a very nice statement. He said, maybe there is no mutation, or maybe there is no ctDNA. So that's why if we look at the rate of the development of ESR1 mutation, you found out that at baseline it's almost 0 to 1% when the patient did not receive any hormonal therapy. And this percentage increases, especially after exposure to aromatase inhibitors and with a longer time. So since the test, I know that the test in the UAE is being covered by pharmaceutical company, but not one size fits all. We have to put our lines and our boundaries. So whenever we are sure that the patient has progressed, we should do the testing to assess which type of resistance is there and what is the mechanism behind that resistance. And yes, it is being recommended that after each progression, we can do the test, because in the first time, ctDNA might not be there, or the mutation itself might not be shown. So honestly, in our clinic, we have lots of patients whom, once there is a progression, especially on a longer period of aromatase inhibitor, we do the NGS testing. And I think it has been quite effective timing-wise and results-wise.
Thank you very much. Anybody has a question? Let me ask if, I think everybody asked this question with the co-mutation, if you have the AKD pathway and ESR, both available with you, how would you make a decision with regards to, would you sequence, would you choose one over the other?
Okay, first of all, the Emerald trial, they have the data for the double mutation, and as we can see that they have the PIK3CA mutation, and it was assessed, and in the Emerald trial, it was positive. We don't have a specific trial to say sequencing or a specific trial for both mutations to be there, but the data and the idea of understanding the pathology or the biology of the mutations is important. So we know quite well that the ESR1 mutation is an acquired mutation, which means that it doesn't come from the beginning. It comes due to usage of aromatase inhibitor. And the longer the usage, the longer the response, the longer the possibility that this might be the cause for further resistance. So when a patient comes, for example, and let us say that the patient received aromatase inhibitor, 6-7 months later we do an assessment and the patient is progressing, even if you find an ESR1 mutation and another mutation, I don't think the ESR1 is the responsible to that, because the patient originally did not respond. But the longer the patient responds, and for example, a patient who had a CR, widespread bone metastasis, liver metastasis, we have 70% who had visceral metastasis in the trial, and they responded for years and years, and we have lots of patients like this who started on the CDK for 4-5 years ago, and now they are having a mutation. I believe that this is the responsible for the mechanism of resistance right now, and not the truncal mutation.
Thank you very much, Dr. Tina, for excellent presentation. I think we'll move on to the next session. Probably not take a break because we're already an hour late. So let me, only an hour late. Let me welcome Prof. Matthew Fassan. He'll be talking about biomarkers in gastric cancer. Dr. Prof. Matthew Fassan. I'm not sure if he's here physically or is it virtual, is it? It's virtual, okay.
So sorry for the delay.
Yes.
Sometimes happen with the distance. So I was talking about due to the new biomarkers, no? The new setting. This is the Pan-Asian adapted ESMO clinical practice guidelines, but the ESMO guidelines are the same, in which you see at diagnosis we have to test HER2, PD-L1, MSI, and Claudin 18.2 were available, of course. And Claudin 18.2 is a part of this family of tight junction proteins, which are, in this case, positive in normal gastric mucosa. In fact, Claudin 18 has two isoforms. One is Claudin 18.2, which is usually expressed in normal gastric mucosa, and Claudin 18.1, which is usually expressed in lung parenchyma. Just to give you some examples of the immunohistochemical expression of this protein in normal glands, you can see on the left some normal antler glands, which are strongly positive for this protein. Also some oxyntic glands, which are strongly positive for Claudin 18.2, and intestinal metaplasia, which can be positive or negative depending on the different type of intestinal metaplasia. In fact, if you want to set up the antibody in your laboratory, or a surgical pathology laboratory want to try to develop this kit in-house, you can use atrophic gastritis as a normal positive control. Why atrophic gastritis? Because you have the positive normal glands, which are usually a 3+ staining, the intestinal metaplastic epithelia, which can be negative but also positive. So you have some examples of both positive and negative controls, and of course the stroma is completely negative. What about the tight junction in normal cells and in cancer cells? We are targeting these proteins and we are not affecting normal cells because usually tight junction are hidden in the tight junction itself. So the targeting of Claudin 18.2 is dedicated only to cancer cells. And the most important point is to stress that the 38.4% of gastric and gastroesophageal junction adenocarcinomas are positive for this protein, with the definition of positivity, which is at least a 75% of tumor cells with a 2+ or 3+ expression. You see there are no differences between the different ethnicities. There is an association with a diffuse type gastric cancer. Claudin 18.2 is not a prognostic factor. This is an article of my group published a couple of years ago in which we tested more than 350 cases. You see there was an association with peritoneal involvement and also with the Epstein-Barr virus positive status. Several others group, this is the Japanese paper published last year in ESMO Open, also provide evidence that Claudin 18.2 is not a prognostic biomarker. Another important point is that there is a high concordance between primary tumor and metastatic tumor cells, which is around the 80% of the cases. You see that in the literature, we found a positivity in the 38% of primary sites and 39% of metastatic sites. When we have both tumor samples, the concordance is around the 85 to 90% of the cases. So as I told you before, a positive case is defined in the presence of at least 75% of tumor cells, 2+ or 3+. But of course, this is the today cutoff, and several different trials will provide some new information about this cutoff. What about the relationship with other biomarkers? You see, this is the overview of the current literature between Claudin 18.2 positive and Claudin 18.2 negative tumors. There is no significant differences between these two groups. So there is no difference in biomarkers association and Claudin 18.2 status. But we, of course, we are performing the testing of this biomarker by immunohistochemistry, and several factors can affect the evaluation of these biomarkers. The first one is the pre-analytical evaluation of the sample, and so we have to follow the ASCO-CAP, College of American Pathologists guidelines. Why? Because, of course, we have to have a cold ischemic time limited to 60 minutes. The sample should be fixed in 10% natural buffered formalin for 24 hours. The section should be at least of 3 or 5 microns at least, and the storage at room temperature, we can stain the slides for at least 45 days. This is very important because we can have false positive or false negative results if we don't have a good pre-analytical phase. As in this case, you see a non-specific cytoplasmic staining. What about the type of sampling? Because, of course, you know that in the 70% of locally advanced and metastatic gastric cancer, the only samples we have to test for molecular testing are the initial endoscopy biopsies. And you see that in biopsy specimen, we found a prevalence of a 38.6% of positivity, and the resection specimen, a similar prevalence of the 37.6%. However, we have a problem. Like for other gastric cancer biomarkers, also Claudin 18.2 can be characterized by a significant intratumor heterogeneity. You see that intratumor heterogeneity can characterize the 40% to 35% of gastroesophageal adenocarcinomas. So we have to need a 4 to 6 biopsies to have an adequate evaluation of this biomarker. This is an example in which you see 2 biopsies, one completely positive, one completely negative. Similar data than observed, for example, for HER2. You see that we can have a intertumor heterogeneity with this area of the tumor which is completely negative, but also we can have an intraglandular heterogeneity, like a barcode in which you see positive cells, but within also negative glands. What about the antibodies? Today we have an antibody which was used in the clinical setting, in the clinical trials, which is the Ventana 4348. But you see that in the market we can find several other antibodies. It has to be underlined that most of these antibodies are targeting both claudin 18.2 and 1 isoforms. So we have to be very careful when assessing lung metastasis, because lung is positive with these antibodies. You see these are the results of a ring trial confirming that most of the available antibodies can give reliable results and are easy to use in the clinical setting. And what about the number of cells to be scored? At least 50 cells, but I would suggest at least 100 cells, because we are talking about an expression of a biomarker. Some examples of small specimens like these micrometastases in the lymph node, but the most important specimens in this setting, the gastric cancer settings, are peritoneal metastases, in which you see in this example more or less 100 cells, which are 3+ positive for the protein. It's not so difficult to deal with this antibody, with this biomarker in gastric mucosa, because you see that this is a completely negative tumor, but they are entrapped positive normal glands. So I have a positive internal control. Another very simple case, a completely positive tubular adenocarcinoma, but also we have to stress that gastric and gastroesophageal dysplasia can be positive or negative for these biomarkers. So the biomarker assessment should not retain the positivity or negativity in these plastic areas. And of course, we have cases in which we have to consider the cutoff of the 75%. How to report claudin 18.2 in our clinical practice? Of course, the percentage of 2+, 3+ positive cells, and also the status according to the 75% cutoff. But I would like to stress the fact that we have also to put all the information for the qualification of the specimens we are dealing with, because this will be important if we have to take back the specimens for other molecular testing. We work with Astellas with this pathology hub experience, gastric pathology hub experience, which is a tool, a website, but is a tool done by pathologists, for pathologists. You see me, but also colleagues like Professor Rushoff, the father of HER2 in gastric cancer, and also the Bethesda panel for MSI, Kristen Rocken, Christina Matiakowski, and Takeshi Kubata. And also we put all this information in a recent paper published in Modern Pathology this year, this August. What about the second important biomarkers, which will be important the next few years in the gastric and gastroesophageal junction cancer setting? FGFR2b, which is a TKI characterize an aggressive cancer cells and is associated with the amplification of the FGFR2 gene. You see that in the gastric cancer setting, the prevalence of this alteration is the 9% of the tumor characterized by chromosomal instability, which are, according to the Tumor Cancer Genome Atlas, the 50% of our cases. Another important point is that there is a concordance between FGFR2b in the primary and in the metastatic setting, with some data that also demonstrated a higher expression in metastatic samples. How to test this new biomarker in our clinical practice? As for crowding 18.2 immunohistochemistry, and the cutoff in this case is 10% of a tumor characterized by 10% of moderate to strong immunoreaction in their tumor cells. Of course, I told you that FGFR2b expression is associated to the amplification of FGFR2, so we can also detect this alteration in liquid biopsy, but of course immunohistochemistry is available in most of the surgical pathology laboratories, so the biomarker will be tested by immunohistochemistry. What about the relationship with histotypes and clinical pathological variables? You see that there is a higher prevalence in proximal type adenocarcinomas and intestinal type tumors. But also here we have the same problems encountered for HER2, for PD-L1, for MMR, for Claudin 80.2, which is intertumor heterogeneity. You see some examples: primary tumor, half completely positive, half completely negative, and the metastasis is completely negative, not only by the immunohistochemical point of view, but also assessing the amplification of the FGFR2 gene. What about also in this case, the overlap with other biomarkers is homeopathic, is minimal, of course, with the exception of PD-L1, because if we put PD-L1 positivity with a CPS of 1, most of the tumors are positive for PD-L1. So the take-home messages of my presentation is that we are moving to a personalization of treatment in advanced gastric and gastroesophageal junction cancer setting. Of course, today we have to give to the oncologist a diagnosis of locally advanced and metastatic cancers, the evaluation of HER2, PD-L1, and MMR, but Claudin 80.2 and FGFR2b are promising emerging biomarkers that have to be tested in the next future. And another important point is intertumor heterogeneity, which is affecting all the predictive biomarkers in the gastroesophageal cancer setting, and we need to test at least 6 biopsies to have an adequate evaluation of this type of tumors. Thank you for your attention.
Do you have any questions for the FGFR? So thank you very much. We'll move to the symposium of AbbVie. So I'm really delighted to present my colleague and friend, Dr. Emad Anwar. He's a consultant medical oncology working in Tawam. He has a lot of interest in research and active member in the society. So he will present the data of platinum-resistant ovarian cancer. As you all know that whenever patient become platinum-resistant, it is really a challenge, and bevacizumab is being pushed for early stage. So we have a limited option. So he will tackle that setting.
Thank you, Dr. Hassan, for the lovely introduction. And again, thank you for being here today. Thanks for the organizing committee. So the question is, what comes after platinum resistance ovarian cancer? And this is a difficult question, actually. For many years, we don't have any options for this group of patients. So the disclosure didn't change. Disclaimer. This is the agenda of my talk. So we know that ovarian cancer, it's most common occurring cancer in women and considered the second highest cause of death from all gynecological malignancies. And we have almost more than 300,000 new cases in 2022, and almost 60% of them, they died because of the disease. Unfortunately, up to 80% of those patients, they presented with the advanced stage ovarian carcinoma stage 3 and stage 4, where 70% of those patients, they relapsed within 3 years. And when they relapse, the 5-year survival is around 30%. So really, there is unmet needs for those patients. Ovarian cancer is a disease of relapse, and relapse is inevitable. Once the patient relapsed, the PFS becomes shorter and shorter with the treatment lines. So platinum-resistant ovarian cancer, it's one of the challenging situations in our clinics where we don't have much options. Objective response rate with the current available chemotherapy around 10%, with the median progression-free survival around 4%. There are many trials try to address new options for this patient. Since Aurelia trial in 2011, by adding bevacizumab to the chemotherapy, we don't have any new options. There are some trials try to improve the outcome for those patients, and only very, very few that succeed to show a positive outcome. But the reality, when we move from one line to another, the median progression-free survival and median overall survival becomes very short. So this is addressing the unmet needs for those group of patients. This is an example for some of the trials in platinum-resistant ovarian cancer. Unfortunately, all failed to show any improvement in outcomes. If you're looking for the NCC guidelines for our patients, so probably a single-agent chemotherapy plus or minus bevacizumab is the current standard of care for many years. Until recently, the mirvetuximab has been approved, and now it's in NCC guidelines. The same for the ESMO guidelines, platinum-based chemotherapy for platinum-sensitive. Once becomes platinum-resistant, non-platinum chemotherapy plus or minus bevacizumab is the standard of care. So antibody drug conjugate now, it's approved in many of the treatment, in many of the diseases, and it's showing a positive outcome. What about the ovarian cancer? And currently, the non-platinum chemotherapy is the standard of care, as I mentioned, since Aurelia trial, by adding bevacizumab to the chemotherapy, that's almost 14 years ago, which showed overall survival benefit. We are lacking any effective treatment. So there is actually unmet needs. So as we know that antibody drug conjugate, we need a monoclonal antibody to target a receptor on the tumor cells itself and to deliver a very toxic chemotherapy inside the tumor cells to induce cell lysis. This is a group of the trials try to address the efficacy of antibody drug conjugate in the platinum-resistant ovarian cancer. Apart from the trastuzumab deruxtecan in HER2 positive tumors from the basket trial as a pan-tumor approval, we have many trials failed. Probably Soraya trial and Marisol trial, they show a significant improvement in overall survival and progression-free survival, as well as response rate. So here I'm sharing with you the phase 3 trial, Marisol trial, which is a study of mirvetuximab versus investigator choice for platinum-resistant advanced high-grade epithelial ovarian carcinoma, as well as primary peritoneal and fallopian tube cancers for patients with high folate receptor alpha expression. So the background, as I mentioned, there is unmet needs, and folate receptor alpha, it's highly expressed in ovarian cancer in 90%. For platinum-resistant ovarian cancer, up to 40% of the patients, they have high expression, and high expression means 75% of the tumor cells express the folate receptor alpha in this group of patients. So we have data from the Soraya trial. It was phase 3, but single-arm trial, showing response rate 32% and median duration of response of 7 months. So there is a positive signals from this trial. Now we am presenting the Marisol trial, which is an open-label phase 3 randomized trial. As I mentioned, mirvetuximab versus investigator choice for patients with ovarian cancer platinum resistance. So the patients randomized to mirvetuximab 6 milligram per kilogram every 3 weeks versus investigator choice. It could be paclitaxel, liposomal doxorubicin, or topotecan. And the primary endpoint, progression-free survival by investigator assessment. We have objective response rate, overall survival, patient-reported outcome as a secondary endpoint. This is a baseline patient characteristics. It's well balanced between the two treatment groups. So almost 60% of the patients, they have prior bevacizumab, PARP inhibitor in 55%, and taxanes has been given for almost 100% of these patients. Platinum-free interval, majority of the patients, 2/3, they have less than 12 months, and platinum-free interval, primary platinum-free interval, but platinum-free interval at time of progression, we have 2/3 of the patient, they progress between 3 months and 6 months. And this is what we call platinum resistance. But also they include platinum refractory, which is progression within 3 months from the last platinum. So here, the primary endpoint, you can see the control arm, the median progression-free survival less than 4 months. And this is what we are seeing in our clinical practice. And mirvetuximab, we have almost 5.62. So we are close to 2-month gain in the median progression-free survival in favor of mirvetuximab. 0.65 is a hazard ratio with very significant p-value of 0.0001. That means we have 35% risk reduction in progression or death in favor of mirvetuximab. What about the blinded independent review, since the trial was already open label? It's confirming what we see in the investigator assessment. Again, we have 5.9-month median progression-free survival versus 4.3 months with a hazard ratio of 0.72, a very significant p-value. And the most important, that the response rate, which is never seen before, 42% response rate in patients with platinum-resistant ovarian cancer. I never see it before. Look for the control arm, 16% only. 5% achieve complete response, which is quite significant for those patients. Majority of those patients are actually symptomatic from the disease. We need something give high response and deep response. Overall survival, the trial is positive also for overall survival, and we can see that by giving mirvetuximab, we extend the survival by 6 months, by 4 months. 16-month median overall survival for mirvetuximab and 12 months for the investigator choice. Very significant hazard ratio of 0.67, which means we have 33% risk reduction of death in favor of mirvetuximab. As a bonus, this drug is very well tolerated. The grade 3 and 4 toxicity is much lower in mirvetuximab compared to the chemotherapy. Severe adverse events, it was even better in mirvetuximab. Dose modification, even less in mirvetuximab compared, or discontinuation compared to the investigator choice. So if you're looking for the toxicity, when it comes to the hematological toxicity, it's much better than the chemotherapy. When it comes to neutropenia, anemia, thrombocytopenia. When it comes to the peripheral neuropathy and alopecia, it's much better than the standard of care. And even the gastroenterology toxicity also, it's favorable compared to other toxicities. Most of the toxicities are grade 1 and grade 2. But what is a unique toxicity for mirvetuximab is ocular toxicity, with a blurred vision, keratopathy, or dry eye, which is reported in this trial, and grade 3 and 4, less than 10%, 7 to 8% only. So what to do with this ocular toxicity? You can use natural tears for these patients to avoid contact lens, to wearing sunglasses, and refer to ophthalmologists as early as possible for intervention. So the conclusion, mirvetuximab is the first novel treatment to demonstrate a benefit in overall survival in platinum-resistant ovarian cancer in a phase 3 trial. Mirvetuximab demonstrates statistically significant and clinically meaningful improvement in PFS, overall response rate, and overall survival, compared to the standard current chemotherapy. And mirvetuximab is the first antibody-drug conjugate for ovarian cancer with proven efficacy, and is the only FDA-approved biomarker-driven therapy for platinum-resistant ovarian cancer. Ocular adverse events occurred in almost 50% of these patients, but only less than 1% discontinued treatment because of the toxicity, and 20% required dose modification. So I think it's a very well-tolerated drug. With that, I will thank you for listening.
Thank you very much, Dr. Emad, for this nice overview. If you have any questions. I have a question for you. So do you think this alpha-1 receptors is a dynamic or it is static? So you can do, if the patient become platinum resistant, you can take the original tissue and check for the folate receptor. Yeah,
you can use the archival tissue from before. Actually, in our practice, we are not rebiopsying when the patient relapses. So this is as a practice. But the good thing is that you can use the archival tissue from the beginning, and it's not acquired. So if you have from before.
Very nice. I guess, I don't know if the drug is available here or not, but
soon, inshallah, will be
can you comment, there's further, soon, he said. It is, okay. Can you comment on, after this trial, we have more data on combination therapy, which even more effective than this. Oncologists are greedy. If something is good, maybe we should combine it with something else. And can you comment on the intermediate folate receptor? Obviously, this was a high folate receptor, but there is further data with the company about I don't know if you have access to it, for the lower folate receptor.
The good thing that the field is dynamic. We have more treatment options, just we are opening the door. But currently, this is the only approved available drug. In my center, we're trying to get it soon. And I think in private, they might get an access faster than us. But you have everything, mashallah. In the public sector, it takes some time.
I think they approved only in the strong expressor, which is more than 75.
Yes, you have to have folate receptor alpha expression in 75 with 2+ intensity. Yeah, this is, you have to
the
test.
The average is 2+, so 75.
Yeah. This is.
So I think if we don't have a question, also for the sake of time, so we'll move to the next session.
Thank you.
I don't know who's chairing the next session. So I'm really, I'm honored to present my colleague and friend, Dr. Aida Al-Awadi, who's a consultant now, moved to Sheikh Shakhbout Hospital. She's the head of department in oncology, so she will present Bristol Myers Squibb, novel approach of dual immuno-oncology for the management of HCC.
Thank you so much for your kind introduction. I think this is going to be the last lecture, so bear with me. I promise it's going to be very quick, and then you can enjoy the rest of the day. So we're going to discuss on the novel approaches of dual immunotherapy for the management of hepatocellular carcinoma. Now we have a plethora of options, but I think immunotherapy has proven to be effective in hepatocellular carcinoma, for which now this is the standard first-line option. But now also we have different options that we need to choose from. So I hope that this lecture will help you to sort of identify what's the best option for your patient in the first-line setting. HCC, it's a heavy disease burden usually. The survival rates are extremely low, with the common cause of death are tumor progression and complication from cirrhosis. In early and intermediate BCLC stages, non-tumor related death has been demonstrated to be frequent as tumor related death. And following resection, about half of the patients with HCC will relapse, and the median time to relapse is less than 3 years. So here is the first study that looked into combination of immunotherapy and hepatocellular carcinoma in the first-line setting. It's a Checkmate 9DW, which looked into nivolumab plus ipilimumab versus lenvatinib or sorafenib as a first-line treatment of unresectable HCC. We know that TKI, such as lenvatinib or sorafenib, had remained the first-line standard of care for unresectable hepatocellular carcinoma for many decades, with median overall survival of about 12 months and unsatisfactory safety outcome, high toxicity profile. But despite improved outcome with PD-L1 inhibitor-based regimen, prognosis remains poor, and there is continued unmet need for alternative therapies with long-term survival option. So in the Checkmate 040, the combination of immunotherapy demonstrated clinically meaningful efficacy and manageable safety in patients with advanced HCC, previously treated with sorafenib, leading to the accelerated approval in the United States and this population, but then also many countries across the globe. So the Checkmate 9DW is a randomized global phase 3 trial evaluating the efficacy and safety of nivolumab plus ipilimumab versus lenvatinib or sorafenib in the first-line setting. So here is the study schema. Again, they enrolled patients with unresectable HCC, systemic therapy naive, child Pew score of A5 or 6, no median portal vein invasion. They randomized the patient to receive nivolumab at 1 milligram per kg IV plus ipilimumab at 3 milligram per kg IV every 3 weeks for 4 cycles, and then continue at maintenance nivolumab at 480 milligram every 4 weeks for as long as it works, and versus investigator's choice of TKI, which could be lenvatinib or sorafenib. And it's worth to mention that this is very unique because it's one of the, it's the first actually immunotherapy trial in hepatocellular carcinoma where it was compared to lenvatinib as well as sorafenib as opposed to sorafenib only. So they looked into overall survival and other survival endpoints as well. So if you looked into the baseline characteristics, very well balanced between both arms, median age at mid-60s, predominantly male. The etiology of HCV was mostly HPV related or uninfected HCC. Most of the patients had child 5 and BCLC stage C, and majority of the patient actually had extrahepatic spread, and about half of the patients received local regional therapies prior to systemic therapy. So in terms of the overall survival, there is a statistically significant and clinically meaningful overall survival benefit in the combination versus lenvatinib or sorafenib. So the longer median overall survival and long-term survival benefit was with higher OS rate at 24 and 36 months. So the median OS was about 23.7 months versus 20 months with a hazard ratio of 0.79 and a significant p-value. You can see the separation of the curve at around 18 months, but then it seems that those who actually responded, there is very long-term control rate and outcome and survival. So you can see with time there are patients who are still alive after receiving the medication, which can indicate that some of them may be also cured with this combination. In terms of overall survival subgroup analysis, it all favors the combination immunotherapy, regardless of the age, sex, region, ECOG status, etiology, whether there is systemic spread or not, and also baseline AFP and BCLC staging. And in terms of response duration of therapy, again, it favors a combination. You can see clear separation of the curve with median duration of response of 30 months versus 12 months. So that's even double, almost more than double the number. With impressive durable response seen in the immunotherapy combination. Complete response happened in 7% of the patient versus 2% in the TKI arm. Partial response, again, almost 30% versus 11% in the lenvatinib plus sorafenib arm. So this established that the response is there and the response is higher, but then also it is durable and can be very durable. In terms of progression-free survival, again, we can see the separation of the curve, and which is maintained with longer follow-ups, and with the median PFS of 9 months versus 9 months as well for the lenvasorafenib group, with a hazard ratio of 0.87. Indicating improvement in PFS for the combination immunotherapy trial. Now, if you look into the toxicity profile, you can clearly see that the TKI arm seems to be more toxic in terms of side effects, hypertension, diarrhea, and etc. But then there are definitely some immune-related side effect that goes with the immunotherapy, but most of the time it's well manageable and self-limiting. And if you look into the table, any side effect happen in 84% of the patient, the combination arm, versus 91% in the TKI arm. So that established that the toxicity profile is very similar to the safety data that we already know about. And in terms of the mean change in the FACT HIP total score, which takes into account the patient's emotional, physical, social and well-being overall, you can see that patients treated with nivolumab plus ipilimumab had a descriptive improvement in health-related quality of life after week 29, and patients treated with lenvatinib or sorafenib had a clinically meaningful decline at several time points. So to summarize, these results support the combination IO as a potential new first line standard of care for patients with unresectable hepatocellular carcinoma. The safety profile is very consistent with the established safety profile of the regimen, and we've seen overall survival improvement across clinically relevant subgroups as well as progression-free survival as well. So this takes us to the next standard of care in the first line setting, which is also atezolizumab plus bevacizumab, and it was approved based on this study, the EMBRAVE 150, which included patients, again, similar to the CheckMate study, locally advanced child A, and those with no prior therapy. They randomized the patient to 2-to-1 fashion to atezolizumab plus bev or sorafenib. So again, very well balanced between both arms in terms of the baseline characteristics. And you can see the separation of the curve, which favors the combination with a median overall survival of 19.2 months versus 13.4 months, with a hazard ratio of 0.6 and a significant p-value. Again, the same thing we observe for the progression-free survival. In terms of the duration of response, again, you can see it's longer in the combination arm, but then also more patients would likely achieve complete remission or partial remission in the combination arm. And again, the safety summary is very well consistent with the regimen itself. So you can see that all grade toxicity was sort of high in both arms, maybe slightly higher in the atezo plus bev arm than the sorafenib, but overall, rarely patients had discontinued therapy due to side effect. And this takes us to the Himalaya trial, another combination immunotherapy trial where they randomized patients with similar characteristic to the STRIDE protocol, which is tremelimumab at one dose plus durvalumab every 4 weeks versus durvalumab versus sorafenib. And this is really meant to compare the STRIDE protocol versus sorafenib or the durvalumab plus sorafenib, but it did not, was not powered to or not meant to compare the STRIDE versus durvalumab as a single agent. So in terms of the baseline characteristics, again, very well balanced between these arms. And again, you can see when comparing the STRIDE protocol, durvalumab, both did way better than the sorafenib as a single agent, with a median overall survival of 16.4 months for the STRIDE, 16.5 for the durvalumab, and then 13.7 for the sorafenib. And in terms of PFS, similar phenomena that we observe. Again, most of the subgroups favor the STRIDE protocol. And in terms of tumor responses, again, very similar to what we've seen in the immunotherapy trials in general. The complete response happens to be more frequent in the STRIDE protocol as opposed to durvalumab as a single agent or even sorafenib as a single agent. A stable disease, sort of very similar between arms, and then the partial response is higher in the combination arm than the other two arms. Again, safety profile, again, very well tolerated in general, the combination, and it's very similar to the safety profile expected and compared to the other immunotherapy trials. So with that, I end my presentation, and thank you so much. I would love to take any of your questions. only one question for the sake of time. Which?
Okay, so very nice. I mean, it's obviously good to have options. The question is simple. So we have Epi-Nivo now. We already have Durva-Tremi, and we have already the Bev-Atezo. It looks to me the single agent TKI appears to even improve. I don't know if it's just better care for these patients because we're hitting 20 months. Remember, the pivotal trial was 10 months with sorafenib, and it was around 11.5 or 12 months with lenvatinib. So obviously, it's improving even with time. That was a decade ago. So my question, here we gave 4 doses of high-dose ipilimumab. And the Himalaya, if you talk to my friend Ghassan Abu Alfa, he really thinks that 1 high dose of anti-CTLA-4 may be enough to prime the cells, and that's why the Himalaya trial was built on that. So what do you think of this? Because obviously it's much lower toxicity than the high-dose epi for 4 doses. We're already using Himalaya, so where would you use either of these regimen in lieu of bevacizumab arm?
Absolutely. Thank you so much, actually, for this question. Actually, I don't have the answer. I mean, we have all of these like plethora of options right now with different tumor types. But I agree and agree with you that it seems that using the CTL4 at 1 dose may be more feasible. But then again, we cannot compare it to the 4 doses of IPI. We don't know, we don't know whether 4 doses is equivalent to the 1 or not. So I would not extrapolate it this way. But for me, it depends on the accessibility of the medication, what I'm comfortable giving the patient, and what the eligibility criteria of the patient. Of course, like somebody with varices or somebody with high risk of bleeding, I will try to stay away from the, VEGF agents. But I agree with you. The variation makes maybe one more intriguing than the other. But by the end of the day, it comes down to the accessibility of the medication, the cost, the safety profile, and etc. But I'm not sure 1 dose of Trema is easier than 4 doses of EPI. If you look, of course, we can compare across trial, but we've seen similar toxicities between both of them.
Cross-trial, of course.
And honestly speaking, I do have patients, different tumor types. I haven't used the combination IPI and Nivo for hepatocellular carcinoma yet, but I know that in different tumor types, like 2 patients with melanoma I treated, I ended up giving one of them 1 dose and the other one 2 doses. They were unable to tolerate because of severe toxicity. Like one of them got severe hyperthyrotoxicosis where we had to admit him to the ICU actually. But those 2 patients actually did very well. So this, I believe that maybe less CTL4 may actually work for these patients, but then this is how the trial was designed and this is what we have to follow.
What about the initial, you show the 2 curves,
Yes.
There is a crossover at 18 months. So is there room, we always think, should we add a combination? I know there was one lenvatinib pembro that unfortunately didn't get the approval. But what do you think of the strategy of adding something to this immuno-only regimen to minimize that initial year of drop-off versus lenvatinib or sorafenib?
I mean, if you looked into the EMBRAVE one, the Atezo and the Atezo plus Bev, maybe we don't see this phenomena as much as with the combination. Absolutely true. Maybe it's something that BMS has to look into in the future. I agree with you. But one of the comments from the investigator that the initial drop maybe was because of COVID, because this was at the time when actually they were doing the study, when a lot of patients actually died from COVID infection. But I agree with you. But what it's intriguing is that those patients actually responded to immunotherapy. They will do very well for a long time. So that's what makes a combination attractive for us to use in the clinic.
Seen the same in RCC, same thing if you use Epi-Nivo.
Melanoma.
You don't get the highest response in the beginning, but afterwards, if you respond, you do
So those
very well.
lucky ones who respond, you see that they would continue to live for a long time, as opposed to the other TKI agents where the response may not be long-lived.
I rest my case.
Okay. Any questions? I think very interesting data, just like, well, the debate will continue which will be the best option to use, but by the end of the day, having more options is better for our patients. Okay, thank you so much. I think we'll end up. Nothing, I think this is the last talk for today. So it was my pleasure to give the last talk of the day, and I think maybe Dr. Hamid would like to give. Okay, so he wants to keep it for me. Thank you so much for attending. I think tomorrow, please be promptly here, because I promise you there's an exciting scientific program. Thank you so much.